morning. Thank you for joining this early morning industrial breakfast symposium. My name is Kwang-il Kim. I'm from Seoul National University. I'm very happy to chair these sessions. Today, we invited a very famous, distinguished Professor Manolis from Greece, and I will introduce it briefly. Professor Manolis is currently the Director of Cardiology at the Department of Metropolitan Hospital in Greece, and he is the past president of the Working Group of Hypertension and Heart of the ESC, and he published more than 300 papers in international journal and more than 3 chapters in international books. Today, the title of his talk is Contrasting Hypertension Guideline in Korea and Europe. Professor Manolis, would you please start?
Good morning. I'm really happy and honored to be back again at the special for this anniversary of the Korean Society of Hypertension. I have been many times in your beautiful country, also some lectures, tour lectures around the country. And we have a long-standing collaboration from the war during 50s, because my grandfather was one of the soldiers that came from Greece at that time to Korea for this war. Anyway, today I'm going to discuss with you the role of the different guidelines. And as you can see, last year we published the European Society of Hypertension guidelines. Later on, if you would like, we can discuss why we have only European Society of Hypertension guidelines and not the joint guidelines with European Society of Cardiology. And also this year we published let's say, the practice guidelines. And also, as I have seen, in 2022, they published the Korean Hypertension Society guidelines for the management of hypertension. You have seen the slides from the practice guidelines that the first step is the master. It's to measure the blood pressure and having the diagnosis, to assess the patients and risk stratification, to select the appropriate therapy, and then to evaluate the response. Concerning the blood pressure measurement, you know that we have the office and out of office. We have blood pressure monitoring and ambulatory blood pressure monitoring, and still the gold standard is the office blood pressure. And even if you will see the Korean guidelines for blood pressure measurements, I don't think so that there are some major differences in this field. The assessment of the patient is very important. It's very important to know the risk factors, the presence of subclinical, such as left ventricular hypertrophy, microalbuminuria, increase of intima media thickness, or target organ damage, because based on this, we have the risk stratification. And as you have seen, for the same blood pressure, as you can see here, let's say high normal blood pressure, one person, according to risk factor, subclinical or clinical organ damage, for the same level of blood pressure, could be low risk to very high risk. And the approach will be different and the target will be different. No differences from the Korean guidelines. Here you have the pre-hypertension, hypertension stage 1 or stage 2, and here you have the different risk factors, but plus minus, there are no major differences between the Korean and the European guidelines. If you will see the definition of hypertension, you can see that for office it's more than 140/90, for home more than 135/85, and for ambulatory blood pressure monitoring more than 130/80. Similar data we have also for Korean guidelines. There is no difference also in this field. Surprisingly, this year we had also the European Society of Cardiology guidelines, and now they have a new term calling this pressure elevated blood pressure. How it's possible in a person with 122 millimeter of mercury to say that your blood pressure is high. He couldn't believe it. And then, if it's correct, why you propose to reduce the blood pressure down between 120 and 130? So, if your target is 120, 130, this person has elevated blood pressure. How you can combine both of them? It's an absolutely mistake. Moving now to the office blood pressure and the targets, you can see that the targets from European Society of Hypertension should be between 120, 140 for systolic blood pressure, 70 to 80 for diastolic blood pressure, because we believe that J-curve exists, and especially J-curve exists in those patients with coronary artery disease mainly. And as you can see also from the Korean guidelines, there are no major differences in this field. Last year, we met with some colleagues from different countries from Asia Pacific, and we published this paper a few months ago, East Midwest, bringing the European Society of Hypertension guidelines into Asia. And you can see also your colleague from Korea, which was part of this meeting and this paper. And here you can see from different countries the treatment threshold for uncomplicated hypertension. And here you can see that Korea is in accordance with the European Society of Hypertension. There are some minor differences for Malaysia, Singapore, and Thailand. Again, if you will see the blood pressure targets, again, Korea is in the same area with European Society of Hypertension, some minor changes for Thailand, Vietnam, Hong Kong, Malaysia, Philippines, and Singapore. Let's move now how to start the treatment of blood pressure. As you can see here from European Society of Hypertension guidelines, if you have grade 1 or grade 2 hypertension in an asymptomatic person without hypertension, mediated organ damage or target organ damage, at least you need to measure at least one more time the blood pressure within 4 weeks, and this is important for the final diagnosis of blood pressure. If the blood pressure is less than 150 over 95, you have to start treatment if the blood pressure is not controlled with lifestyle changes. However, if the blood pressure is higher than 150 over 95, you have to start immediately the drug treatment. On the other hand, no matter if you have grade 1, grade 2, or grade 3 hypertension in a symptomatic person with hypertension-mediated organ damage or chronic kidney disease, stage 3, or cardiovascular disease, you have to start immediately with lifestyle changes and drug treatment. For the Korean guidelines, they propose that if you have hypertension without complication, lifestyle changes with or without antihypertensive treatment, and if the blood pressure is less than 149, 90, it's okay, but if the person is high risk, then the blood pressure should go in less than 130 over 80. If you have a person with complications, you have to start immediately with lifestyle changes and drug treatment, and we will discuss later. And according to target organ damage, your target should be less than 140 over 90 or less than 130 over 80. Actually, as you can see, there are no so important differences between the guidelines. In the European Society of Hypertension guidelines, we propose to start with dual combination, with a RAS blocker, with a calcium channel blocker, or RAS blocker with a diuretic. Why? Because a large number of patients have uncontrolled blood pressure worldwide, and we believe by starting with a combination treatment, and mainly fixed dose combination treatment, you will be able to control the blood pressure much better. The next step, if the blood pressure is uncontrolled, you have to combine the 3 classes of drugs. I don't believe that you will be able to control 90% by using the triple combination, should be around 70-75. According to the new guidelines, there was an upgrade of beta blockers in comparison with the previous one, because now we propose that beta blockers can be used as monotherapy or at any step of combination therapy. When to start with monotherapy? You can start with monotherapy if you have a person, low-risk person, with a blood pressure less than 150/95, or if you have a high normal blood pressure and very high cardiovascular risk, or if you have a frail elderly patient. And in case that still the blood pressure after the triple treatment in the higher tolerated doses, then you can say that this person has resistant hypertension. What about Asia-Pacific area? As you can see, here you can see from Hong Kong, Indonesia, but in Korea, they propose that for patients without complication, RAS blockers, beta blockers, CCBs, or diuretics may be used, and for patients with complication, once again, the 5 classes of drugs may be given depending on the guidelines for the specific complication. What about European Society of Cardiology guidelines? There is a clear copy of European Society of Hypertension guidelines with one exception. The text is exactly the same without having beta blockers in this field. We will discuss later on where is the evidence for a beta blocker. So just an advice, when to select the combination of a calcium channel blocker with a RAS blocker or a RAS blocker with a diuretic. If you have a high or very high risk person, yes, consider as initial treatment a RAS blocker with a calcium channel blocker or a RAS blocker with a diuretic in case that there is unacceptable edema, hypervolemia, or advanced nephropathy. If it's a low risk, consider both RAS blocker with a calcium channel blocker or RAS blocker with a diuretic. However, you have to have in mind that RAS blocker with calcium channel blocker, it's the priority if you have metabolic abnormalities or hypokalemia prone. Let's move now to the upgrade for the beta blockers. Why there was so much discussion for using beta blockers either as monotherapy or in combination therapy? In the European guidelines, it is recommended that European Society of Cardiology guidelines, beta blockers are only for combination. And this combination is only for the high-risk patients, for those having angina, post-MI, heart failure with reduced ejection fraction, or heart rate control. Because they said that beta blockers are not effective as antihypertensive drugs. What about Asia-Pacific? In Asia-Pacific, in accordance with the European Society of Hypertension, is Malaysia proposing first-line treatment, Taiwan and Thailand, and as you can see in Korea, they propose to use first-line treatment beta blockers only, not only, but mainly in those with comorbidities. However, in the European guidelines, we propose that all major classes of drugs, including large blockers, beta blockers, CCBs, and thiazide-type diuretics, have effectively reduced blood pressure and cardiovascular events in randomized controlled trials. These drugs and their combinations are recommended as the basis of antihypertensive treatment strategies. That's why we propose that beta blockers can be used either as monotherapy or at any step of combination therapy. Why? Because first of all, we recognize that a heart rate more than 80 beats per minute is a risk factor for cardiovascular events. And very often we have young people with high heart rate and we want to control the heart rate. This is a paper published recently for my group and my colleagues. You will be surprised. It's close to 500,000 hypertensive patients, follow up 10 years, more than 100,000 deaths. And as you can see from the entire cohort, the higher the heart rate, talking either the whole cohort, younger than 60, 60 to 69, more than 70 years, the higher the heart rate, the higher the cardiovascular risk. The large number, it's mainly because it's from the veterans hospitals in United States. There is not this number in Greece. So, we know also that if you will see the data from hypertensive patients, more than 30% of our patients have more than 80 beats per minute. And according to the European Society of Hypertension guidelines, there are other 19 conditions that you may be used beta blockers in the field of hypertension. However, which beta blocker? Not all beta blockers are the same. You know that we have the first generation with propranolol, then the second generation with atenolol, bisoprolol, metoprolol, and then the third generation, the non-selective, such as carvedilol, and the Vito-1 selective with nitric oxide release, which is nebivolol. If you are going to use a beta blocker in our days, you have to use a cardioselective beta blocker. And the two most important cardioselective beta blockers is the first, nebivolol, followed by bisoprolol. However, we know that nebivolol, and you know from many years, has one more activity through the beta-3 receptors, and based on this, we have a better metabolic profile and vasodilation during the nitric oxide release. But they said that beta blockers are not effective in blood pressure reduction. Where is the evidence? This is a paper published many years ago, 357 randomized trials, more than 40,000 patients treated, and 160,000 patients placebo. And as you can see here, it's very effective, the use of beta blockers, and it's much better than thiazide-type diuretics or ACE inhibitors in reducing systolic and here diastolic blood pressure. And here you can see the data from a nice trial from Thomas Giles from United States using nebivolol, valsartan, or the fixed combination. And as you can see with the blue color, nebivolol, it's much more effective than valsartan in the treatment of systolic and diastolic blood pressure, and with red bars you can see that the combination is very effective. And here probably some of you are familiar with this trial that we published with my colleagues from Korea a few years ago, the Benefit Korea trial with more than 3,000 participants. And as you can see, nebivolol either as monotherapy or in combination with RAS blocker or calcium channel blocker was very effective in the Korean population, and this was clear to those younger, mid-age or older than 70 years. And another issue which is very important is the side effect profile, because if the side effect profile is high, then the discontinuation rate will be high and the adherence or compliance will be low. And from this trial from Thomas Giles, you can see that the discontinuation rate of nebivolol was similar to valsartan. Another important issue for criticism is the endothelial, the erectile dysfunction or sexual dysfunction in those treated with a beta blocker. It is clear from all the data that this is not the case for those using nebivolol. Those are my last slides, just published in less than 1 month from now, a meta-analysis with 91 randomized controlled trials, 7,700 patients using nebivolol or other classes of drugs. As you can see versus placebo, there was a clear superiority of nebivolol for systolic, and here you can see for diastolic blood pressure, versus all the other competitors, like RAS blockers, calcium channel blockers, diuretics. You can see that was equally effective in reducing systolic and diastolic blood pressure. And here you can see the data comparing by using ambulatory blood pressure monitoring. You can see once again clear superiority of nebivolol versus placebo, and here versus the other competitors. And the surprise was by using ambulatory blood pressure monitoring, it seems that for the reduction of diastolic blood pressure, nebivolol was superior than the other competitors. And this is not my position because I'm here to support Nebivolol because it's a Menarini breakfast symposium or whatever. Here I have a summary from all the guidelines published recently in Europe and United States. And as you can see, Nebivolol is a drug that was supported from 2018 European Society of Cardiology Hypertension Guidelines, the statement of American Heart for Stable Coronary Artery Disease, the position of European Society of Cardiology in Heart Failure Guidelines, again for European Society of Cardiology Cardiology Guidelines. Here you have the guidelines for atherosclerotic disease, the guidelines for COPD, and also the guidelines of European Urology Association for the sexual dysfunction. So it's not something that I'm saying that there is a clear superiority of Nebivolol. This now was recognized from all the medical community. Two last slides from my presentation. A few years ago, 2 years ago, they published this paper from United States and Europe discussing about the harmonization of American College, American Heart, and European Society of Hypertension and Cardiology guidelines. And as you can see, there are more similarities, less differences. And I think that doctors in daily practice are in front of a tsunami of guidelines for high blood pressure. Guidelines from 10 different countries in Asia Pacific. Guidelines from International Society of Hypertension, American Heart, American College, GPs in United States, European Society of Hypertension, European Society of Cardiology. I think the two papers that we published, the one that East meets West, bringing the ESH 23 guidelines hypertension into Asia, and the other paper published from American Heart and European Society of Cardiology guidelines talking about harmonization of the guidelines, I think that it's the right time to sit all together and to have common practical guidelines in order to improve the control and the treatment of blood pressure. Thank you very much for your attention.
Thank you, Professor Manolis, for your very comprehensive review regarding the similarity and the difference between the European and the Korean hypertension guideline. And also, you showed that all the beta blockers are not same, and there is a heterogeneity in the beta blocker in the nature and the effect of the treating hypertension. And also, in Korea, many physicians prescribe the beta blocker for the hypertensive patient with angina or heart failure or some tachyarrhythmia, but you showed that the beta blocker is very effective for the very young hypertensive patients who have a very high heart rate. So that is very impressive. And I also agree with your opinion that there are a very some difference between the national guidelines. So we have to discuss about the hypertension guideline from the European, Asian, and the USA. So we need some more common guideline for treating all the hypertensive patients. Because this industrial session do not accept the question from the audience, so if you have any question regarding this topic, please ask the Professor Manolis personally. And I would like to close this industrial session, and I would like to thank the sponsor, the Menarini Korea, for preparing this wonderful session and invited this distinguished Professor Manolis.
Thank you very much.
And I also thank you for all the audience joining this morning session, and thank you.
They are all the professors. Good morning, everyone. So welcome for the joining this session. So this session is on the treatment of hypertension in young adults. So is it too early to treat high blood pressure? So my name is Jail Shin from Yonsei University, Seoul, South Korea, and
My name is Alison Dre from the University of Sydney.
yeah. So the first two talk I will introduce, and the other two will be Professor Allison. And after 4 lectures, we will have a panel discussion. Okay, the first speaker is Chanjuli from Yonsei University, and his talk is on early life blood pressure and its effect across the life course. Yeah, please.
Thank you, Chairman. My name is Hanjuli from Yonsei University, and today's my talk is about early life blood pressure and its effect across the life course. Actually, this session is about young adult, but I will focus on childhood because the speakers after me are going to be talking mostly about young adults. I'm going to be talking about a little bit earlier than the young adult. When I was asked to speak on this topic, I wondered what early life is. So I asked ChatGPT what early life is in human terms, and was told that it is the stage of early childhood where growth occurs that affects later stage of life. Today I will talk about blood pressure during the childhood and adolescence and its effect on the later stage of life. I'm talking about the history of the blood pressure in pediatrics. Measurement of blood pressure in routine pediatric care was not established until the task force on blood pressure in children in 1977. The current definition of hypertension in childhood was made by the 1977 task force. The blood pressure of 95th percentile on the separate occasions on the blood pressure measurement. The latest clinical practice guidelines for the elevation of blood pressure in pediatrics was published in 2017. The definition in this practice guideline revised the definition of hypertension for adolescent. The definition of hypertension for adolescent uses the same single statistic cut point in adult. It's related to the blood pressure threshold that causes the cardiovascular event. First, let's look at what happened to blood pressure as children grow up. In selected cohort after blood pressure screening, Minneapolis, developmental change in the cardiovascular risk was studied in youth 11 to 19 years of age. As you can see, systolic blood pressure and diastolic blood pressure increases as age increases. Diastolic blood pressure increases similarly in both sex. Systolic blood pressure increased significantly in both sexes, but at greater rate in boys. There is a significant tracking of blood pressure from childhood to adulthood. But the prediction of adult hypertension is imprecise because blood pressure can be variable, and the initial hypertension measurement in clinic may return to normal with the repeated measurement. The correlation between childhood and adult blood pressure decreases with increasing length of follow-up. This figure shows that the correlation over the average 6 years between childhood and adolescent systolic blood pressure was significant and similar to the systolic blood pressure correlation over 13 years between adolescent and young adult. However, systolic blood pressure correlation over the 20 years between childhood and young adulthood was lower. However, there is some evidences that childhood blood pressure is associated with the high blood pressure in adulthood. This figure shows the prevalence of adult hypertension by a change in the blood pressure category from childhood to adolescent. Even within the persistent normotensive group, 19% reported adult hypertension. There is a graded increase in the frequency of self-reported adult hypertension across the BP change groups. The increase in blood pressure or the continued high blood pressure was associated with the increased frequency of reporting the adult hypertension. For subject remaining the remaining normotensive from childhood to adolescent, the average blood pressure measured at mean age 10, 16, and 30 years is plotted with the participant stratified by adult hypertension status. The hatched line is a normal, adult normal blood pressure, and this line shows a solid line shows the adult hypertension blood pressure at age 10, age 16, and 30. Even among normotensive use, subjects reporting adult hypertension have a great increase in the blood pressure from age 10 to 16, and with further difference in the blood pressure at mean age of 30 years. The blood pressure, the change in the participants who are the adult normal blood pressure, the blood pressure is decreased in from the 16 to 30 years old. But this figure shows adult hypertension shows the increase in the blood pressure during the adolescent. To better understand how adolescent blood pressure track into young adulthood, large-scale follow-up studies was conducted. Adolescents with a mean age of 17 years with blood pressure below the 140 and 90 were followed up for the instance of hypertension. This study identified 3,810 new cases of hypertension between the ages 17 and 4 years. Using Cox regression models adjusted for age, BMI, and stratified by baseline blood pressure, the hazard ratio of hypertension increased gradually across the blood pressure group without a discernible threshold effect, reaching a hazard ratio of 2.5 for boys and 2.31 for girls in the group with the blood pressure at 130 to the 140 and the diastolic pressure 185 to 89 millimeter mercury. This finding suggests that high blood pressure in childhood is significantly associated with adulthood hypertension. Next, I will discuss about the relation of child blood pressure to subclinical cardiovascular disease. This study evaluated the blood pressure-related increase in vascular stiffness on the target organ damage in use. Participants were stratified by the systolic blood pressure into the low and mid and high risk blood pressure categories. Pulse wave velocity increased across the group. Aortic dispensability coefficient, and compliance were greater in the lower than the mid or high group. After adjustment of confounding factors, pulse wave velocity was associated with LV diastolic dysfunction, and aortic compliance was associated with diastolic function and urine albumin to creatinine ratio. This finding revealed that blood pressure is related to the increased vascular stiffness and the target organ damage. This study examined the association of blood pressure trajectories from childhood to adolescent or young adult with arterial stiffness in adulthood. Blood pressure measured at 4 visits from 6 to the 15 years to the 14 to 24 years Among the 2,000 individuals, these trajectory groups of systolic blood pressure identified as follows: low level group and medium level group and the high level group. Individuals with a high level SVP pattern were more likely to be the men and smokers and present high blood pressure, the BMI, and heart rate at baseline, as well as the latest follow-up period. It also shows the high level group shows a high systolic blood pressure and diastolic blood pressure and the greater BMI. BAPWV in adulthood was significantly different among the SVP trajectory groups, being lowest the low level group and highest in the high level group. Table shows the result of mixed linear regression analysis of blood pressure trajectories from childhood to use on BAPWV in adulthood. Higher BP trajectory levels are associated with the higher BAPWV. After adjustment for potential compounding factors in early life, the association of BAPWV and SVP trajectory and diastolic trajectory remained statistically significant. Carotid IMT is also one of the surrogate marker of subclinical atherosclerosis. Although cardiovascular disease begins in early life, to extend to the which blood pressure at different life stage contribute to cardiovascular disease is unclear. This study aimed to determine the relative contribution to determine the at different life stage across the early life course from infancy to the young adult with a carotid intermediate thickness. This table shows the association with systolic blood pressure from the 5 life stages with adult carotid IMT. Higher cumulative the systolic blood pressure across the observed the life course was associated with the higher carotid IMT independent of the adjustment. This figure shows the relative weight of the association of systolic blood pressure from the 5 life stages with the carotid IMT in young adulthood. Systolic blood pressure from each life stage contribute to the carotid IMT in young adulthood, and the degree to which exposed to systolic blood pressure associated with the carotid IMT was largely similar across the observed life stages. These results indicate that accumulation of risk exposure to blood pressure levels at all life stages contributed to adulthood carotid IMT. The contribution attributed to each observed life stage was approximately equal. These results the support prevention effort that achieved and maintained normal blood pressure levels across the life course starting in infancy. Another study evaluated the effect of blood pressure change on the IMT. This study cohort consists of 4,000 participants from 4 prospective studies. Individuals are classified into 4 groups: normal child and adulthood blood pressure, high child blood pressure with normal adult blood pressure, it shows a resolution, and normal child blood pressure with high adult blood pressure is incident hypertension and persistent high blood pressure. Individual with persistently elevated blood pressure and individual with normal child blood pressure but elevated adult blood pressure had increased risk of high carotid IMT in comparison with the control group. In contrast, the individual with elevated blood pressure as children, but not as the adult, did not have significantly increased the risk. This result suggests that this risk of atherosclerosis can be reduced if elevated blood pressure during childhood is resolved by the adulthood. In adults, systolic blood pressure is associated with left ventricular hypertrophy. This is also true the adolescent. In multi-center study of 300 adolescents, the mean age of 15 years, the LV mass increased with the increase in clinical category of systolic blood pressure. This table shows that the systolic blood pressure percentile alone is a predictor of left ventricular mass index, and it remains significant in the fully adjusted model. Another study shows that LV mass index increased with the across daytime ambulatory systolic blood pressure in use. In addition, blood pressure levels were related to systolic and diastolic dysfunction. And is childhood blood pressure related to adult LVH? The longitudinal study evaluated the relationship between childhood blood pressure and the adult LVH. The longitudinal cohort of 1,000 adults performed repeated measurement of blood pressure 4 to 15 times from childhood to the adulthood and assessed the LV dimension with echocardiography in adulthood. This figure shows the longitudinal trajectory pattern of systolic blood pressure in those with LVH and normal by race and sex. Compared to the normal group, those with LVH had a higher systolic blood pressure from childhood to the adulthood, and higher the slope in young adulthood, but a low slope in the mid adulthood. This figure shows the standardized odds ratio and the confidence interval of the model estimated levels and the level adjusted linear slope of childhood systolic blood pressure for adult LVH after adjustment of compounding variables. Association of level independent linear slope of systolic blood pressure with adult LVH was significantly inverse in the pre-adolescent children of 4 to 9 years, but significant positive in adolescent. Inverse association in the pre-adolescent children might be explained by the phenomenon that the pre-adolescent children who had lower blood pressure tend to have a greater rate of increase. In any case, blood pressure and blood pressure slope in adolescent are strongly associated with LVH in adulthood. Also, childhood hypertension is associated with subclinical cognitive dysfunction. This multicenter study compared neurocognitive function between 75 children with newly diagnosed untreated hypertension and 75 matched with normal hypertensive control. Children with hypertension had worse performance of the memory, attention, and executive functions. Next, I will discuss about relation of child blood pressure to subclinical cardiovascular disease. A prospective cohort study involving participants in the cohort consortium evaluated whether childhood risk factors were associated with cardiovascular event in adulthood. Mean follow-up duration is 35 years. Systolic blood pressure is significantly related to adult, the fatal cardiovascular or fatal or non-fatal cardiovascular event. The gradient of the hazard ratio for cardiovascular event are apparent across the clinical categories of systolic blood pressure categories in even high normal systolic blood pressure category. The effect of early hypertension of middle life, cardiovascular mortality is, I have a time limit, so I will wrap up my lecture. The blood pressure is increased as age increases, and children with greater blood pressure elevation may be more likely to develop adult hypertension. Childhood blood pressure is related to subclinical atherosclerosis and target organ damage. Elevated blood pressure during childhood is a predictor of adult target organ damage, but the risk of target organ damage is reduced if hypertension is resolved. Increased blood pressure in early life is associated with a higher risk of death from cardiovascular disease decades later in the adulthood. So strict blood pressure management throughout the lifespan is crucial. Thank you for your attention.
Thank you so much for the comprehensive review on the effect of childhood blood pressure on adult blood pressure. Okay, the next speaker is Professor Ho-Gyu Lee from the Department of Preventive Medicine, Yonsei University College of Medicine. He will talk on awareness, treatment, and control rate of hypertension in young adults. Please.
Thank you, Chairman, for the kind introduction. So, yesterday, the KSH and the epidemiology working group, we released our annual Korean hypertension fact sheet. So we do this every year, and this topic is closely related to this fact sheet. So I'll show most of the data from this fact sheet. And we've been actually doing this for 7th year now. And each year we present some important descriptive statistics related to hypertension prevalence management. So currently many Korean societies do similar things with the fact sheet. So our distinct goal with this fact sheet is that we try to lay out the data. We try to just present the descriptive data without any of our own interpretation in text, so that people who use these figures would be able to come up with their own interpretation, and they could use it in their lectures, and they can use it as slides. So, and we try to focus mostly on the descriptive side rather than the associations or implications. So there are some chapters. I wouldn't be able to go over all of these chapters, but this year's topic is mostly on young adult hypertension, so I will focus on that chapter. This is a summary of hypertension statistics in Korea. So there are 13 million Korean adults with hypertension, which translates to 30.1% in prevalence. There are 11.5 million are diagnosed, 10.9 are treated, and 8.1 million are adherent to treatment, which translates to 77.2% of awareness rate and 74.1% treatment rate, and 58.6% in control rate. So if you're familiar with these hypertension management figures, statistics over the world, you'll probably realize that these numbers are just mind-blowing. They're really excellent figures. There are no other countries in the world with this high rate of management in terms of hypertension. So I always show this slide as a follow-up. I like the slide. This is from the NCD risk group. It shows the percent of diagnosed, treated, and controlled over the world. In men, it's 49%, so less than half are diagnosed. and 38% are treated, and 18% are controlled. So less than 20% are controlled among males, and slightly higher in women, 59% diagnosed, 47% treated, and 23% controlled. And we can easily compare this with numbers in Korean data, so pretty much just dwarfing everybody else in the world. This achievement this change has been achieved in a relatively short period of time. You can see in this map that the darker color in the top panels represent higher treatment rate, and darker colors in the bottom panels represent larger percent change within this time period of 30 years. So we have among the highest treatment rates and among the fastest change to achieve that goal. This is in terms of average population blood pressure. So South Korea currently ranking the top in terms of low average population blood pressure, both in men and women. And the change was rapid. So being from the 25th place to the first from 75 to 2015. Now you can see this figure. This is the age-adjusted stroke mortality in Korea, and population mean systolic blood pressure and hypertension control. So the rapid decrease in stroke mortality coincides with decreasing population mean systolic blood pressure and increasing hypertension control rate. So I think this is not a coincidence. This is a very, very related phenomenon that we, by achieving a very good hypertension control figures, we are seeing rapid decrease in stroke mortality at the same time. So if we combine this all, we have the fastest rate of decreasing age-adjusted total cardiovascular disease mortality over the world. We used to be above global average in the 90s, and now currently among the lowest with Japan, Singapore, Taiwan, and the rate of the decline is just phenomenal. Now we could see we could have a concern that the rate of decline, the rate of decrease is not as it used to be in 20 years ago. Now we're kind of seeing this flattening. So what can we do better to actually bring it down further? And one of the things I think we should focus on is really the young population, because if we break it down into age groups, then we are not seeing any decrease anymore in young premature cardiovascular mortality, and it is low in an absolute scale, but in a sense, cardiovascular disease mortality shouldn't just happen at all, like in their 20s and 30s. So I think we should bring it down even further. So let me go back to the young adult chapter in our new fact sheet. And this is the summary of hypertension statistics among young adults. Let me first start with this block representing people with hypertension. So age 20 to 39, the young adult hypertension is slightly less than 1 million, and that's less than 1/10 of the entire people with hypertension. This may be small, but the problem is that most of them are not persistently treated, and most of them do not see a doctor at all. So this small shade is probably the only number of people that are adequately treated regarding to their hypertension. What's more interesting is that we have twice as more people with pre-hypertension. My cursor just, yeah. We have twice as many people with pre-hypertension, and we have equally many people with elevated blood pressure. So prehypertension equivalent to above 130/80, equivalent to stage 1 hypertension, the ACC/AHA guideline, and elevated blood pressure above systolic 120 and below diastolic 80. So, so these people will eventually, those with elevated BP in the next decade will eventually become prehypertension, and those with prehypertension will eventually become overt hypertension in the next decade. So these people are not with us, are not with physicians yet, but most likely they will be. If they're not coming to the doctors in the next decade, then something's probably wrong with the detection and awareness. This is a number of people with hypertension by management status. So pretty much the red bars are undiagnosed, untreated. The green bars are treated and controlled. So in the Middle Ages and older, the total number of hypertension is increasing, but the portion is mostly increased within the treated and controlled group. So the total number of patients are increasing, but we're pretty much detecting them all and treating them all, and they're well controlled. The problem is here, 2039. The number is small, not really increasing, but these red bars, the portion of just undiagnosed, untreated, these are not really dropping down. So there are still unmet needs within this age group of hypertension. So we look closely more into the management figures. The awareness rate has rapidly increased for most of other age groups, and reached the plateau since 2010. And the figures are still low, like below 30–20% among young adults of age 20 to 39. Similar with the treatment rate, lower treatment rate among young adults relative to the other age groups. But I think we have some sense of optimism here, so that this bar represents the data that we have shown for the 2020 fact sheet, where we also did a young adult hypertension chapter 4 years ago. We wanted to see the change, what happened after this 4-year period. So I think we're seeing some improvement compared to the data that we had 4 years ago. And we see some increase in treatment rate, and similarly, an increase in control rate. And what's more important is that among young adults, once they are treated, so this is among treated, once they are treated, they are well controlled and probably better controlled than the rest of the age groups. So the problem is that they're not detected, they're not diagnosed, and they're not treated. But once they're treated, they have more potential to be adequately controlled. So I think the awareness and active treatment would be particularly important this young adult hypertension. So these are similar figures, just shifting some axes, so that the management figures are low in young adults, but we are recently seeing some improvement. Now this is a trend of average blood pressure among people with hypertension. So I think this is like a continuous scale of control, of blood pressure control. And what we see is that for young adults, their average SBP, their young hypertension, their average SBP is 133. Not perfect, but probably okay. But their average diastolic blood pressure is 88. It's close to 90, and it used to be actually above 90. So I think there should be a concern that we're not detecting or treating high diastolic blood pressure among these young adults as much as we probably should be. So this is not a fact sheet. This is our published data. So we actually translated this this phenomenon into control rates, broken down into systolic and diastolic blood pressure in Korean adults. We see that for systolic control rates, people below 40 have very high control rates, but then for diastolic blood pressure, the control rate is very low, much lower than the other age groups. And then this is related to the subtype known as isolated diastolic blood pressure. So pretty much having high diastolic blood pressure without having high systolic blood pressure. And their counterpart, isolated systolic, and then systolic diastolic. What we see is that among younger age groups, the diastolic subtype is the predominant form of hypertension. And whereas for older individuals, the systolic subtype seems to be the predominant type. So this IDH, is this important? So that's a complicated question. We tried to answer this question a few years ago with our own data from the national claims data. What we saw was that having only elevated diastolic blood pressure, and even to a low threshold, such as 130/80, as stage 1 hypertension of the ACC/AHA guideline, the risk is higher than having a normal blood pressure. So having only diastolic blood pressure elevated is probably not a benign feature. It is high risk, and we should be detecting it, and it should be managed properly. And even among people with low SBP, having a high diastolic blood pressure conferred higher premature cardiovascular events, and having lower diastolic blood pressure was associated with lower risk. And same was true not for CVD events, but also for subclinical events such as hypertension-mediated organ damage. So isolated diastolic hypertension was associated with thickened carotid IMT and presence of microalbuminuria among people with age lower than 50. Now I'm going to spend a few minutes on adherence. It's not part of the given topic today, but adherence is really related to the control of blood pressure, and adherence is very low. We see that most of people with hypertension are non-adherent to treatment, so I think this is a particularly important topic for young adults. And we see that this is the adherence rate among treated, so among people treated, those who are treated less than 80% of the time within a given year. And it's obviously lower than the other age groups, but what's bothering me is that it's not increasing. It's since 2013, it's not really increasing rapidly. So I think this needs some more attention. And so is it important? Think achieving good adherence is important for blood pressure, but is it important for preventing cardiovascular disease events? And this is a tricky question because we can't do an RCT. We can't do an RCT on adherence. We can't make people take less medication on purpose. So this has to be solved using observational data. We tried to do this. We tried to tackle this a few years ago using the national claims data among young adults with hypertension. You see, most of them are more than 2/3 were non-adherent, and these people, non-adherent, were associated with at least 60% more risk of having a premature cardiovascular risk. And the factors associated with medication adherence, these are important because we want to be able to take action into improving medication adherence. So pretty much the usual demographics and SCS and poor lifestyle, that's expected. But what we see is important is that using initial combination therapy was associated with higher likelihood of having good adherence and good persistence during the first year of treatment. And among those initiating with combination therapy, initiating with single pill combination was associated with higher likelihood of having a good adherence and persistence. So among, this is back to the fact sheet. So among 20 to 39, the rate of using combination therapy, the rate of using medication more than 2 classes are close to 50%, whereas in the rest of the population it's higher than 60%. So we can think of it as young adults being more easily their blood pressure more being easily controlled. So we may be using less drugs, but compared to the rest of the population, I think the combination therapy rate is lower. And the use of different classes is pretty much similar, except for the fact that for young females, we are using less RAS blockers than the rest of the population, probably related to the fact that related to the childbearing age. So let me summarize my talk. We have the highest awareness, treatment, and control rates in Korea versus global rate, but that pertains to the general population. But we have low awareness, treatment, control among young adults, but they're recently improving, and control rate is high among people who are persistently treated. And DPP control is particularly low among young adults, and this confers higher risk. And low medication adherence persistence among young adults, this also retains higher risk. Thank you for your attention.
Thank you so much for the very comprehensive and insightful lectures. Okay, so the next two will be chaired by Professor Alison Gerard.
Thank you so much. I would like to introduce our next speaker, who's an Associate Professor Ming-Yu Kong, who's an Associate Professor of Cardiology at the Sun Chun-hyang University. Thank you.
Thank you for a kind introduction. Good morning, everyone. I'm Ming-Yu Kong from Sun Chun-hyang University Hospital. I will present about investigation and treatment of hypertension in young adults. Yeah, I have no conflicts of interest to disclosure. Yeah, let's see the prevalence of hypertension in Korea from recent Korea hypertension fact sheet. The prevalence of hypertension tends to increase with age. In young adults aged 20 to 40 years old, the prevalence of hypertension is approximately 15 to 20% in men and under 10% in women. As you can see this figure, this is prevalence of isolated hypertension and isolated diastolic hypertension according to age group. Based on data from MMM participants in 1999, the prevalence of hypertension in individuals under 40 years old was below 10%, with 2.6% in their 20s and 7.8% in their 30s. Let's see the data from United States as the data from 2013 to 2014. In young adults, the prevalence was 6.7%. 7.3%. And then, interestingly, a high proportion of young hypertensive patients aged 18 to 39 are overweight or obese patients. This percentage continues to increase, and recent results show that the combined rate of overweight and obesity exceeds 90%. And this is most recent data from US. According to recent US statistics from 2017 to 2018, the prevalence of hypertension as defined by the newly revised ACC/AHA guidelines was quite high at 22.4% among individuals aged 18 to 39. In particular, the prevalence exceeds 30% among men. And these days, we often meet young hypertensive patients in the clinic. When we encounter young patients with high blood pressure in the clinic, what should we consider and decide? I think the first thing, should we manage young hypertensive patients by the same as general adult patients? And second, what specific tests should be performed for them? Third, so should we begin treatment? And should we start medication immediately? These are my questions. So first thing, should we manage the young hypertension patients by the same as over 40 years adult patients? Patients with blood pressure over 160 and 100 millimeter mercury, which is stage 2 or higher hypertension, should receive medication treatment. So we don't need to worry about that, just treat by medication. Yeah, it's very easy. But however, the patient with a blood pressure between 130 and 160, I think this is our problem. To decide medical therapy for these patients, guidelines recommend calculating the cardiovascular risk. As we know well, in United States, ASCVD 10-year risk calculation is used for primary prevention patients, and we can calculate the risk using age, sex, race, blood pressure, cholesterol level, and history of diabetes, and medication and smoking status. However, this risk score system was validated in patients aged just 40 to 79 years. And then age is very important parameter in this calculation. So there is a possibility of underestimation in young patients. In Europe, European guidelines recommend calculating the risk using this score 2 risk prediction. As you can see, the left figure of map, this is calculating system based on like this risk region category. The red region is very high risk group, so A, B, C, D is divided into 4 region category group, and then we can calculate using age, sex, smoking, blood pressure, and non-HDL cholesterol levels. And then these risk tables show the risk of patients aged only 40 to 69 years old. Therefore, this calculation formula is also difficult to apply to young patients in Korea in real practice, I think. And then in UK, as you can see, this risk calculation, Q risk 3, this was validated on 25 to 84 years old patient and included the relative risk and heart age and lifetime risk calculation. So we can consider to use this calculation for primary prevention. However, such calculation formulas are complex and time-consuming, making it difficult to apply them in the actual clinical setting in Korea, I think. So this is very important, I think. The results of the cardiac study, as you can see here, provide us some clues as to which patients should start treatment. It was prospective cohort with 4,851 participants aged 18 to 30 years in United States. In left figure for cardiovascular disease event, stage 2 hypertension and stage 1 and elevated blood pressure groups had a significantly higher risk compared to normal blood pressure group respectively. In right figure for all-cause mortality, only the stage 2 hypertension group had a significantly higher risk of death compared to each other groups. And second question is what specific tests should be performed for them? Although it is an older study, the analysis of over 4,000 hypertensive patients ages 17 and older shows that secondary hypertension occurs in about 10% of patients with hypertension before the age of 40. In those patients, renovascular and primary aldo were comparative common reason for secondary hypertension. As you can see the figure, this is incidence of selected forms of secondary hypertension according to age. So in those young patients aged 19 to 40 years, we should consider the cause of secondary hypertension for renal disease and renal vascular hypertension, especially fibromuscular dysplasia and monogenic disorder and pheochromocytoma and primary aldosteronism. And we must conduct the following tests to differentiate the causes of secondary hypertension. We should perform the blood tests for kidney function, electrolytes, renin, aldosterone, plasma metanephrine, and thyroid function tests, and urine tests for ACR and PCR, and 24-hour urine test for meta-adrenaline, aldosterone, cortisol, creatinine, electrolyte, and etc. And we can consider imaging modalities, for example, renal ultrasound or renal angiography for FMD or adrenal imaging also. Once secondary hypertension is excluded through those tests, we need to conduct examinations for end organ damage in order to identify high-risk patients. Yeah, unfortunately, you know, as I told you, in young adults, there's a possibility of underestimation, and then most of young patients is not validated from before risk calculation system. So we need to perform that test for differentiate end organ damage. It's very important. So we should perform blood tests and urine analysis, including creatinine, eGFR, electrolytes, ACR for CKD, and perform ECG, echocardiography, cardiac markers for heart failure or coronary disease or AFib, and perform also carotid ultrasound, PWV, and cardiac CT for large arteries. It's very important for assessment of end organ damage. And although it's very rare, if the following characteristics are observed in young hypertensive patients, monogenic hypertension must be suspected. The following is young onset hypertension, low renin hypertension, persistent electrolyte abnormalities, brachydactyly and hypertension, and adrenal steroid disorders, and family history of monogenic hypertension, young onset hypertension, sudden death, stroke, MI at young age in a first degree relative. Because if monogenic hypertension is diagnosed, specific treatment, as you can see, this should be initiated, as you can see this table, so it's important. The last question is, should we begin treatment and should we start medication immediately? As I showed you on prior slide from the result of cardiac study in young adults, compared to normal blood pressure, hypertension group over 140 and 90 millimeter mercury had a higher prevalence of LVH and coronary disease and chronic kidney disease. And in right figure from meta-analysis on published on Lancet 2016. Yeah, it's not only young patients, just in general population. As we know well, blood pressure lowering treatment significantly reduced the risk of MACE, coronary heart disease, and stroke also. So we can consider and think about early pharmacological treatment can prevent end organ damage in young adults also and reduce cardiovascular disease, I think. And let's see again the result from cardiac study. As you know, young hypertensive patients had a significantly higher incidence of cardiovascular disease and all-cause mortality. So we can imagine and we can consider early initiation of medical therapy can be considered if we think about that. However, we should consider following like this aspect. No RCTs to assess whether drug treatment is beneficial in young adults. And two, second, 10-year risk calculators not validated in young adults. And uncertainty of cost effectiveness for drug treatment in young adults for whole their life. And then possibility of upcoming drug side effects. And then potential pregnancy in young women, we should consider about that. Therefore, according to recent British-Irish Hypertension Society position statement for treatment in young adults, they recommend more, I think, some conservative pharmacotherapy initiation. As you can see, the right algorithm for management, if the patient blood pressure is 140 to 160 without cardiovascular disease and diabetes and CKD and hypertension-mediated organ damage, lifestyle intervention first for 3 to 12 months. As we know well, lifestyle intervention consists of these components, including increasing potassium intake, increasing physical activity, optimizing weight management, and reducing salt and reducing alcohol, and stop smoking. I think the most important thing is, optimizing weight management. As I told you on before a prior slide, the proportion of obese and overweight is about 90% in young hypertensive patients. So weight reduction is very important, I think. If blood pressure is not controlled despite lifestyle intervention, pharmacological treatment should be considered. First-line hypertensive in young adults, ACE inhibitor or ARB and beta blockers. While investing secondary hypertension, we can consider non-RAS antihypertensive, including calcium channel blocker. And then for women with childbearing potential, we can consider calcium channel blockers and beta blocker. This is my summary slide, last slide. When you encounter young hypertensive patients, first, pregnant women should be differentiated, and the possibility of secondary hypertension must be excluded. Next, it's necessary to check for end organ damage and calculate the risk. So we need to differentiate high-risk group. And then considering comorbidities and severe risk, you can decide treat hypertension. If the systolic blood pressure exceeds 160, pharmacotherapy should be initiated immediately. If it is lower, 140 to 160, lifestyle intervention should be tried first, and pharmacotherapy can be initiated depending on the response of lifestyle intervention. Yeah, thank you for your attention.
Wonderful, thank you very much for your presentation. And our final speaker in this session is Professor Hyung Junju, who's a professor of cardiology at Korea University, who will be speaking about research proposals in young adult hypertension. Thank you.
Thank you for nice introduction. I'm Hyung Junju from Korean University Anam Hospital. My topic is research proposal in young adult hypertension. So this topic is very difficult. And then former presenters already discussed key issues related to hypertension in young and middle-aged populations. The last 15 to 20 minutes, I introduce recent research topics and their future perspectives. To prepare this topic, I reviewed recent studies and numerous studies focused on hypertension in young and middle-aged populations in Korea. Regarding the data source, this includes a retrospective single or multi-center registries, but also a digitalized electronic health record databases. And additionally, we have a large and well-organized cohort like COGES. And then in terms of research topics, and one focus is predicting a new onset hypertension. And given the significant social and burden of hypertension, early surveillance and intervention for new onset hypertension will be very important. And other studies are examine spatial subtypes or phenotype of hypertension, such as isolated systolic hypertension and then exercise-induced hypertensions. And as well as studies also focused on clinical and subclinical characteristics, such as hemodynamics and then self-care behaviors and other subclinical atherosclerotic damage. The South Korean government runs a nationwide program to monitor the public health and behavior for several decades. South Korea has also maintained and unified medical insurance systems and has opened its digitalized claim data for research purpose. Korean National Health and Nutritional Examination Surveys and National Health Insurance System database is a representative database to study these topics. And additionally, there is a special database for the specialized populations, such as soldiers. This is the DAMIS database I introduced later. And some studies examined secondary hypertension, and then some studies studying the association with hypertension phenotypes and clinical and demographic characteristics. So nowadays, many researchers use nationwide longitudinal claim data for these studies. Among these data sources, I will introduce Defense Medical Information System database. It includes young soldiers. This database includes electronic medical records and imaging data and other laboratory data from 19 military hospitals, about 1,020 medical corps in South Korea from 1997. One recent study used the DAMIS database to invest secondary hypertension and identifying common cause of secondary hypertension. The result different somewhat from the findings in the previous data in other regions and healthcare systems. They found kidney disease and then also thyroid disease is common causes of secondary hypertension in Korean soldiers. And also, the independent predictor of secondary hypertension were abnormal thyroid function test, and proteinuria and hematuria, and severe hypertension, and non-overweight. And family history hypertension, and headache, and total cholesterol, and diabetes is not associated with the secondary hypertension. Another researchers studies the association between the lifestyle and the hypertension outcome in soldiers. Using DEMIS database, the authors investigate the body weight change and their incidence of dyslipidemia in the futures. As you can easily imagine that the military life provides a highly regulated and highly health-focused environment. This study demonstrates that the weight loss during the service reduced the future dyslipidemia incidence. It highlights the both benefit of lifestyle modification and the challenges associated with sustained lifestyle change. And as you can see here, globally, research on hypertension in young and middle-aged population is increasing. And there is similar studies on secondary hypertension in other countries. And as you can see here, they suggest that antihypertensive medications and hypokalemia is associated with the diagnosis of secondary hypertension. And male sex, obese, and family history hypertension is negatively associated with the development or diagnosis of secondary hypertension. Interestingly, contrary to Korean data, diabetes is also associated with high risk of secondary hypertension. And the other military-based study demonstrates that the role of insulin resistance in a new onset hypertension. And so I believe that the military database offers a valuable insights in young adult hypertensive research. In Japan, a special cohort of middle-aged workers provide data on the impact of pre-hypertension on cardiovascular disease incidence. And already you know that Korea also has an extensive health checkup database that also serves as a valuable research resources for the studying young and middle-aged hypertension. And in addition, a recent study explored unique hypertension phenotypes in young adults, such as spine hypertension and orthostatic hypertension. And this year's European Society of Hypertension conference also covered these kinds of spatial phenotype of hypertension, as far as I know. And the final topics is blood pressure monitoring and interventions in digital age. In this study, the authors studies the telephone health coaching intervention on hypertension control in young adults. In result, intervention group shows the significant behavior changes, including increased physical activities and reduction in dietary sodium intake, and increased frequency in home blood pressure monitoring. But the intervention failed to show a significant reduction in blood pressure in intervention group. According to the clinical trials.gov, there are currently 45 trials in Korea, including mostly drug intervention trials using new generics. But there are some studies regarding the feasibility using a new blood pressure monitoring device. And there are some trials involving observational or feedback-based interventions. And as you know well, the blood pressure monitoring is very important and emphasized in both global guideline and the Korean guidelines. And researchers worldwide are investigating new techniques such as telemedicine and then mobile and digital platform to, for the management of hypertension. And HOPE Asia Network Consensus State, and this network is include Korea and Japan and other Asia countries. And this consensus statement state the importance of home BP-centered approach, and then more importantly, the digitalization of this home blood pressure-centered approach. So starting this year, I conduct home blood pressure monitoring studies funded by the Korean Society of Hypertension. And these studies integrate the hospital data and then patient-centered patient health records. And then over the past 10 months, I recruit more than 600 patients, but exceeding the original goal of 500 participants. And then now recently expand the recruitment target to more than 1,000 to examine the long-term clinical outcomes. So this project is registered in the clinicaltrials.gov with contribution from other departments, including nephrology and then neurology doctors. And although the Korean Society of Hypertension funded this project, but I think this project is not a stringent cohort compared to other cohort before. I have only one coordinator, and it reflects real clinical practice, and I will study the patient engagement and its effect on long-term clinical outcome. Here is a preliminary result from the interim analysis, and we integrate, the office blood pressure and home recorded blood pressures. And we can also integrate other patient reports and then other hospital data, including laboratory and other special examinations. Okay, and we developed a mobile platform and to record personal health information, and then also it can be visualized on the physician's desktops using temporary ID QR code. And patient-centered blood pressure monitoring can enhance blood pressure control in real-world practice. For example, this is a case of 41 male, obese, smoker, and very busy workers with high blood pressures. And he often rushed into clinics, and then it makes it difficult to for his physician to adjust his medication, as you can see here. And then the physician recommend the home BP monitoring. And then using this platform, without any additional interventions, his physicians can effectively manage his blood pressure, as you can see. And as you can see here, single measurement of home blood pressure or single measurement of office blood pressure we can difficulty to discriminate the meaning of a single measurement. However, we somehow integrate 5 to 7 measurements together, it was very consistent with the medications. So physicians changed their medications, and then his blood pressure is stabilized, as you can see here. So I think that repeated measurement of blood pressure is very important, and then also we need some platform to integrate their repeated measurement in the clinic. Okay, to summarize my talk, there is extensive researches on hypertension in young adults. These studies are supported by the various valuable data resources, such as nationwide claim data database and spatial database such as DEMIS, and well-organized cohort like COGES. And other countries also have such a cohort. Regarding the topics, recent topics include secondary hypertension and prehypertension and isolated systolic and diastolic hypertension. And then new onset hypertension, a prediction of new onset hypertension also had very important topics. And then there are many studies regarding a spatial phenotype of hypertension of orthostatic and spine hypertensions. And I also focused on, in digital age, interventional trials using new platforms also can be feasible in these days. Thank you for your attention.
Yeah, thank you so much. So it's time to have a panel discussion. So there will be 4 professors: Hyunjin Kim from Hanyang University, Jae-bin Seo, Seoul National University, Hyunju Yoon from Jeonnam National University, and Minhyun Jo from Gyeongbuk National University. So it would be good to discuss. Yeah.
I'm Hyunjin Kim from Hanyang University. Thank you for our speaker. And I have a short question to Professor Min-gyu Kong. In your opinion, what is the most appropriate cardiovascular risk prediction score system for young hypertensive Korean adults between 20 and 40? Because currently the incidence of young hypertension has been increased, so we occasionally meet the young patient in clinic.
Yeah, thank you for a nice question. It's very difficult to answer, but in my opinion, as I showed you on my slide, among 3 risk calculation systems, actually, prior to calculation system only validated with patient aged just over 40 years old, but Q-risk-3 is validated with 25 years aged and to 75 aged population. So I can recommend that calculating system, but you know, in our clinical setting, it's very it's very difficult to calculate the patient risk in real practice, 3 minutes practice setting. So I think we need to simplify some algorithm for managing hypertensive patient in young adults. So if the patient had 140 to 160 millimeter mercury systolic blood pressure, it's our problem. I think we need to differentiate secondary hypertension and organ damage, and then if the patient have organ damage or some cardiovascular disease or diabetes or chronic kidney disease, we should initiate early medical therapy intervention. I think it's very important, I think. Thank you.
Yeah. Professor Jae-bin Seo.
Okay, thank you for your kind and excellent lectures. Generally, atherosclerosis begins in the young population, especially in the adolescent period or youth generation. So we see, I think I agree it's important to treat the hypertension in early period. Even some people say the atherosclerosis is the adolescent disease. So I have a simple question to Dr. Gong. Your slide showed us the first line medication for young adult is AER-based inhibitor or beta blocker. So this is provided by some investigator. And what is your personal preference for those young patients?
Yeah, and I also prefer ARB or beta blocker. You know, I think in young adults, beta blocker had an important role for some patients. You know, beta blocker is activate on sympathetic nervous system, and in young adults have 90% of obese or overweight patient, and those patients have insulin resistance and then have a lot of adipocytes. So in that mechanism, for focus on that mechanism, beta blocker has an important role. Yeah, I think so. I prefer beta blocker and also ARB.
Yeah, that's the Hyunju Yun.
Yes. Yeah, thank you for a nice lecture. I'm Hyunju Yun from Jeonnam National University. I have an additional question to Dr. Gong. I'm very sorry. As you already know from data, diastolic hypertension subtype is frequently in young adult groups. According to the guideline, we have to approach it to the systemic BP target goal, but is any kind of additional method or additional tip for management of diastolic hypertension effectively in young adult or less elderly group?
Thank you for your question. It's very, very difficult for me. I think, yeah. As we know, yeah, in young adults, it's very frequent. Isolated diastolic hypertension type is very more common, yeah, than isolated systolic hypertension. But it's very difficult to initiate medical therapy to just isolated diastolic hypertension patient. So if the patient blood pressure is under 160, so I think we can consider lifestyle intervention first, and then we can recheck the response and blood pressure. Yeah, after that, I think it's more better. So yeah, it's just my answer. I'm sorry, it's not enough, I think.
Yeah, thank you. Next, Min Hyun-jo.
Thank you. I am a pediatric nephrologist, so I would like to ask 3 internal medicine doctors my questions. During young adult period, there is special events to be considered. As Professor Kong mentioned, pregnancy. Unfortunately, I have several experiences of children with chronic kidney disease or end-stage kidney disease, probably due to exposure of ACE inhibitor or ARB during pregnancy. As the number of young adult hypertensive patients increase, the possibility of this tragic complication also increase. So I think that, in my opinion, we need more specific and continuous education for young adult patient and the young adult patient doctors. So what do you think about this situation? I would like to ask internal medicine doctors, please.
Who can answer? So the treatment of the patients who are pregnant is treated by internal medicine physician or obstetric gynecologist? I don't know exactly. But
as far as I know, usually young women, patient treated by an internal medicine doctor in a primary care center. So I worry about this situation. Actually, this is very rare and preventable. So, but has been developed continuously. So I worry about this situation.
Oh, Professor Chanjuli, yeah.
Actually, I'm also internal medicine doctor, but today I presented the pediatric hypertension. But in my case, I treated the young woman who can be pregnant. I preferred the calcium channel blocker than the ARB because of the adverse effect. So, and if the woman who have the proteinuria, I prescribe the ARB instead of a calcium channel blocker, but I always warn about the adverse effect of the to the fetus. So I always tell them to they quit the ARB before the plan of a pregnancy. So I also agree with your concern about that.
Thank you so much. But I can suppose that pregnancy in young adults can be detected early, but sometimes so the ACE inhibitors is used for the treatment of hypertension. But if pregnancy is detected later, so I wonder how much the adverse effect of the ARB or ACE inhibitor is. But definitely will be harmful, I think. So I think the education is very important, in the treatment of this kind of patient group. Okay, so is there any questions or comments from audience or Professor Allison?
I just want to thank everyone for their presentations this morning. It was very insightful and informative, and I was just interested to see all the different research proposals that were put up there, and large majority were pharmaceutical drug trials. I think there's a lot of scope to expand what we do in our research and also look at other novel interventions such as lifestyle interventions, psychosocial interventions, particularly given the challenges around behaviour change and also adherence. I think there's quite a gap that could be addressed with future research.
Yeah, thank you. So, I have one question to Professor Hoguli. So, you showed several slides. So, many young adult patients or the hypertension is undertreated and the low adherence. So, what do you think about the barrier for them, and is there any method to improve this kind of problems?
Yeah, thank you, Chairman, for the question. It's a difficult issue. So, I think the real barrier for young adults is to actually see a doctor. So I mean, just admit that they have a problem, and it's really hard because there are less chances for them to actually measure blood pressure. And as we all know, we can't control risk factors that we don't measure. So fortunately in Korea, we've expanded our national screening to young adults starting from 2019. Before it was employees or general population above 40, and now we have expanded to age 20 or over. So I think the chances of actually knowing their blood pressure increased. So that I think that relates to the improvement of awareness and treatment that we see. As far as adherence, there are multiple factors. There are patient factors, physician factors, there are healthcare factors, and I guess there are equally as much barrier to patients, to physicians, as there is for patients. It's hard to treat young adults against their will to not take medication for life. So I think there should be a lot of discussion, and also that discussion involves long-term risk of cardiovascular events. So I think that relates to I think the first question that Dr. Kong received. It's actually hard to estimate long-term cardiovascular event, long-term risk of cardiovascular events in these patients. And if we don't estimate the risk, we can't start the discussion with these patients. So when we estimate like a 10-year ASCVD risk, the risk is often low for young adults, say like 1%. And how can we persuade, how can we convince these patients that you have a 1% risk and you have to take medication? So that really doesn't make sense. That's why we have to use longer term, a longer period of time risk estimation, for instance, 30 years or lifetime risk, so that you have a 35% chance that you will eventually have a CVD event if your blood pressure stays this way for the rest of your life. So I think that's how we start discussion. And that relates to decision for treatment and also for adherence.
Thank you so much. Okay, so time is over, so we'll close this session. And this session was very insightful, and so more research is necessary between the collaborations between pediatric hypertension and adolescent and connected to adult hypertension. So thank you so much for joining this session, and also very thanks for the speakers and chairs and audience. Thank you so much and have a wonderful day. Yeah, thank you. Thank you so much.
요즘 자주 보이는 단어가 하나 있습니다. 고혈압. 혈압이 만성적으로 정상보다 높은 것을 말하는데요. 수축기 혈압이 140, 이완기 혈압이 90 이상이면 고혈압으로 판정합니다. 우리가 고혈압에 관심을 기울여야 하는 이유는 무엇일까요? 바로 고혈압은 뇌혈관 질환, 신부전증, 동맥경화증과 심장질환 등의 합병증을 일으킬 수 있기 때문입니다. 국내 성인의 고혈압 유병률은 28.4%. 우리 가족도 그 위험에서 벗어날 수 없겠죠? 고혈압은 특히 가족력이 크게 작용하는 질환입니다. 부모 모두 고혈압의 경우 80%, 한쪽만 고혈압의 경우 20에서 50%로 자녀에게서 나타납니다. 그렇다면 우리 가족이 실천할 수 있는 고혈압 예방 및 관리법은 무엇일까요? 바로 금연, 절주, 운동, 식이요법입니다. 흡연과 음주는 혈압 상승의 강력한 위험 요인이므로 금연 및 절주는 필수적입니다. 또 규칙적인 운동도 혈압을 줄이는 데에 효과가 있습니다. 지방과 정제 탄수화물을 줄이고 과일과 채소 섭취를 늘리는 대시 식단과 소금 섭취를 줄이는 것도 도움이 됩니다. 주기적인 혈압 측정과 지속적 관리로 너와 내 가족의 건강을 지켜주세요.
네네. Yeah, good morning, everyone. So it's a time to it's a time to start. Welcome to this session. This session is how to manage mask and mask-uncontrolled hypertension. I'm Sang-hyun Nim from Catholic University of Korea, and co-chair is Professor Kei Asayama from Japan. On this session, 4 speakers and 3 panelists. After all speaker presentation, and then we will have a 15-minute panel discussion. Actually, let me introduce 2 speakers, and then Professor Asayama will introduce next 2 speakers. Let me introduce the first speaker. First speaker is Hyo-seok An. I'm sorry. He's graduated from Gyeonggi University. Now he works in Catholic University of Korea and Ujeongbu St. Mary's Hospital. So today's His topic is a risk profile of masked hypertension and masked uncontrolled hypertension. Please, Dr. An.
Thank you for good presentation chance. Today's topic is risk profile of masked hypertension and masked uncontrolled hypertension. BP continuously changes in the short term and long term, diurnal change and seasonal change. So, in sleeping, nocturnal blood pressure dipping occur, and in the morning, morning blood pressure surge occur. Daytime BP is commonly office BP. By the way, in the daytime also blood pressure variable. So masked hypertension means that office readings suggest normal blood pressure, but out of office readings that are constantly above normal. And masked uncontrolled hypertension, MUCH, means that in patients with treated for hypertension, controlled office blood pressures, but uncontrolled blood pressures in out of office settings. Masked hypertension is that also known as untreated masked hypertension, and is defined by the following in an untreated patient. Masked uncontrolled hypertension is that also known as treated masked hypertension, and defined by the following in a treated patient. In untreated patients, office BP high and ambulatory BP low, that means white coat hypertension have risk of over-treatment and risk of progression to hypertension. And office BP low and ambulatory BP high, that means masked hypertension. In treated patient group, office BP low or ambulatory BP high, that means masked uncontrolled hypertension. So masked hypertension and masked uncontrolled hypertension have also risk of under treatment and poor prognosis. Clinical BP, office BP, home BP, ambulatory BP have different normal range and cutoff value. So commonly, ambulatory BP monitoring have lower normal range and cutoff value than clinic and office BP. In Korean group, masked hypertension is 17%, and masked uncontrolled hypertension group is 13%. In epidemiology, masked hypertension is present in approximately 10 to 30% of adults with normal office-based blood pressure. And masked hypertension may be more common among men, African Americans, and patients with diabetes, chronic kidney disease, and obstructive sleep apnea. In meta-analysis, masked hypertension have worse prognosis than white coat hypertension and normotensive group. So BP increasing, worse prognosis. Masked hypertension have worse prognosis in cardiovascular events and total mortality than white coat hypertension and normotension group. And masked uncontrolled hypertension, MUCH, have also worse prognosis than normotensive group and hypertensive group. The overall adjusted hazard ratio of composite outcome, including cardiovascular outcome and all-cause mortality, was 1.80 for masked uncontrolled hypertension versus hypertension group. In meta-analysis, masked hypertension have more cardiovascular event than normal hypertension group, and also masked uncontrolled hypertension group have a higher cardiovascular event than normotensive group. So in total mortality also same. So masked hypertension have worse prognosis, and MUCH have worse prognosis than sustained hypertension. Daytime masked uncontrolled hypertension have worse prognosis than nighttime MUCH, and worst prognosis showed in daytime plus nighttime masked hypertension. So adjusted hazard ratio 2.29. So in prognosis in masked and masked uncontrolled hypertension are constantly associated with increased risk of major adverse cardiovascular event and all-cause mortality, similar to that of sustained hypertension. In meta-analysis, 11 studies, including 30,000 patients who underwent home ambulatory BP monitoring, MUCH was associated with an increased risk of MACE and all-cause mortality than hypertension group. Simple case I'll show. 50 years old male, chief complaint is carotid atherosclerosis. A healthy person without any chronic disease visited the Department of Cardiology due to an increase in IMT of 1.3 millimeter in a carotid artery ultrasound examination performed during a health checkup. He have a smoking history, office blood pressure 135, 87 millimeter mercury. But 24-hour ambulatory BP monitoring, he have nocturnal hypertension and masked hypertension. So he have target organ damage, carotid atherosclerosis, and masked hypertension. So BP medication start. Why to evaluate for masked hypertension or masked uncontrolled hypertension? Masked hypertension, office-based blood pressure 10 millimeter mercury or less below the patient's goal. In masked uncontrolled hypertension, office-based blood pressure below the patient's goal plus any of the following: elevated atherosclerotic cardiovascular disease risk, chronic kidney disease, diabetes mellitus, evidence of new or worsening end organ damage, for example, prior atherosclerotic cardiovascular event, heart failure, LV hypertrophy, hypertensive retinopathy, and so on. A cohort study, 14,000 people with treated on controlled clinic blood pressure. 31% have masked uncontrolled hypertension according to 24-hour ambulatory BP monitoring criteria. Male, smoker, obese, diabetes are considered as risk factor for MUCH. In China data, obesity have higher masked uncontrolled hypertension, but masked hypertension is non-significant. In Turkey cohort, obesity patients have higher masked hypertension significantly. Morning masked hypertension is related to alcohol and insomnia. Daytime masked hypertension is related to job strain, mental stress, and smoking. Nighttime masked hypertension is related to sleep deprivation, obstructive sleep apnea, metabolic syndrome, diabetes mellitus, and chronic kidney disease. Conclusion: masked and masked uncontrolled hypertension have increased the risk of major adverse cardiovascular event and all-cause mortality, similar to that of sustained hypertension. So BP monitoring is important. Future advance of BP monitoring will be improve prognosis of masked hypertension, I think. Thank you very much.
Yeah, thank you very much, Professor An. So he briefly summarized the risk profile regarding masked hypertension and masked uncontrolled hypertension. Let's move on a second talk. So second speaker is Professor Sung-Ah Bae. He graduated from Jeonnam University. Now he works assistant clinical professor of cardiology at Yonsei University Yongin Severance Hospital. So his topic is monitoring and diagnostic strategy for masked hypertension and masked uncontrolled hypertension. Professor Bae, please.
Thank you, Chairman. Good evening. Good morning, everyone. My name is Sung-Ah Bae and Yongin Severance Hospital, and I'd like to talk about the monitoring and diagnostic strategy for masked hypertension and much. CY is none. And the blood pressure varies slightly each measurement, especially due to the circadian variation. It tends to be higher during the day and decrease in the evening. The patient with masked hypertension may exhibit normal office BP readings, but show the abnormal elevation during the specific period, such as nighttime or early morning. Already knows that the definition of hypertension was below the hypertension diagnostic threshold, the office, but above the hypertension diagnostic threshold in home and ambulatory BP. And the much is almost the same, but the patient receiving the hypertension. In Korea, the prevalence of mask hypertension and much is about 17%, and much is 30%. So in this paper, conclusions that discordance between the ABP and clinic BP was observed more frequently in on-treatment subject than the treatment subject. And this paper, key message is the masked hypertension or masked uncontrolled hypertension are not decreased in patients with high or very high risk profile. This study analyzes about 8,000 on-treatment patients and found that the masked hypertension significantly increased CV and stroke risk. Especially, the masked hypertension is approximately double the risk of CV risk and nearly the triple risk of the stroke compared to normal hypertension. And another study is that IDACO study. Then the Kaplan-Meier curve demonstrated the cumulative of CV event across the different BP categories. The patient of much and masked hypertension showed significantly higher incidence of CV event compared to the normal individual, highlighting the importance of detecting the masked hypertension to prevent the advanced event. In the real-world practice, the patients say that sometimes when I check my blood pressure, my SBP is over the 1,114, but today my blood pressure is normal, so I don't need to take a hypertension medication. So the doctor thinking about watchful monitoring or versus hypertension medication. The principle of office BP management is most important is office BP should be measured under the standardized condition, avoiding the isolated reading or during the stress clinical visit which may not reflect the true BP status, and ensure the accurate measurement by using the validated device, and compare the out-of-office BP monitoring is very important. In outpatient clinic, patients with a wide range of body type were seen. So while the current guidelines recommend selecting the cup size operatives for each patient arm, but the many clinics rely on only a single fixed automated BP pressure machine for all patients. This approach can lead to measurement errors, particularly in patients whose body size is outside of the standard range. In this study, is effect on cup size on the accuracy on the BP reading, and the cup randomized crossover trial show that when the cup is too large for the patient with a smaller body size, the BP may be underestimated, whereas the cup is too small, the cup that is the BP will be overestimated. Therefore, in patients with smaller physical, then it's crucial to consider the possibility that the office BP measure may be underestimated their true BP. And another factor is influence the office systolic BP reading. Recent meal investigation and recent alcohol intake and clinical office setting can significantly influence the office systolic BP reading. So particularly in the alcoholic intake, which can cause the BP fluctuation about 20 millimeter per mercury. So it is crucial to ask the chronic alcoholics about the recent heavy drinking, interpret the office BP aggressively. And we know that the muscular hypertension is the golden standard is ABPM and or home BP monitoring is class 1B. And in patient with a high normal blood pressure, high normal blood pressure means between the 120 and 140. The ambulatory BP is very important. The advantage is can identify the white coat and muscular hypertension and measure the real-life setting and during the usual activity and stronger prognostic evidence and additional BP phenotyping, example, nocturnal dipping status. But the main disadvantage is can be uncomfortable and affect the sleep. This is in the ESC guidelines say that a minimum of the 70% usable BP recording is required, and a diary of the patient activity, intake of medication, and sleep time should be completed. But in the case about 13 years ago, the complication of the ambulatory BP monitoring, the main problem is a skin problem. The particularly in the anterior cubital fossa after the 24 hours ambulatory BP monitoring. So patients say that last time I did an ABPM test, but my arm hurts so much, so I don't ever want to do that test again. So the doctor said that in that case, please measure your BP at the home and bring the readings with you next time. Home BP monitoring is very important. The main advantage is also identify the white coat and muscular hypertension and cheap and widely available and more relaxed than the doctor's office and easily repeated and used over the longer period of assess the day-to-day BP variability. But main disadvantage is that only static BP are typically available, and the potential measurement error and nocturnal reading is not usually possible. So outpatient clinic, doctor, I'll give you a blood pressure. This is my hospital hypertension management notebook. And please check your BP at the home every morning and evening. Make sure bring it to your next clinic. But the patient does measure their BP at home. This is some patients use a ramen noodle tray, only use. So patients say that I forgot to bring my blood pressure log today, so I'll make sure to bring it next time. But most patients never bring their blood pressure log. This is the main problem. So why the measure the target organ damage risk assessment is very important. Why? Because the supported decision to start or intensify the BP lowering treatment. So the uncertain situation or muscular or white coat hypertension, an individual or a young age, and some patients say that the home BP is very high, then I didn't take BP medication, but I feel fine all this time. I really need the hypertension med. So the patients say that this is very important because the overcoming the patient and physician inertia is the treatment target. So which organ is important? In the kidney, we always test the GFR and ACR, and heart, the ECG and echocardiography. LVH is important, and the diastolic dysfunction is also included the target organ damage. And cardiac biomarker is also tested in the troponin T and NT-proBNP. And in the arteries, the carotid or femoral ultrasound and pulse wave velocity and cardiac CT also used. I recently published the early menopause women and abnormal diastolic dysfunction is a poor clinical outcome in suspected angina patient. And early menopause woman is associated with abnormal diastolic dysfunction. And in the early menopausal and normal diastolic dysfunction is not associated with MACE, but abnormal diastolic dysfunction with early menopause woman has nearly double associated with MACE. Look at the case. The patient is intermittent high BP. I usually feel fine, but sometimes my blood pressure is suddenly spiked to the 160 millimeter per mercury. Recently, I have been experienced occasional headache. The office BP is high normal BP, and the menopause is early menopause, and recently weight gain is 5 kilograms. And lipid profile is mildly increased, and A1C is also impaired fasting glucose, but LVG is known. So I tried to check the TTE, and the LG ejection pressure is normal, and every chamber size and every geography is normal. But the diastolic dysfunction does show the impaired relaxation, and the septal prime is decreased, and TI velocity and LA volume index is increased. And the 20 hours ambulatory BP is increases the BP, and so I diagnose masked hypertension. But in current ICD-10 includes the cause the hypertension, but unfortunately there is no specific code with masked hypertension. Considering the significance, I believe it should be recognized and assigned the dedicated ICD code in the future. Back to the case, most patients never bring their blood pressure log, so the new BP monitoring method emerged. Most of office BP or home BP or ambulatory BP is a strong evidence and best method, but the home BP is required training and medical supervision, and ambulatory BP not acceptable older users. So the coupleless wearable BP monitoring is great potential of BP monitoring, but the no-couple induced discomfort is very good advantage. Recently, a ring type blood pressure monitoring CAT BP health insurer approved patient burden of about $3 to $6, and Skyref's the world first ring type continuous BP monitoring was recently approved. So when the hypertensive patient receive CAT BP from hospital or clinic where their finger and 20-hour record of BP pressure changes automatically transmitted to the medical staff and the hospital or clinic. This is the mechanism. The PPG is the photo mean the light, and the plasma is the Greek word mean the enlargement of the volume, and graphy is mean the record or write. So light emitted from the LED passes through the reflects the skin and change the blood flow or alter the amount of light absorbed or reflected. So photodiode detect this change, allowing the device to measure the blood volume variation corresponding to the cardiac cycle. This is a validation paper and data collected from the operation room, Seoul National University Hospital. And data collected PPG and A-line BP and COP BP. The data collected from about 4,000 people, and mechanism is AI deep learning model. And the blood pressure estimated and confirmed the compliance of the international standard. So in this result, so that the standard is the mean error is lower the 5 millimeter per mercury, and standard deviation error is 8 millimeter per mercury. Then the CAT BP show the meet the AAMI is the medical instrument standard. And they meet the British Hypertension Society standard. Group A is very tight, but they meet this grade. And recently, published the KCJ that this study showed the BP pressure management compared with between the conventional ABPM and CAT BP Pro using the same arm simultaneous method. The primary outcome is mean error and standard deviation error were assessed in accordance with the international standard. The characteristics show that the hypertension about 60% and the hypertension medication is about 45%. And results show that the ISO standard is lower than the 5 millimeter per mercury, and the data show that lower the 24 hours and daytime and nighttime. And the correlation profile show that the strong correlation in the BP transition from the daytime to nighttime. The ESH guidelines show the correlation coefficients is upper the 0.7, so they meet this criteria. The last evidence guidelines from the coupleless BP show that coupleless BP devices should not be used for the evaluation or management or hypertension in clinical practice, class C or 3B/C. And recently, ESC guidelines say that the emerging techniques include wearable device, wrist device BP measurement, or coupleless device is program PPG or other technique. However, there is insufficient scientific consensus of the accuracy standard and validation procedure. So in view in this issue, none of these coupleless measurements are currently recommended in routine clinical use. But making evidence take a time. Recently, ESH guidelines say that autonomic electronic upper arm cuff device are recommended or office on out-of-office BP and class 1B, but about 30 years ago, the British Hypertension Society protocol say that the automated and semi-automated devices say that the validation criteria are limited, so assessment must be interpreted cautiously. So it's need more time to making advance. And currently, there are currently more than 10 clinical trials underway, the clinical trials from GOV about the coupleless BP monitoring. Therefore, as the evidence of the coupleless BP monitoring continues to grow over time, it's expected to that will be eventually receive the recommendation in future guidelines. This is the last slide. Then, masked hypertension and masked uncontrolled hypertension significantly increase the severe risk and making their detection cruel in clinical practice. And the office BP alone is insufficient, so emphasizing the importance of the ABPM and home BP monitoring and regular HMOD evaluation is captured more accurate reading and assessed target organ damage for better risk assessment. And the new technology, including the coupleless BP device, show the promise to improving the detection and measurement of masked hypertension and much. So clinical evidence growth, their innovation are expected to be incorporated into the future hypertension guidelines. Thank you for listening.
Thank you very much for excellent talk regarding the monitoring and diagnosis strategy, including the coupleless device for patients with masked hypertension, especially with funny cartoon and cases. So very interesting. Next, Professor Asayama is introducing next two speakers.
Thank you. My name is Kei Asayama. I take over the chairperson role. So the third speaker is Dr. Byung-sik Kim from the Hanyang University Guri Hospital. He is affiliated to the Department of Internal Medicine, Division of Cardiology. So, Dr. Kim, please proceed.
Thank you, Chairman. Hello, ladies and gentlemen. I'm Byung-sik Kim from Hanyang University Guri Hospital. I'm very honored to have the opportunity to present in this session. Today, my topic is right BP target for masked hypertension and masked uncontrolled hypertension. I will present in the following contents. Hypertension is the world-leading risk factor for the mortality and is responsible for 1 in every 5 deaths. Therefore, blood pressure control is one of the voluntary global targets for prevention and control of non-communicable diseases. This effort has led to continuously improved of blood pressure control rate. However, hypertension is still affects 33% of adults worldwide, and among those with hypertension, effective treatment coverage rate is only 21%. Today's topic is about hidden patient in controlled hypertension, which appears to be under control, but actually is not, a condition known as masked hypertension. It is known that about 10 to 20% patients attending hypertension clinic have masked hypertension. In the international database on ambulatory BP in relation to cardiovascular outcome study, 14.6% of participants had masked hypertension. Prevalence of masked hypertension also vary by country, from 8.8 in Belgium to 30.5% in China. In an analysis of the Artemis registry, significant variation by geographic region was also observed. Prevalence of masked hypertension was observed to range from 9% in Europe to 16% in Asia and 17% in Africa. There are also racial differences in the prevalence of masked hypertension. A study from the US reported that range from 10.6% in Hispanic and 11.8% in non-Hispanic white and 15.7% among African Americans. Considerations in the BP target of masked hypertension. The first thing is masked hypertension carries a similar risk to sustained hypertension. In the management of hypertension patient, target blood pressure is set consider organ damages and cardiovascular risk. It is similar to other guidelines such as 2024 ESC and 2024 ESH guideline. They are also considering organ damages and cardiovascular risk when managing hypertensive patient. In terms of organ damage and cardiovascular risk, how does masked hypertension compare to normotensive and sustained hypertensive patient? In meta-analysis, masked hypertension patient had significantly increased CFPWB value compared to normotensive patient, but significantly lower CFPWB value compared to the sustained hypertensive group. In the Pamela study population, individuals with masked hypertension had higher prevalence of LVH compared to normotensive individuals. In addition, in meta-analysis, masked hypertension patients had significantly higher LV mass index compared to the normotensive group, but significantly lower value compared to the sustained hypertensive groups. Furthermore, observational study performed in Japan showed that masked hypertension is associated with advanced target organ damage in treated hypertensive patients comparable to that in case of sustained hypertension. Similar findings are also found in the Jackson Heart study. target organ damage was significantly higher in masked hypertensive compared to the normotensive group and was similar between masked hypertension and sustained hypertension group. In the international database on ambulatory BP in relation to cardiovascular outcome study, incidence of cardiovascular event increased from normotension over white coat and masked hypertension to sustained hypertension. Also in Dallas ART study, masked hypertension were independently associated with higher cardiovascular event compared with the normotensive groups. In a meta-analysis, patients with masked hypertension had a 1.67-fold higher risk of all-cause mortality and 2.19 for cardiovascular mortality. Another meta-analysis found that risk of cardiovascular event is substantially greater in masked hypertension compared with normotension and close to the risk of sustained hypertension. These findings consistently show that masked hypertension, whether detected by home BP or ambulatory BP, associated with a higher rate of organ damage and cardiovascular risk compared to the normotension and is similar to sustained hypertension. Moreover, patients with masked hypertension are at significantly increased risk of developing sustained hypertension. The second point is out-of-office BP more accurately predict cardiovascular risk than office blood pressure. As everyone knows that masked hypertension is defined as blood pressure below the hypertension diagnostic threshold in the office, but above the threshold in out-of-office blood pressure setting. The international database on home blood pressure in relation to cardiovascular outcome study showed that home blood pressure showed consistently higher hazard ratio than office blood pressure. In the PIN home study, home measured blood pressure is prognostically superior to office blood pressure. Previous meta-analysis also found that home blood pressure is an important prognostic variable over and above that of office blood pressure. Home blood pressure consistently showed a significantly association with outcomes, whereas office blood pressure did not significantly associated with outcomes. Ambulatory blood pressure also predict cardiovascular outcomes better than office blood pressure. Observational cohort study from the Spanish ambulatory BP registry, ambulatory blood pressure was more informative about the risk of all-cause death and cardiovascular death than clinic measured blood pressure. In recent meta-analysis that compare ambulatory BP, home BP, and office BP show that office blood pressure showed lowest hazard ratio for outcome. Specifically, hazard ratio per 10 mm mercury increased in systolic office BP is 1.30 and systolic home BP is 1.39 and ambulatory BP is 1.44. When comparing each others, home blood pressure and ambulatory blood pressure have similar ability in predicting outcome, and both are superior to office blood pressure. Therefore, guidelines tell us that in addition to accurate diagnosis of hypertension phenotype, ambulatory BP and home BP can also be considered in addition to office blood pressure to improve cardiovascular risk prediction due to better reproducibility and prognostic value than office blood pressure measurement. Given the prognostic importance of out-of-office BP elevation, it seems appropriate to recommend that in patients with compound masked hypertension be managed similarly to those with sustained hypertension. strict lifestyle modification, and close follow-up. In addition, antihypertensive drug treatment may be considered. Guideline recommended treatment initiation or treatment intensification for confirmed masked hypertension or masked uncontrolled hypertension with a low-grade recommendation level. Also in ESH guidelines, blood pressure lowering drug treatment in masked hypertension can be considered in high-risk patients. However, effect of anti-hypertensive treatment are unknown in masked hypertension because no RCT has ever been performed on masked hypertension. Considering the limitation of the available evidence, treatment of titration in masked hypertension only if treatment is well tolerated as not to keep the patient above the recommendation target blood pressure. Antihypertensive treatment in masked hypertension. Until now, no RCT addressed the question whether antihypertensive treatment of masked hypertension entails benefit. Recently published anti-mask trial assessed whether blood pressure lowering treatment per 1 year would improve target organ damage as assessed by BAPWV, urine ACR, and electrocardiographic LVH in patients with masked hypertension. Anti-mask trial was multi-center random placebo-controlled clinical trial. Patients recruited from 5 centers in China. Inclusion criteria were patient aged 30 to 70 years with masked hypertension and had not been treated for hypertension or were off treatment at least 2 weeks. And they had at least one sign of target organ damage. Considering the moderate reproducibility of masked hypertension, the diagnosis was confirmed at 2 screening visits. Exclusion criteria was as following, such as secondary hypertension, liver dysfunction, renal dysfunction, severe cardiovascular and non-cardiovascular diseases. Masked hypertension definition was office blood pressure lower than 140 systolic and 90 for diastolic in the presence of ambulatory hypertension. Ambulatory hypertension threshold was above 130 and 80 for the 24-hour ambulatory blood pressure and over 135 and 85 for the daytime ambulatory hypertension, 120 and 70 for nighttime ambulatory hypertension. Sign of target organ damage included electrocardiographic LVH defined as Sokolov-Lyon index or Cornell product, albumin creatinine ratio of above the reference range, and the arterial stiffness defined as BAPWV of above 1400 centimeter per second. Quality of life was assessed using questionnaire developed by the WHO. Follow-up visit was monthly interval until month 4 and 3 months interval after that. 24 ambulatory BP monitoring was performed at 2 and 12 months and additionally at 4 months per patient who had uncontrolled ambulatory BP. Target organ damage was assessed at 3, 6, 9, and 12 months. Active treatment was initiated with alisartan 80 mg once daily. If the BP remained uncontrolled, alisartan dose doubled at month 2 and amlodipine 2.5 mg once daily added at the 4-month visit. In the control group, matching placebo was used. The primary endpoint was improvement of target organ damage, defined as decrease in BAPWV by above 20% or to less than 1400. ACR reduction by above 20% or to less than reference range, and the normalization of LVH criteria. Secondary outcome included change in ambulatory blood pressure and change in target organ damage and quality of life score. Among 479 patients with masked hypertension, finally 153 in active treatment group and 167 in placebo group was included in the study. Mean age was 54 and 53, and prevalence of diabetes was 3.9 and 4.8. Prevalence of previous antihypertensive treatment was 30.1% and 17.4%. Most patients had increased BAPWV value. In the active treatment group, 37% on elisantan 80 milligram and 21% of patients on elisantan 160 milligram and 42% on patients on elisantan plus amlodipine 2.5 milligram. Baseline blood pressure was similar in both groups. The office and ambulatory BP decreased on treatment group, but not on placebo group. The office and office systolic BP group difference was from 1.0 to minus 9.1, and ambulatory SBP group difference was from minus 0.3 to minus 8.8 millimeter mercury. The prevalence of target organ damage change was more pronounced in the treatment group. The prevalence of LVH change from 5.9% to 2.0 in treatment group and 9.6% to 8.0% in placebo group. Arterial stiffness change from 97.4 to 60.3% in treatment group, 97.6 to 80% in placebo group. There are no between group differences in quality of life score, and adverse events were similar in both groups. The trial concluded that in patients with masked hypertension, active treatment improved target organ damage, and out-of-office BP monitoring is essential for managing suspected masked hypertension, and treatment should be guided by out-of-office blood pressure. BP target in current guideline. In 2017 ACC and 2023 ESH guideline, recommended target blood pressure was less than 130 and 80 in most patients. Also in 2024 ESC guideline, recommended target SBP as 120 to 129. Korean Hypertension guideline also recommended similar blood pressure target, except for lower risk group or elderly patient group. A crucial gap is that no outcome-based ICT has ever used the home BP or ambulatory BP to guide treatment of hypertension. Although home BP and ambulatory BP has been shown to be prognostically more sensitive, no information exists on whether guiding antihypertensive treatment by home BP or ambulatory BP has a greater protective effect, and which are the optimal home BP and ABP target for treatment. Therefore, although there are limitations, currently these targets can be determined using corresponding blood pressure. Considering the corresponding blood pressure for a target of 130 and 80, the target out-of-office blood pressure should be 130 and 80 for home BP monitoring and daytime ambulatory BP monitoring, and 110 and 65 for nighttime ambulatory blood pressure, and 125 and 75 for 24-hour ambulatory blood pressure monitoring. Summary and conclusion. Masked hypertension has a risk similar to that of sustained hypertension. Out-of-office BP has superior prognostic value compared to office blood pressure. Therefore, despite the limited evidence available for the treatment of masked hypertension, it is necessary to treat it with the same blood pressure target as sustained hypertension. Research on out-of-office BP target is also limited, so at present, it is necessary to set target using the corresponding blood pressure of the office blood pressure target. Thank you for your attention.
Thank you very much, Dr. Kim, providing the great summary regarding masked hypertension, as varied very much. And masked hypertension, the risk of population is almost similar to sustained hypertension, and the detailed study explanation of anti-mask trial. And finally, out of blood pressure is, of course, important for us. Thank you very much. So we will call the final speaker of this session, Professor DAY2 Shimbo from the US. Professor Shimbo, his career started at the Mount Sinai Hospital in New York City, and then moved to the Columbia University in New York City. That means he is a genuine New Yorker for 30 years, almost overlapped to the Korean Society of Hypertension history. And he's now a dean of the whole medical departments of the Columbia University. So, DAY2, could you please start your presentation?
Okay, so I'm going to talk about the cost effectiveness of mass hypertension screening and treatment among those suspected to have mass hypertension. There you go. Here's my disclosures. I have funding from the NIH. So what has been carefully described in the prior talks is, obviously we define mass hypertension using out-of-office blood pressure monitoring. And that is a form of what I call true or ecologic blood pressure. And of course, we have two forms, ambulatory and home monitoring. And as all of you are aware, ABPM has typically been recommended as the reference standard, just because there's more evidence supporting its use. And of course, we define mass hypertension as the office blood pressure not being high and out-of-office blood pressure being high. This is from a meta-analysis by Zhang et al. Showing that the adjusted risk ratio for cardiovascular disease events associated with mass hypertension versus sustained normotension is about 1.7 with a confidence interval of 1.42 to 2.02. What's remarkable about these studies is I haven't found a negative study yet about mass hypertension and the association with CVD risk. So the data actually are very strong supporting it as a risk marker. And as I reviewed yesterday, I think the problem is, how are you going to detect it? Because, at least in the US, if we say that it's an important risk predictor, you have to look for it. And in our estimation, using NHANES data, we would have to screen approximately 153 million US adults who don't have high blood pressure and are not taking BP meds. I don't know about you, I don't know how many of you actually worn an ABPM device, but I don't think it's feasible to actually do this population-wide. That is why the American Heart Association and the American College of Cardiology in 2017, in their guidelines, actually recommended a targeted approach. So instead of saying we should screen for all people with a blood pressure less than 140/90 in the office, or in this case, 130/80, because remember that's the 2017 ACC-AHA BP threshold, they recommended just ABPM or home for a specific range of office blood pressure, 120 to 129, and between 75 to 79 for diastolic blood pressure. And in fact, the US actually, based on these guidelines, reimbursement for Medicare was approved for this indication. So I was happy to see that the targeted approach is actually being reimbursed, particularly using ambulatory monitoring to look for mass hypertension. So I don't need to convince you it's important, and I think it's important to detect. I think the issue that Dr. Kim raised is that there actually are scarce RCT event, CVD event data. He already mentioned the anti-mask trial. I'm not going to go into this in any extensive detail, but literally this is the only randomized controlled trial of taking patients with mass hypertension and seeing if treatment of the out-of-office blood pressure, targeting that, actually improves cardiovascular risk. And you can see here along the top, office systolic and office diastolic were better in the active treatment groups versus placebo. The 24-hour blood pressure did improve for systolic and diastolic in the intervention group versus placebo. And then, of course, the outcomes were target organ damage. But we have to be careful. This is not an event study. They didn't look at myocardial infarction, heart failure, mortality, et cetera, et cetera. They just looked at target organ damage measures. So I would love to actually see this replicated and repeated with a bigger sample size to look at cardiovascular disease events. So this talk is about cost effectiveness. So we do have to take a leap of faith, right? Because if treating mass hypertension doesn't improve cardiovascular disease outcomes, why even study its cost effectiveness, right? We wouldn't study it if it didn't improve health. So there is an assumption here, and I'm going to review the data on cost effectiveness, that lowering out-of-office blood pressure actually lowers cardiovascular disease event risk among people without high office blood pressure. I would say that's probably a reasonable assumption. I don't think we need to prove that lowering blood pressure is actually better for health. I think the main issue, and I think a previous speaker talked about this, is what is the target level that you're driving the blood pressure to? I think we don't really know. So in fact, because we don't know, and we don't know really if event risk is reduced, most of the cost effectiveness data is actually based on computer simulation modeling. Now you might ask, what is that? It's literally taking a computer and putting massive inputs. You're basically making educated guesses of what it would look like to screen and treat. And these educated guesses are actually based on prior literature. So really what I'm about to show you is a thought experiment to actually see whether screening and treatment would actually be cost effective. Does that make sense? So the first study is actually by my colleague Anthony Vieira and also Hadi Beghagi, who is from UNC. I think Hadi was a student of Anthony Vieira. Anthony Vieira is now the chairman of Duke in family practice, looked at the cost effectiveness and looked at office blood pressure, home, and then ambulatory. So this is a computer simulation modeling. They looked at a hypothetical cohort of primary care patients who are adults greater than or equal to 21 years of age, and they assumed that they had a cardiovascular risk profile similar to the US population. So they mapped it onto NHANES data using the same age and sex distribution. And you can see what was tested here. If mass hypertension, we're not going to screen for mass hypertension if the blood pressure is high in the office, right? So if the blood pressure is not high, there's 3 approaches you could take. One is do nothing. Keep rescreening every 3 years for individuals 18 to 40, and then every year is greater than or equal to 40, which is actually endorsed by some US guidelines. And just keep doing clinic blood pressure assessments until it becomes high. And there is a rationale for that. I don't know if a previous speaker mentioned this, but do you know that mass hypertension over time can convert into sustained hypertension if you wait long enough? Another approach is just go ahead and do ABPM. Look for it, and if it's high, treat. And if it's not high, just keep doing ABPM periodically until you catch it. And another approach is just to do home monitoring over time. Same approach is that you just repeatedly do it over time, every few years, just to capture someone who has mass hypertension, and then treat it if you find it. In this case, these are the thresholds used in this computer simulation modeling. We used the threshold of 140/90 and the corresponding thresholds for ambulatory and home to define mass hypertension. Now, this is very complex. This is not my area. I'm not a cost-effectiveness person. But all of this computer simulation modeling basically, because remember, we're talking about screening. So you know there are true positives and false positives, true negatives and false negatives for detecting mass hypertension. And then what happens is, if you're wrong or right, you know, people have cardiovascular disease events, MI, unstable angina, stroke, and TIA. And you can see here that people actually move between different categories because you can have an MI. After the MI, you can go on to dying. After the MI, you could go on to have stable angina. You could have a stroke. And you can see, you can actually estimate how many people are moving between different categories. And actually, there's actually a category for people dropping dead without having cardiovascular disease events, a non-fatal event. So here are the inputs. They looked at literature trying to determine what's the prevalence in the US for having hypertension. These analyses assume ABPM is the reference standard. So if ABPM is the reference standard, you know that the sensitivity and specificity are going to be 100%. And they determined sensitivity of clinic blood pressure, specificity of clinic blood pressure, and also for home based on prior literature. They made assumptions about if you start someone on a drug, how much does it lower CHD risk and how much does it lower stroke? These are based on prior randomized trials. Remember, there are no randomized trials of mass hypertension for CVD events. And then we talked about transitions. This is the probability of just dying, dropping dead. And you can see dropping dead after multiple non-fatal events. They actually pulled this from multiple US life tables in the prior literature. We looked at different transitions if you're normotensive, hypertensive, and so forth, and the risk of stroke. And then they also looked at that what is the population distribution for CHD? You can see here. And then what's the population distribution for stroke? They looked at quality of life and looked at what is the US quality of life for a healthy population. It's funny, the quality of life is 0 for someone that dies because they can't enjoy their life, and they put that in. And then these are the quality of life indicators after you have a non-fatal event. Obviously, your quality of life goes down if you have a cardiovascular disease and you're living with it. And then quality of life actually goes down if you're taking BP meds. And that's what I was surprised to see in anti-mask. The quality of life actually didn't change. But in reality, I think everyone knows that if you're on BP meds, you're likely to actually have a lower quality of life. I'm just going to quickly go through this. They had assumptions about, it's doctors' time to measure clinic blood pressure. It actually costs money to do home. It costs money to do ambulatory. You have to pay for the devices. You have to pay for nurses' time. And then you can see all of the costs associated with treatment, having any event, if you go to the hospital and get a stroke or MI, these are actually pulled from prior data. And then what's the maintenance cost? Like if you have a heart attack, now you're going on 4 or 5 different medications, right? And then you're having multiple office visits after that. So this is a thought experiment, but I laugh. It's kind of an educated guess based on prior literature. So here are the results. As it turns out, for both men and women, up to the age of 80 for both women and men, ABPM wins out. That's actually the most cost-effective strategy. So it means that if you don't have high office blood pressure, you should just immediately go to ambulatory, and you should do that periodically. And there was one case that older 80, clinic blood pressure actually won out. Home did not. And in these computer simulation models, you can make little adjustments. What if we change the diagnostic accuracy of home? What if we change the diagnostic accuracy of ABPM? What if we look at ABPM failure rates? Let's adjust these. And you can see that mostly if you do some adjustments, that it's mostly ambulatory. Sometimes clinic blood pressure wins out. But I do want to highlight the fact that, remember, we're making the assumption that ambulatory is the reference standard. It has a perfect sensitivity and perfect specificity. As it turns out that if you set home to a perfect specificity, home actually wins out, ironically. So it just really depends on what you're saying is the gold standard. They changed the ABPM failure rate. Remember, ABPM fails. Sometimes you can't get enough readings. Sometimes the device fails. And they set different prevalences, different costs, and basically everything won out except for what happens if you have no side effects and no lower quality of life on antihypertensive medication. It turns out that home wins. So this is basically just saying, for the most part, ABPM is the winner. There's some times that office wins out, and there are actually some times that home wins out. But ABPM is definitely the winner. So computer simulation modeling has a lot of assumptions. This assumes that treating mass hypertension lowers cardiovascular events. I think, Dr. Kim, you reviewed sustained hypertension and mass hypertension have the similar risk. And this analysis made that assumption as well. One thing is this study didn't look at potential side effects and adverse events that are associated with being on a lot of drugs. There is only one other study. My colleagues and I looked at the cost effectiveness, but now we did some different changes here, which I'm going to go over. So this model, we used NHANES 1999 to 2014 data. We merged it. I mean, this is pretty ambitious. We merged it with data from the National Heart and Lung and Blood Institute's pooled cohort study. This is a massive study combining Framingham, MESA, Cardia, all these studies together, and looked at cardiovascular disease risk. They also looked at that AHA category that you should be screening, right? And they looked at 20 years and older, no CVD, and they were not on BP meds. And they did 100,000 simulations to detect what would happen for cost effectiveness. They looked at 3 approaches. One approach is usual care. You just keep doing office blood pressure measurement. If it's high, you repeat it. And if it's high again, you should start treatment. But any time that it's low, you should just keep repeating it over time to monitor for the occurrence of blood pressure elevation in the clinic, right? Just like Vieira's study. And then 2 other approaches were taken. They still continue with the screening with clinic blood pressure, but now in one arm doing ambulatory and treating if it's greater than or equal to 130/80, the AHA threshold, and doing nothing and just rescreening, and then doing the same for home. Okay, so we're trying to put the best of the best in diagnostic approach. Same thing, Lee Goldman is a very famous cardiologist. He is my prior dean at Columbia. He came up with the CHD policy model. It's the same thing. Remember that very complicated figure of people moving between categories? This is basically a simplified approach, and it's been well validated in the literature for cost effectiveness. So here are the assumptions. This study also assumed ABPM had perfect sensitivity and specificity, and then home, and you can see what the home sensitivity and specificity were. They were based on prior literature, and you can see here they did sensitivity analysis. They made adjustments to see what would happen. For out-of-office screening for ABPM or home, this is how often they screened in their simulation model. Every 3 years if you're less than 40. So can you imagine getting an ABPM every 3 years? And then if you're older than 40, you should do ABPM every year or home every single year. And they made adjustments to sensitivity analysis. And they used a systematic review to look at what is the CVD event risk associated with mass hypertension. That's what I showed you in my second slide. They looked at costs of patient costs, device costs. One thing you should see here, I don't know if we do this in Korea, but some clinics in the US actually do loaners. So one home device you send with one patient, they bring it back, you clean it, and then send it to another patient. So in this analysis, we assumed one device per person, but they also did a sensitivity analysis where they actually reused it for 52 people. They looked at a failure rate of 5%, replacing the device, either home or ambulatory, every 5 years. And then you can see what the quality of life adjustments they took, and they based that on the literature. If you're taking a lot of pills, your quality of life goes down. They also looked at medication adverse events, and they looked at intolerable, and serious. And then they actually, you know that if you take a lot of BP meds, you could actually get renal failure, or you could die. So they actually looked at this, and they based this on prior literature. So here are the results. Usual care plus ABPM, and usual care plus home. Basically, your CVD event risk goes down compared to usual care for either ABPM or home. Makes sense, right? You're treating the thing that's causing increased risk. You would assume that CVD event risk goes down. It doesn't change mortality, but unfortunately, there's more serious adverse events where people are actually taking drugs. Because remember, these are people with normal office blood pressure. They're actually getting serious adverse events because of being on BP meds, regardless of whether you are in the home arm or ambulatory. Here are the primary results. Cost effectiveness in this study was defined based on less than 50,000 of an ICER, which is incremental cost effectiveness ratio, divided by the quality of life years gained. You can see it's highly cost effective if it's less than 50, and then 50 to 150. Actually, ambulatory actually won as the most cost effective approach, and home did not. It's actually inferior to clinic blood pressure for cost effectiveness. You'll see why. Oh. Just a second. I don't know why it's not advancing. Huh. There we go. This is just a slide to show you that, as you hit 50,000, office, usual care is screening with office blood pressure is cost effectiveness, but after you pass about 85,000, it's actually cost effective for ambulatory. Do you see that? And then home is the orange line along the bottom. It's never cost effective to do home monitoring to screen for mass and treat mass hypertension. Sorry, folks, these slides are just getting stuck. Okay, so you might ask, why did home do so poorly? Didn't it decrease event risk? It's because, do you see that the event risk cost goes down in home, but do you see that you're putting people on more drugs? Drugs cost money, and if you have adverse events like getting renal failure or being hospitalized, do you see that that costs money as well? So actually, ironically, home is good. It lowers CVD risk, but you actually have treatment-related problems. Sorry, folks, I don't know why it's getting stuck. I'm just going to skip this just for a second. They did some sensitivity analyses, and you can see here, the top one is, remember that clinic? You're giving it to 52 people? And actually, you know that home devices are not reimbursed in the US. Made no difference. Actually, if you share home devices, ambulatory still wins, and it's inferior to usual care. And what's interestingly is if you set home as the gold standard, you can see actually home wins. So it's very sensitive to saying which one is the best. And then lastly, if you say that the sensitivity and specificity of ABPM is inferior and similar to home, it's actually usual care wins the day. Sorry, folks. So again, simulation models with many assumptions. It made the assumption that treating mass hypertension actually improves CVD risk. And remember, these people have normal office blood pressure, so lowering it actually produced a much smaller effect on CVD risk because you have nowhere to go if it's already normal. I'm sorry, folks. The other thing is, I didn't say this in that latter analysis, we used proof BP to estimate what the ambulatory was. We didn't look at heart failure, and we didn't look at specific racial and ethnic groups in the US. So finally, compared to sustained normotension, I think it's pretty obvious that mass hypertension is bad. And there are scarce data on whether treating mass hypertension improves cardiovascular disease risk. It looks like, based on simulation models, out-of-office BP monitoring appears the most cost-effective. You should just immediately do it. ABPM may be better than home, but it actually depends whether you say ABPM is the reference standard or not. Thank you, that's it. Sorry for the technical difficulties.
Thank you very much. Yeah, thank you very much. Now we have panel discussion. So we have three panelists: Jiyeon Kim, Dongguk University, Hemi Kim, Jungwon University, and Chanju Ri, Yonsei University. Please start, panelists.
Yeah, I'm Jiyeon Kim from Dongguk University. I have a question to Dr. An and Dr. Bae. The same question. Yeah. I thank you for your nice lecture, and I learned a lot of masked untreated, uncontrolled hypertension and masked untreated hypertension. Yeah. Should we consider ABPM to rule out and detect the presence of masked uncontrolled hypertension, especially men and diabetes or CKD patient? Yeah. Should we reconsider and repeat ABPM to detect that?
Thank you for your comment. So ABPM is most important in the detect the mask hypertension or much mask uncontrolled hypertension. But I already showed the slide. Then the ABPM is most disassociated is the skin problem, and most of the women hate the ABPM again. So this is the big challenge. So and the home BP monitoring is also very important, but some patient is very challenging because it is very busy day, and ABP home BP monitoring also had some time to check the BP about 1 or 2 minutes, but most patients have all patient a busy day, so most 10% or maybe 5% only have the BP log checked. So this is very big challenge. So I think the next future, the coupled BP monitor is more important in the masked hypertension or much patient. I think that. Thank you very much.
Thank you.
I think that's a very good and difficult question. So, ABPM data is scarce. So, I don't know, and everyone don't know. But today, Dr. Shimbo's lecture can be answered that your question. I heard very impressively Shimbo's lectures, and ABPM's future is like very light, I think. Yeah.
Thank you for your great lecture. I'm Hemi Kim from Chungang University Hospital. I want to ask Dr. Shimbo. Thank you for your great lecture. And according to your presentation, ABPM is the most cost-effective for the detecting masked hypertension. So I want to just ask your personal opinion. When if we're treating the masked hypertension patient, do you think still repeated ABPM monitoring for when we adjust antihypertensive medication or in that situation? And so is it still cost effectiveness, do you think? Or we should use home BP monitoring or other things?
Yeah, that's a great question. So remember, in these analyses, these studies made the assumption that ABPM is the gold standard, perfect diagnostic accuracy, okay? Does it surprise you that actually that's the most cost effectiveness if it's the perfect diagnostic strategy? And so you remember that both studies, it's sensitive to, if you actually make home the reference standard, home actually becomes the most cost effective in this approach. So it all comes down to, do you believe ambulatory is a reference standard? Okay, I have trouble with that because why is ABPM a reference standard? It's because it's just been studied more. It doesn't mean it's better than home. It's actually just been studied more. And I don't know if that's a good reason to say ABPM is the best. Now getting to your question, in these analyses, ABPM was done every 3 to 5 years, right? To look for masked. But they didn't really talk about what happens is if you get masked hypertension, you're treating, how do you follow them? Are you going to be doing ABPM once a month? I just don't think that's possible. So in reality, I think the practical approach is probably ABPM for initial diagnosis. But if you're going to treat, it just makes sense that home should be used to treat, with the possibility that you're going to increase adverse events and lower quality of life because they're going to be on more medications, which is what I showed in the second study. Does that make sense?
Thank you.
Thank you for all lecturers, and I'm really impressed with the lectures. I have one comment to the Dr. Simbo's lecture, and I have one question to the Dr. Kim, Byung-ji Kim. In Korea, the medical cost for ABPM is just $20.
Oh.
So it's very cheap. So in that case, how about the cost effectiveness of ABPM? And I think it may be great cost effectiveness for the patient and national economy, but not for the doctor's own profit. So I think it's a very different situation, Korea from the US. So do you have any idea about that?
Yeah, I have a comment. So I didn't show it because I didn't have time. But remember these computer simulation modeling, we made little adjustments to assumptions. And it turns out if you made ABPM cheaper, ABPM still wins. And that makes sense, right? It's cheaper and it's better. I think the problem in the US, and I have no idea what it's like here, but people are just not doing it in the US. It's like specialized centers that have to do it. And if the primary, hypertension is mostly treated by primary care doctors. They typically in the US don't have access to an ABPM device. So I think the problem is implementation in the US. It's nice to say ABPM is a reference standard, but no one's doing it anyway in the United States. I think that's the bigger problem. I don't know if you had
Then I have a question to the Dr. Kim. So in your lecture, you told us the target BP and the treatment option for the masked hypertension. So, but the patient who have patient with masked uncontrolled hypertension or masked hypertension, who is likely to be male or smoker or tend to have mental stress or have insomnia. So did you have any idea about the behavioral change or the antipsychotic medication for treatment for masked hypertension instead of antihypertensive medication?
Yeah, thank you for your very important question. As everybody knows that when we meet the patient, blood pressure in office is usually high, but some patients tell us that home blood pressure is uncontrolled, but office blood pressure is controlled. So these patients are masked hypertension, and this condition is well appeared in situation that you told, like very high stressful usual days, like office or more other situation. It is not exactly tell, but it seems very good approach to control their stressful event or sleep control. When after then their home blood pressure or ambulatory blood pressure is normalized, it can be very wonderful situation to without prescribed drug, and then they under control office and out of office blood control. So I agree with the treating other than blood pressure, like stress prevent is very good approach. Thank you.
Are there any questions? Oh, from audience, yeah, right.
Thank you for the beautiful lectures for all presenters. My name is Wang-Ki Kim. I'm a cardiac surgeon. I worked in the tertiary center, but now I moved on to the corporation, developing the AI-based telemedicine program to connect the patient and the doctors. So maybe I have same goals for same as the goals from all the professors, that I want to collect and detect the masked hypertension during the follow-up. So maybe I should develop my IT technology more and improve my AI something. But but for the clinicians, maybe face-to-face technology would be important. So Professor Bae, do you have any your personal specific skills, especially for the out of control patient? We just call it Malik in Korea.
Thank you for your comment. As about the remote clinic measurement of BP pressure is very important. So the urban country and another region is very hard to contact the clinic. So in the future, next technology is important to check the BP pressure measurement, but the BP pressure is the result is buried in, and the data was so much, so we must to interpret this report summarized. So it's important to make the result summary in such as machine learning or large language model. So this is important technology. So I think it's more develop the technology period in this period. I think that.
No, I just mean, do you have any special skills in the conversation? Because I know you are the most kind people, as I know.
I already has only idea. So that's all. Thank you very much.
Yeah, Professor Ray, please.
Thank you. I'm Lee from Korea, Dongguk University. For the concept of master hypertension, we have to invite Professor Parati, but unfortunately he is not here. And I think the concept of master hypertension is now evolving, because after changing the target threshold of hypertension treatment, we have to change the concept of master uncontrolled hypertension, lowering the target office and ambulatory blood pressure. It may cause different prevalence and different characteristics of master hypertension patient. And another point is that in my data analysis, I'm preparing the manuscript. The diagnostic threshold of home blood pressure is a little high. So if we lower diagnostic threshold, as Brazilians did, to 130/80 millimeter mercury, and Taiwan also reduced the home BP threshold to 130/80 millimeter mercury. If we reduce home BP threshold, I found that we can reduce the prevalence of master and sustained hypertension in the intermediate zone. That was referenced by ambulatory blood pressure. So you published in JACT based on the utility of home blood pressure measurement. I think if we reduce diagnostic threshold of home blood pressure, diagnostic threshold, or treatment threshold, we can change the concept of master hypertension, and we will have many things to do in the future. It's my opinion. Thank you.
Okay, thank you very much for the very active discussions. And now the session is almost closing. For your information, in Japan, the national government statistics says that the ABPM reimbursement, the number of reimbursement of ABPM is decreasing, has been decreasing for more than 5 years. That is not a good situation. Of course, the vast majority prefers to use home blood pressure measurement, but of course, according to the Dr. Shimbo's presentation, we should apply for more ambulatory blood pressure monitoring in population. Of course, the recent advanced technology will enable us to apply ABPM much more easily in the near future. But anyway, so thank you very much for attending this session, and enjoy the rest session in the conference. Thank you.
Thank you very much. Professor Simbo, please come up, Simbo. Please come up to the stage one more time for Operation Block.
Daichi Shinbu, in deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024, in conjunction with the 64th Scientific Meeting of the KSH, November 9th, 2024.
So Good afternoon, everybody. This session is lunch session sponsored by Hanmi Farmers. So, I'm Byung-Yeol Jo from Gangwon National University, Korea. We prepared two topics related to Amazon family and Cabediro SR. So, I introduce the first topic. The title of the first topic is Optimal Comorbidity Management for Cardiovascular Protection in Hypertensive Patients with Dyslipidemia. The speaker is Dae Kim from Ulsan University, Korea. I would like to introduce Professor Dae Kim, Korea. Professor Kim graduated from Seoul National University and received his bachelor's, master's, and doctoral degrees from the same university. He also completed his internship, residency, and fellowship at Seoul National University Hospital and worked as research fellow at Harvard Medical School and MGH. Professor Kim's academic activity included Director of Education at Korean Society of Echocardiography, Director of Public Relations at Korean Society of Hypertension, Director of Policy at Korean Pulmonary Hypertension, and scientific community members at the Korean Society of Cardiology. He is currently working as an associate professor in the Department of Cardiology at the University of Ulsan College of Medicine. Dr. Kim, please.
Yeah, thank you, Professor. Good afternoon, ladies and gentlemen. It's my great pleasure to present this topic in luncheon-sponsored symposium by Hanmi Pharmaceutical Company. The title is Optimal Comorbidity Management for CV Protection in Hypertensive Patients with Dyslipidemia. According to the Korean hypertension fact sheet, the number of patients with hypertension continue to increase, especially one with comorbid disease. In this patient group, as you can see here, the patient with dyslipidemia was most frequent in these patients, almost 40%. The 61% of patients with hypertension also have dyslipidemia, and conversely, 63% of patients with dyslipidemia also have hypertension. How's the mechanism of this patient? The common mechanism has been shared: LAX activation, increased oxidative stress, or pro-inflammatory activity increase, cause endocellular dysfunction. These all mechanisms all lead to atherosclerosis. The problem is we call lipid tension because this axis shows the systolic blood pressure. This axis shows the levels of cholesterol. But the increase in both ways are like this. The probability of coronary heart disease exponentially increased. Conversely, 10% reduction in blood pressure, 10% reduction in total cholesterol level, there was no additive benefit rather than, but the benefit of cardiovascular disease reduction is 45% in this patient. So comorbidity management is very important according to the slide. So, Korean Society of Hypertension guideline and European latest guideline recommend the administration of statin is recommended in hypertensive patients with moderate to high risk. It reduces the occurrence of the cardiovascular events, recommend as a class 1 indication and also class 1 indication in European guidelines. But so, how to manage the patient with hyperlipidemia? Looking at the meta-regression analysis from various clinical trials, we found that regarding the cholesterol level, especially LDL cholesterol, the lower, the better for secondary prevention or primary prevention. So various guidelines are available in Europe, American guideline, 2019 European guideline and 2022 Korean guideline and American Diabetes Association guideline are last year published. The common things, as you can see, for secondary prevention established atherosclerotic cardiovascular disease, the cholesterol level should be lowered below 55 milligram per deciliter, and more than 50% of LDL cholesterol reduction was recommended. In patients with high risk or DM, and the LDL cholesterol level should be lowered below 70 milligram per deciliter for all guidelines. Looking at the Korean guideline, patients with coronary disease, LDL cholesterol should be lowered below 55 milligram per deciliter. Moderate atherosclerotic disease, ischemic stroke, TIA, or carotid artery disease, aortic aneurysm, or peripheral artery disease, the LDL cholesterol level should be lowered below 70 milligram per deciliter. The problem is there is statin, we know pitavastatin, atorvastatin, simvastatin, rosuvastatin. 2 milligram, 10 milligram, 20 milligram, 5 milligram is the initial dosage of each statin. The problem, when we target achieve the LDL below 70 milligram per deciliter, in pitavastatin, only 8%, 9%, and 22%, and 31% achieve the goal below 70 milligram per deciliter. This is the big problem. The most common problem is statin. The statin dose response curve is very flat, like ARB. After doubling of the dosage of statin, after a second doubling and third doubling, the triple step titration, only 5 or 6% of LDL cholesterol reduction from the before dosage. So triple doubling of statin dosage, only 15 or 80% of LDL cholesterol reduction can be achieved. However, just adding on the other drug, such as additive 10 milligram, one-step coordination and additive 10 milligram can achieve the additional 18% of LDL cholesterol reduction. This is the different stage from the statin doubling in this diagram. According to Korean guidelines, so 2018, revised in 2022, the recommendation of ezetimibe combination was a class 2A indication, but the indication was upgraded to class 1 indication in 2002 Korean lipid management guideline. When you use the rosuvastatin plus ezetimibe combination, as you know, the rosuvastatin is the high-intensity statin, lowering cholesterol level of more than 50% from the baseline. When you combination of 20 milligram rosuvastatin plus ezetimibe, you can achieve the 63% of LDL cholesterol reduction from the baseline, very powerful effect. The target achieve rate from each dosage of rosuvastatin, rosuva 5, rosuva 10, rosuva 20, and then ezetimibe combination. When we use rosuvastatin 20 milligram plus ezetimibe 10 milligram combination, less than 70 milligram of cholesterol level below achieved at 81%. More than 50% of LDL cholesterol reduction achieved at the rate of 91%. Both together as a 93% achievement rate when you use rosuva 20 milligram plus ezetimibe 10 combination. This is the study from our Korean investigator, Racing, published in Lancet 2020. The investigator compared the moderate intensity statin with ezetimibe combination versus high-intensity statin monotreatment. This study funded by Hanmi Pharmaceutical Company. They compared almost 1,900 patients with moderate intensity statin ezetimibe with high-intensity monotreatment. Already have adult atherosclerotic disease was established patient. The rate of MI almost 40%. The previous percutaneous intervention rate almost 66%. In this patient group, comparing to moderate intensity statin plus ezetimibe versus high intensity statin monotreatment, there was no significant difference on all endpoints. So regarding the hard endpoint, two treatment strategy with especially moderate intensity statin with additive combination, that inferior to high intensity statin strategy. So let's move to how to manage a patient with hypertension after repeat management. According to 2023 ESH guideline, very similar with the previous European guideline. First step, the combination with a single pill, lacimid plus CCB. Lacimid plus diuretics has been recommended. But the problem is, which one is better, especially in patients with high risk of cardiovascular disease? In a complete trial published in New England Journal of Medicine 2008, the lacimid plus CCB combination is superior to lacimid plus hydrochloride combination. So, in other aspects, in patients in high risk group, lacimid plus CCB is better than lacimid plus diuretics, especially in patients with the stiffness type. So this is our latest Korean hypertension fact sheet reported this year. As monotherapy treatment, the ALB is most commonly used in South Korea. In contrast, the use of AC inhibitors is below 1%. Very extreme use of ALB is our unique condition, especially in South Korea. How about the dual combination? The last ALB plus CCB is almost 70% used. After that, ALB plus diuretics used as 17% of patients. The difference between two combination groups is increasing. So why we use Losartan for as a first-line ALB in Korean market share data? As you can see here, the Losartan is the most commonly used, highest market share among other ARBs. The advantage of Losartan is they has evidence regarding a patient with hypertension, heart failure, and diabetic nephropathy, prevention of stroke, etc. So the evidence and indication can be a most important factor to we choose which ALB we have to use. According to the DAY2 study comparing the captopril ACE inhibitor and the Losartan ALB, as you can see here, the withdrawal for adverse event effect, the rate was significantly lower in patients taking Losartan as compared with captopril. This is another landmark trial with Losartan. The study name is RENAL study. Patient with 1,500 hypertensive patients with type 2 diabetes and nephropathy. As you can see, the one arm is active arm is Losartan, increased 10 milligram, and another group is placebo control. The primary endpoint composite of doubling of serum creatinine, establishment of ESRD, and death. Primary endpoint was lowered significantly 16% in a Losartan treated group. The most important thing of this RENAL study, this benefit of RENAL outcome more pronounced, especially in Asian patients. All ethnic group, 16% of decrease, but in Asian people, 35% of decrease in primary outcome. Another study is a LIFE study. LIFE study is published in 2002 Lancet, a landmark trial of Losartan compared with ALB Losartan versus beta-blocker the primary endpoint was lower in patients treated Losartan, mainly driven by stroke reduction, as you can see here. 25 of stroke reduction observed in patients treated Losartan. Remarkably, the new onset diabetes was lower in patients treated with Losartan as compared with beta-blocker atenolol. The unique feature of Losartan was like this. In liver, they converted into active metabolite EXP3179 and EXP3174. EXP3174 is, as you know, the typical AT1 receptor antagonist. EXP3179 is another active metabolite doing various pleiotropic effects like this. So the losartan beneficial effect as some pleiotropic effects, especially favorable effect in lipid profile like this. LDL cholesterol reduction or TG reduction like this. But let me show the case-centralized study performed by Korean investigators, especially members of Korean Society of Hypertension. They compared the losartan plus CCB amlodipine and losartan plus hydrochloride like this. The result was there was no difference between two groups regarding office BP, but regarding the 24-hour ambulatory BP data, there was a significant difference of 24-hour ambulatory BP, 24-hour central BP. In central BP measurement, patients treated with losartan plus amlodipine, as compared with losartan plus high-sized group, there was a significant difference in pulse wave velocity in CCB and ARB group. As you know, the pulse wave velocity increase as 1 meter per second increase, CV mortalis increase 15%. Let's looking at how to improve the adherence with two regimens. This data from factor sheet in Korea, the control rate of hypertension of the 56 last year, 58 this year, slightly improving. But regarding the hypercholesterolemia, control rate is only 47% in South Korea. How we can improve this control rate of both important diseases? But the patient taking polypharmacy, definition of polypharmacy in this diagram equal to greater 6 medications. In patients with hypertension, 21% with polypharmacy. In hyperlipidemia, 13% with polypharmacy. According to the ISD guideline, recommend one, reducing polypharmacy, use of a single pill combination is most important. Secondly, once daily dosing over multiple times per day is very important. Single pill and once daily regimen is very important factors to improve adherence in this patient group. When single pill was used, the adherence was on almost 55%. When 2 pills used, adherence decreased up to 40%. When we use 3 pills, the adherence rate decreased 32%. So in patients with a fixed dose combination, a single pill, there was remarkable difference in adherence rate. So it makes result in the difference in systolic BP, LDL cholesterol level. According to the meta-analysis with the polypill technology, as you can see, the CV outcome benefit as a primary composite endpoint decreased by 38%, CV death 35%, stroke 41%, MIs 48%, revascularization rate 46% decrease. This is the data published in 2 years New England Journal of Medicine. Fixed dose combination drug for comorbid condition are also effective in the secondary prevention of cardiovascular disease. At 24 months, patients are taking polypill. The adherence rate is 74%. However, patients are taking usual care was adherence rate are only 63%. So cardiovascular death, non-fatal MI, non-fatal stroke at 3 years as a secondary outcome, significantly decreased in treated polypill up to 30% of risk decrease according to this diagram. So I'm going to final talk of my today. The lower, the less, the better. In the between the lower, the better, 2 words are inserted, the less. The less means that we have to use the single pill. The third generation single pill from Hanmi Pharmaceutical Company, amlodipine Q tablet, the CCB amlodipine, ARB losartan, and statin is rosuvastatin. Fourth generation single pill released from Hanmi Pharmaceutical Company. The name is amlodipine XQ. Amlodipine, losartan, rosuvastatin, ezetimibe, 4 pill combinations. But according to the data, amlodipine Q, amlodipine XQ, with a combination of losartan plus amlodipine, systolic BP lowering effect was up to 17 millimeter mercury, diastolic BP up to 9.5 millimeter mercury. The LDL cholesterol lowering effect on amlodipine Q, rosuvastatin only up to 48% reduction from the baseline of LDL cholesterol level. When ezetimibe combination was added, up to 59% decrease from the baseline of LDL cholesterol level. But looking at the real photo of these single pill combination, there are many options to dosage. Amlodipine 5 milligram fixed, losartan 50, 100, and something. And for rosuvastatin, 10 milligram, and for 10 milligram and 20 milligram. For rosuvastatin, 5, 10, 20, and 10 milligram as a combination are available in current market. So combination of clinical data from amlodipine XQ phase 3 clinical trial, systolic BP reduction up to 16 millimeter mercury, LDL cholesterol reduction up to 60%. Yeah. So the product of PK profile, the similarity of the both fixed dose combination and losartan combination, they measured AUC value and the Cmax very close to 1, and very bioequivalence of the fixed dose combination. Let me summarize of my talk of today. Hypertension and dyslipidemia frequently occur together, a major cause of atherosclerotic disease. Regarding lipid management, all guidelines recommended should below 55 milligram per deciliter in patients with established other cardiovascular disease for secondary prevention. For high-risk group, for primary prevention, 70 milligram per deciliter was recommended to reduce the cardiovascular disease. For hypertension management, in our country, especially ARB is most commonly used anti-hypertensive medication. ARB plus CCB is the most commonly used, almost 70% of patients. To improve the adherence, the single pill combination is very important. So I was introduced the amlodipine family, amlodipine, amlodipine XQ, amlodipine X. Thank you for your attention.
Thank you very much, Dr. Kim, for nice presentation, including the comorbidities property management, and especially introduce the amlodipine family, detailed introduction. In order to prevent the cardiovascular disease in hypertension and dyslipidemia, comorbid disease, is a very important thing. Very important to keep the blood pressure control and the LDL cholesterol level below the target, and also to keep the high adherence. So in this case, so single pill combination is a good choice for comorbid disease. So I introduce the second topic. The title of second topic is the role of carvedilol in beta blocker. The speaker is Dok Hyun-jang from Bucheon Sejong Hospital, Korea. Let me introduce Dr. Dok Hyun-jang. Dok Hyun-jang graduated from Chungnam National University and received his master's and doctoral degrees from Korea University. He also completed his residency at Bucheon Sejong Hospital and completed his clinical instructor at the Department of Cardiology at Korea University Anam Hospital. Dr. Dang's academic activity, including being a full member at the Korean Association of Internal Medicine, full member at the Korean Society of Cardiology, at the Korean Society of Interventional Cardiology. He currently works as the clinical director of the Department of Cardiology at the Bucheon Sejong Hospital. Please, Dr. Jang.
Thank you for introduction, Chairman. Today, I will talk about the role of carvedilol in beta blocker. Arrhythmia is heart electrical impulses are not properly generated or transmitted. It was caused several causes, including coronary artery disease and heart attack, cardiomyopathy, heart valve disease, congenital heart disease, and heart rhythm abnormality. Prevalence of atrial fibrillation over 5 years. Atrial fibrillation patient increased by 10.30%, and the medical reimbursement is increased by 21.6%. Prevalence of atrial fibrillation is expected to continue to increase with the population aging. This paragraph is EU 2060 to 2060 AF population projection. As increased patients age, AF prevalence will increase. Atrial fibrillation, ventricular arrhythmia, patient visit hospital, we should check echocardiography for assessment, diagnosis, and prognosis and management. Diagnosis of atrial fibrillation is confirmed by typical atrial fibrillation pattern on ECG. Generally, atrial fibrillation lasting at least 30 seconds is diagnostically significant, and atrial fibrillation may have symptom or not. Undiagnosed asymptomatic atrial fibrillation is common, and as a result, the first symptom in patient diagnosed with atrial fibrillation may be ischemic stroke or death. This is a classification of atrial fibrillation. It depends on duration of arrhythmia. This is 2020 ESC management guideline of atrial fibrillation, CC2ABC. Treatment AF is ABC pathway. A means anticoagulation, avoid stroke. B is better symptom control, including rate control and rhythm control. C is comorbidity and cardiovascular risk factor management. This is a 2021 Korean Heart Rhythm Society recommendation of acute heart rate control of AF. In patients with low LVEF less than 40% and sign of congestive heart failure, recommended use of smallest dose of beta blocker to achieve rate control. In patients with more than LVEF 40%, using recommended beta blocker or diltiazem or verapamil. In case of long-term heart rate control, it's the same as acute rate control. This is a 2020 ESC guideline, choice of rate control drug in AF. It depends on the comorbidity. In patients with known or hypertension or HFpEF patient, a recommendation is the beta blocker or diltiazem or verapamil. In case of patient with heart failure with reduced EF, first-line treatment is beta blocker. In case of patient with severe COPD or asthma, recommendation of calcium channel blocker. This paragraph is benefit of beta blocker in patient with sinus rhythm. This Kaplan-Meier curve showed the mortality reduction effect of beta blocker in patient with sinus rhythm of heart failure. This Kaplan-Meier event curve showed the CV hospital admission reduction in using of beta blocker. This paragraph is mortality benefit of beta blocker in Korean AF patient. Blue line is beta blocker, and green line is CCB, and the red line is digoxin, and the black line is control group. As you can see, in patient with heart failure, beta blocker hazard ratio is 0.52, and adjusted hazard ratio is 0.63. This graph is the anti-fibrillatory effect of beta blocker, inhibition of ventricular fibrillation by anti-ischemic, by anti-adrenergic, and inhibition of calcium channel to transient, so it prevents beta ventricular fibrillation. And this is the role of beta receptor in adrenergic activation. adrenergic receptor is divided 3 receptor, beta 1, beta 2, alpha 1 block, alpha 1 receptor, and only carvedilol blocked 3 receptor, beta 1, beta 2, alpha 1, and the other beta blocker blocked only beta 1 blocker. This is a management ventricular arrhythmia 2022 ESC guideline. This graph shows the molecular structure of carvedilol, and carvedilol have a unique anti-SOICR effect on carvedilol, so direct inhibiting effect of RYR2 receptor. When heart damage occurs, beta 1 receptor are relatively reduced 70 to 50, and the beta 2 and the alpha 1 receptor relatively increased 20 to 25, 10 to 25. So other beta blocker block the only beta 1 receptor, but carvedilol block the beta 1, beta 2, and alpha 1 receptor. So it increased the anti-remodeling effect. So many studies show the effect strong point of carvedilol. This study is a Capricorn study to evaluate the anti-arrhythmic effect of the addition of carvedilol to modern treatment of post-MI patient with LV dysfunction. Population is 1959 patients with acute MI and proven LV dysfunction, ejection fraction less than 40%. 98% of whom were treated with ACE inhibitor, and the reperfusion therapy was applied in 46 patients of all patients. A significant reduction in the incidence of arterial arrhythmia, fibrillation, and flutter in post-AMI patients, and showed strong prevention effect of ventricular arrhythmia in post-AMI patients in carvedilol group, and also showed preventive effect of supraventricular arrhythmia. This is a MADIT CRT study. This study showed reduced the incidence of ventricular arrhythmia in post-AMI patient and inappropriate treatment of AF in patient with cardiovascular defibrillator. This is a meta-analysis of post-operative AF comparing with carvedilol and control group. Relative risk is 0.49, and when comparing metoprolol, relative risk is 0.51. This paragraph is the effect on premature ventricular complex. This diagram is before using beta blocker, and this diagram is after using carvedilol treatment. It showed significant reduction of the PVC burden, and this diagram is effect of carvedilol on suppressing PVC according to dose. The role of carvedilol in heart failure patient. This paragraph is a Capricorn echo sub-study. It showed change in LV end systolic volume, LV end diastolic volume, LV stroke volume, and LVF at 6 months after treatment. So comparing with the placebo group, LV end systolic volume is decreased, and LV stroke volume is increased, and LVEF is increased comparing at placebo group. This is a US carvedilol study. When administering carvedilol, the risk of death is reduced by 65% compared to placebo. This is a Copernicus study. Adding carvedilol to standard treatment reduced the mortality by 35% in patients with severe heart failure. Severe heart failure means LVEF less than 25%. This is a satellite study, and when administering carvedilol, NYHA class and heart failure symptom significantly improved. This study is optimized HF. Carvedilol used at discharge reduce mortality and rehospitalization in the 2-3 months immediately following discharge when the risk of disease exacerbation is high. Effect of it also caused the effect of HFpEF patient, and the carvedilol reduce mortality even in patient with HFpEF patient. Long-term use of carvedilol in HFpEF patient improved the ejection fraction and symptom NIH class. This is a COMET study. Carvedilol reduced mortality by 17% compared to metoprolol in patients with chronic heart failure, and the carvedilol reduced risk of MI and unstable angina and stroke by 19% compared to metoprolol. This is a meta-analysis comparing carvedilol and other beta-1 selective beta blockers. Beta-1 selective blocker including atenolol, bisoprolol, metoprolol, nebivolol. Carvedilol reduced the mortality in heart failure by 15% and the mortality in AMI by 45%. This is additional benefit of carvedilol. There is several risk factors for incident AF, aging, genetic, ethnicity, male sex, and other comorbidity disease. And carvedilol can block alpha-1 receptor blocking effect, so there is several additional benefit. This is blood flow velocity, and carvedilol improve blood flow in carotid artery flow and forearm blood flow and calf blood flow. Gray parameter is before using carvedilol, and the red paragraph is after using carvedilol. Renal effect of beta blocker in CKD. Almost beta blocker does not interference renal blood flow, only propranolol decreased renal blood flow and decreased GFR. But carvedilol increased renal blood flow and increased GFR. So carvedilol's alpha receptor blockage has a beneficial effect on insulin resistance. When comparing metoprolol, hemoglobin A1C level is increased in metoprolol group, but there is no difference in carvedilol group. Carvedilol shows significant benefit compared to metoprolol in albuminuria and insulin resistance and the lipid parameters. As you can see, ACR is decreased in carvedilol, and HOMA-IR was also decreased, and the total cholesterol decreased comparing metoprolol group. And the carvedilol improved insulin resistance, unlike other beta blockers, including pindolol, metoprolol, atenolol, propranolol. So carvedilol indication is broader than other beta blocker. It includes hypertension, angina, and heart failure. This is drug information is carvedilol and carvedilol SR. There is a intermediate relatant formation and slowly releasing information. Carvedilol SR can improve the compliance of taking the one pill through extended release multiplet formulation. And the carvedilol SR capsule comparing carvedilol IR, the two drugs were pharmacokinetically equivalent. Carvedilol SR has been proven to be bioequivalent to reference drug carvedilol. This is dosing equivalence. So, Hanmi pharmacosexual carvedilol SR product profile. And this drug have two strong points. It is cheaper than original drug, and this is only generic drug of carvedilol. Thank you for your attention.
Thank you very much for your presentation, including about the beta blocker, especially carvedilol introduction. So, carvedilol is original drug. Carvedilol is a Hanmi drug, so very, very confusing. Anyway, it's the same drug. So, there are several kinds of beta blockers, but I want question to Dr. Zhang. It's very simple. So, could you brief mention one word? What case do you think carvedilol is more effective than other beta blocker?
As I mentioned in this presentation, carvedilol is the blocked beta-1, beta-2, and alpha-1 receptor blocker. So in patients with heart failure or arrhythmia, carvedilol is a more useful drug than comparing other beta blocker.
Yeah, thank you very much. Maybe it's time to closing this session. So I would like to thank Professor Kim and Zhang for the presentation, and thank you to everyone who participated in this session until the end. Lastly, I would like to express my deepest gratitude to Hami Pharmacy for sponsoring this session. I hope you have a great day. Thank you very much.
올바른 혈압 측정만으로도 사망을 예방할 수 있습니다. 혈압 측정, 더 이상 미루지 말고 가정에서부터 시작해보세요. 그렇다면 올바른 가정 혈압 측정 방법은 무엇일까요? 측정 전에는 먼저 화장실을 다녀옵니다. 담배, 커피, 혈압약을 복용하지 않고 운동도 하지 않습니다. 커프를 두르는 팔은 맨팔 또는 얇은 옷을 착용해야 합니다. 그 다음 바른 자세로 앉아 5분 정도 안정을 취합니다. 커프는 심장과 같은 높이에 감고 측정 중에는 말을 삼가주세요. 1분 간격으로 아침에 2번, 저녁에 2번 측정하여 기록합니다. 나와 내 가족을 지키는 가장 쉬운 방법. 함께 혈압을 측정하세요. 전 세계 사망 위험 요인 1위, 고혈압. 매년 1,000만 명이 고혈압으로 인해 사망하지만 고혈압 환자의 절반만이 자기 혈압을 알고 있습니다. 많은 사람들에게 고혈압의 위험성을 인식시키고자 MMN 캠페인이 시작되었습니다. 나와 내 가족을 위협하는 고혈압. 올바른 혈압 측정만으로도 사망을 예방할 수 있습니다. 혈압 측정, 더 이상 미루지 말고 가정에서부터 시작해보세요. 그렇다면 올바른 가정 혈압 측정 방법은 무엇일까요? 측정 전에는 먼저 화장실을 다녀옵니다. 담배, 커피, 혈압약을 복용하지 않고 운동도 하지 않습니다. 커프를 두르는 팔은 맨팔 또는 얇은 옷을 착용해야 합니다. 그 다음 바른 자세로 앉아 5분 정도 안정을 취합니다. 커프는 심장과 같은 높이에 감고 측정 중에는 말을 삼가주세요. 1분 간격으로 아침에 2번, 저녁에 2번 측정하여 기록합니다. 나와 내 가족을 지키는 가장 쉬운 방법. 함께 혈압을 측정하세요.
Just 110. Yeah, 110. Oh, 120. 120. Yeah, sorry. I made a mistake. Yeah, 120. 120, right? I'm sorry. I was confused. Okay. 지금 1시 10분인데? 20분 아니고? 10분부터 하면 얼마야? 10분부터 30분 동안? 10분부터 20분이네? 이거 얼마지? 20, 30, 40, 50, 20분부터 30분 동안. 그죠? 10분 동안, 30분 동안, 10분 동안, 30분 동안, 30분 강의. 오케이. Ladies and gentlemen, there is some mistake on the program. We will start a plenary lecture right now. So I will start this session for the plenary lecture. It is my great pleasure to introduce world's most distinguished scholar from the United Kingdom, Professor Brian Williams. He's the professor and chair of University College of London. He was a lifetime internationally high-ranking scholar. In 2023, he was awarded the President's Medal by Royal College of Physicians. And this year, he was awarded an OBE by the King for service to medicine. Today, he will give us a lecture with a title of A New Dawn for Aldosterone in Hypertension. Professor William, please.
Thank you very much for the kind invitation to be back here in Korea. It's a great pleasure to be here, particularly on the 30th anniversary of your society. I'm going to talk about some new developments in hypertension, and as I put here, a new dawn for aldosterone in this area of work. These are my declarations. I wrote an editorial last year in JAMA in which I highlighted the recent dramatic changes in our understanding of aldosterone in hypertension. It was 1953, 70 years ago, when Conn first recognized that an aldosterone-producing tumor was a cause of hypertension. Spironolactone followed in 1957, and eplerenone in the year 2000. But not much happened since then, because most of the focus was on the renin-angiotensin system. But more recently, we've seen the emergence of new non-steroidal mineralocorticoid receptor antagonists, which can be used for the treatment of hypertension. And then in the last 2 years, studies with the first generation of aldosterone synthase inhibitors. But alongside the drug development, which has taken a long time, and I'll explain why in a moment, we're also seeing a revolution in our understanding of the pathology of aldosterone secretion and recognizing that it probably is much more significant as a cause of hypertension than we previously realized. And this will soon be followed by a revolution in diagnostics, which I'll show you some new data with PET imaging, which I think is going to reveal many more tumors, many small tumors, which cause hypertension and go undetected. If we think about hypertension, there is no doubt that almost every single cause of high blood pressure involves sodium retention, shifting the pressure natriuresis curve to the right so that higher pressures are needed to offload sodium. So patients become sodium sensitive, and this sensitivity is exacerbated by a high sodium diet and aging with a lowering of GFR. And of course, the master regulator of sodium balance is aldosterone. And this mineralocorticoid is produced only by a single enzyme, aldosterone synthase, or CYP11B2. And this is in the zona glomerulosa of the adrenal cortex. And this regulates plasma sodium and potassium by promoting reabsorption of sodium in the distal tubule and secretion of potassium. And many other factors, including the activity of the renin system, can influence the secretion of aldosterone. And of course, aldosterone has two faces. Firstly, its important role in the regulation of physiology in terms of fluid composition and sodium balance, as well as hydrogen ion balance. But it also has pathogenic effects when it's produced in excess, resulting in hypertension, quite often severe in children with genetic causes of hyperaldosteronism, sometimes hypokalemia, but not always. And actually, we're beginning to realize it's involved in the generation of inflammation in target organs and the resulting fibrosis. Now, primary aldosteronism is the extreme that we see of excess aldosterone. And this is often associated with severe, sometimes quite resistant and uncontrollable hypertension. In those who have primary genetic abnormalities giving rise to hyperaldosteronism, in children, we often see the emergence of stroke in these young people. And at the moment, 5 to 10% of all hypertension is thought to be due to autonomous excess secretion of aldosterone, and maybe 20 to 25% of patients with resistant hypertension. And all of these patients have disproportionate levels of target organ damage with inflammation and fibrosis, and have premature cardiovascular morbidity and mortality. And although hypokalemia is the hallmark of primary aldosteronism, it's not necessarily always present. And we think now, because there are other mechanisms that I'll show you causing high aldosterone levels, more than 90% of cases of primary aldosteronism globally remain undiagnosed. And therefore, these patients receive poorly targeted lifetime treatment, often with poor blood pressure control. And it's substantially underdiagnosed because of a poor screening method and a very complex diagnostic procedure, which is often not performed. But as I've said, this interaction between aldosterone and sodium gives rise to a number of features, including arterial stiffening and atherosclerosis, damage to the kidney with fibrosis and proteinuria, cerebrovascular disease, which seems to be particularly common in people with hyperaldosteronism, perhaps because these patients often have dysregulated circadian rhythm as well because of salt loading. And lastly, effects on the heart, including LVH, fibrosis, heart failure, and of course, atrial fibrillation exacerbated by the low potassium. Now, what's changed is our understanding of this disease. It's been remarkable what's happened in the last 20 years. We used to think that these patients had big nodules in the adrenal that we could see on CT, and that was the extent of the disease. We now know that if you take the adrenal from some of these patients, many of them simply have small islands of aldosterone-producing cells which are dysregulated. They're no longer responding to the sodium and the renin and the other activation. They're simply continuously producing excess aldosterone. And sometimes you see these tiny nodules scattered throughout one or more of the adrenals. So you can have big nodules, which are quite rare actually, Most of the disease is hidden, like an iceberg, where you see these small nodules or you see these tiny clusters of cells, which are never diagnosed in routine clinical practice. And this dysregulation and autonomous production of aldosterone contributes, I think, in many, many more cases to the salt sensitivity and development of hypertension. In fact, if we go back 20 years, in a paper in the New England, which is often not quoted, you will look at the relationship between just circulating aldosterone level, which is a crude measure of increased aldosterone excess. And you can see that there's a significant relationship between increased circulating aldosterone and the likelihood of developing hypertension in later life. So we're seeing a situation where the master regulator of sodium, aldosterone, is disturbed, causing salt sensitivity, made worse by high salt intake, precipitating hypertension. Worse in older people because of aging and stiffening of the arteries and reduced GFR. And also we know that obesity is associated with increased aldosterone levels, and all of this exacerbated by aging and the effects on circulatory compliance. So the underlying mechanism for all of this is likely to be aldosterone mediated. And as I put here, dysregulated aldosterone synthesis is likely to be a cause of hypertension, much more than we've ever previously appreciated. And I think over the next 10 years, we're going to see huge advances in understanding a lot of essential hypertension will turn out to be dysregulated aldosterone. Another paper just published from China looked at the relationship between the aldosterone-renin ratio, which is a marker of dysregulated aldosterone secretion, and the hazard for future cardiovascular disease. And we can see here that there appears to be a threshold phenomenon, and once you get above 1, you get this about 50% increase in risk of major events once your aldosterone-renin ratio is elevated. And over time, you can see that those with a high aldosterone-renin ratio have a much higher incidence in hypertension of subsequent cardiovascular events. And as I mentioned, obesity, which is a massive problem around the world nowadays, exacerbates this problem. This nice paper from Japan showing that if you are obese, you shift to a salt-sensitive state. And if you look at the factors related to that, visceral obesity results in aldosterone excess and activation of the mineralocorticoid receptor, resulting in salt-sensitive hypertension. And it's interesting that some of the GLP-1 inhibitors, whilst also promoting weight loss, also are natriuretic. And I suspect the weight loss itself is actually contributing to the natriuresis, overcoming some of the aldosterone excess. We've also known for a long time that aldosterone is implicated in the development of heart failure by virtue of the fact that drugs that block aldosterone, such as spironolactone, have been beneficial in this condition. And more recently, studies with non-steroidal mineralocorticoid receptor antagonists have demonstrated the ability of these drugs to impact favorably on the outcome of patients with chronic kidney disease. So the target organ, as well as the blood pressure, is sensitive to excess aldosterone. Now, the underdiagnosis of autonomous aldosterone excess or primary aldosteronism is a real problem. Firstly, because it's badly diagnosed or misdiagnosed, it's assumed to be relatively rare, and it almost certainly isn't. The diagnosis is based on this classic concept of a cons adenoma, i.e. a solitary visible adrenal nodule. And the screening pathways are complex. We're about to get another guideline in the new year from the Endocrine Society. It's going to be very interesting to see what they say. But really, very few people are screened for aldosterone excess. But I think this is all about to change. So when we were at medical school, and perhaps even today, a popular perception is that there are two real forms of aldosterone excess, either due to an autonomous production from a nodule, such as an adenoma, or bilateral adrenal hyperplasia. What I'm going to show you is nodules are very, very much more common, many of them small and are not visible on conventional CT imaging, and hyperplasia is relatively rare. So what we've now begun to see, this is the classic nodule, 2 centimeters, greasy nodule in the adrenal. This is the traditional Cons adenoma. More often what we see are these smaller microadenomas scattered throughout the adrenal, and in some cases just a cluster of cells which is enough to produce enough aldosterone to cause salt sensitivity. And then you have this bilateral adrenal hyperplasia, which is actually quite rare. The important thing is that almost all of this disease is undetectable by conventional CT or MR imaging. The resolution limit of CT and MR is about 1 centimeter. Most of the disease is below 1 centimeter. But now that we have PET imaging, we can see this disease in a way that we've never been able to see it before. So this has led to a reclassification of these tumors according to the Histaldo classification, where you have these large single tumors which are actually quite rare, and then you see these clusters of smaller micronodules or aldosterone-producing nodules or micronodules, and in some cases diffuse hyperplasia. And look at this adrenal here. This is very typical, where you take the adrenal, you see little nodules, you see some cell clusters, and this is the cause of the disease, which often goes undetected. So if we look at the typical pathway, what happens is you do an aldosterone-renin ratio. If it's not elevated, we think it's unlikely that you've got the disease. If it is elevated, you have confirmatory testing. If that's negative, primary aldosteronism is unlikely. If it's positive, you go to CT, MR, and adrenal vein sampling, and you then find either bilateral disease or unilateral adenoma. If it's a unilateral adenoma, you have surgery. If it's a bilateral disease, you go to targeted medical therapy. And if surgery is not desired, you go straight to targeted medical therapy. The problem is very few patients get screened routinely for an aldosterone-renin ratio. The second problem is even fewer patients, even if they have a positive aldosterone-renin ratio, undergo confirmatory testing to see whether the aldosterone levels can be suppressed by saline. And then even when the confirmatory test is positive, you then do a CT, you can't see any nodules on CT, and therefore it's assumed that the patient has bilateral adrenal hyperplasia and the patient goes for medical therapy. So this is a really unsatisfactory, complicated process that many patients never get subjected to, and as a consequence, more than 90% of this disease remains undiagnosed. So we're now on the verge of a revolution in imaging for primary aldosteronism. And we've learned that incidental nodules are very common. The problem is, on CT, if you see a nodule, you don't know that that nodule is producing aldosterone. Much of the disease is micronodular, so it's not even detectable, and that's at least 50% of the disease. So we've now got the development of PET tracers, which are able to identify the source of excess aldosterone production. And this allows very high resolution and high sensitivity to detect even the cell clusters with a high signal intensity. The first two were C11 metomidate and 18F-ceto. The problem with these is these are not selective for CYP11B2 or aldosterone synthase, so you have to give a high dose of steroids to suppress cortisol synthase to try and get selectivity, and it doesn't always work that well. The third one we have developed, and it's generating a lot of excitement, which is a highly selective aldosterone synthase inhibitor, which has been tagged directly with F18, so it will detect only aldosterone synthase. So this is an example. These are the first evaluations. This is a CT. I think you can probably just see a nodule in the lower pole of this adrenal. This is PET. It's now unequivocal that you can see a hot spot in the lower pole. You then do an overlay with the CT, and you can see that the hot spot overlays the area which looked irregular on CT. The problem is this is a good example of C11 metomidate. There are many where it's inconclusive. So there are now 2 of these in advanced development. As I've said, the main problem with them is they're not selective. So neither is selective. You have to suppress cortisol synthase with pre-treatment with dexamethasone, and the lateralization SUV is quite poor because of the lack of selectivity. Nevertheless, they have highlighted that you can see these nodules even when you can't see anything on CT. So I'm going to show you some new data from our aldosterone synthase F18 tracer called AldoView, which we developed at UCL and have taken now into humans for the first time. Now, this is based on a highly selective aldosterone synthase, which was being developed by Merck some years ago. Interestingly, they decided that there was no market for aldosterone synthase inhibitors and decided not to take it into human development. We asked them if we could have it, and they agreed that we could, and we've taken it into human development. And this is the first one that we did. It's a cross-sectional image of a patient being now screened with PET-CT, and you'll see in a moment in the right adrenal, the signal will come up, and you can see this, this clear signal of a tumor in the right adrenal, which enables us to be very confident. And you can look at the lateralization over here. You can see a 6-to-1 ratio in signal intensity in that adrenal. I'm now going to show you some cases. So here's a patient who had a nodule in the right adrenal, possibly 2 nodules in the left adrenal on CT, underwent AVS, adrenal vein sampling. This suggested right dominant production, so the patient went to surgery to remove the adrenal, but before they went to surgery, we did PET, and we also saw right dominant. You can see here unequivocal signal on the right, and when we do a reconstruction, we can see the adrenal that's hot, and we don't need to do AVS. We can go straight from PET-CT in this patient to surgery. Here's another case, a nodule on CT, quite a large nodule. Not untypically, it was difficult to do the AVS. We couldn't get into the right adrenal. Therefore, we weren't sure, but it looked like it was right dominant. We did PET, and we could see, actually, in this adrenal, quite interestingly, you can see the hot nodule. You can also see some areas here which look like they have excess in the upper pole as well. This patient recently undergone surgery. We haven't yet got an outcome for that patient. And here's another patient where we have a CT positive scan, again, right dominant on sampling, and again, right dominant on PET. But this patient went to surgery on the basis of AVS. I don't think this patient's going to do very well, because what we can see here is what we're seeing more and more in these cases. Big nodule on the right. Surgeon thinks this is the cause of the primary aldosteronism, but you'll notice this patient also has a nodule on the other side, quite small. We're going to follow this patient up to see what happens. I suspect their primary aldosteronism will recur after surgery, and you can see it beautifully on this reconstruction here. But this is super exciting because we're able to take the adrenals out. We then do autoradiography with the actual tracer on the adrenal tissue, and you can see the hot spot where we think the tumor is. Here we have immunohistochemistry for CYP11B2, which shows you quite beautifully the overlay with the tumor. And if we do CYP11B1, we see no binding or in that area. So this is highly selective for aldosterone synthase. So what we're learning from these CT studies is that when you see a nodule, it may not be the active source of the aldosterone excess. Some of these nodules are incidental. When there is an active nodule that's visible, it may not be the only source. There may be a small micronodule on the other side, and if you knew that, it would change your decision-making about surgery. And many of the patients with autonomous aldosterone excess do not have visible nodules on CT or MRI, and they can only be seen on PET. So let me finish with the final bit, which is just a quick few words on the new era of treatment. Because instead of just spironolactone and eplerenone, we now have drugs that inhibit the synthesis of aldosterone. We have novel mineralocorticoid receptor antagonists and a debate about whether we should use both. The breakthrough came with this beautiful description and study showing that you can inhibit CYP11B2 aldosterone synthase selectively. This has been a big challenge in pharmacology because of the very close homology between CYP11B1 and B2. It's been very difficult to selectively inhibit aldosterone synthase, but it's now been done. 2 drugs in phase 2 development, baxdrostat with AstraZeneca and lorundrostat with a smaller company in the United States called Mineralis. Both of them showing impressive effects on blood pressure lowering in patients with resistant hypertension and now going into phase 2. Here's an example with baxdrostat in patients with resistant hypertension, big drop in urinary aldosterone secretion because of the inhibition of aldosynthase, and impressive reductions in systolic and diastolic blood pressure, about 12 millimeters systolic reduction in resistant hypertension, placebo-corrected. I'm now leading a study with baxdrostat in which we're using this drug globally in patients with uncontrolled hypertension on 2 drugs or more to see whether we can really begin to target difficult-to-control blood pressure by almost certainly overcoming this salt sensitivity due to undetected aldosterone excess in many of these patients. And there are other developments in this area, as well as the Mineralis and the AstraZeneca drug. Bayer also have an aldosynthase inhibitor, but they're not marketing it as a single drug. Interestingly, they've combined it with empagliflozin, the argument being that you can give this for chronic kidney disease, you can give it to diabetics, where we know there's high aldo levels, and the EMPA will have a moderating effect on potassium. Similarly, Mineralis are developing theirs in combination with DAPA, and of course, AstraZeneca are developing theirs in combination with DAPA. So there's going to be a big interest now in aldosterone as a major cause of difficult-to-control blood pressure. The final thing, of course, everybody will ask the question, should we just use an ASI instead of an MRA? Should we use the 2 in combination? It reminds me very much of the debate we had 20 or 30 years ago about whether we should combine receptor blockers for angiotensin with ACE inhibitors. I'm sure that debate in this area will also rage for some time. So my last slide. Who will benefit from targeting aldosterone? Well, I think people with difficult-to-control and resistant hypertension who I think quite commonly have undetected dysregulation of aldosterone. Patients with primary aldosteronism, and I think many of these patients with bilateral disease will now be better treated because we have a drug that will directly target the increased aldosterone synthase. And in addition, many patients where we know aldosterone excess plays a role in hypertension. People with obesity, people with diabetes, people with heart failure where we know blocking aldosterone is life-saving in some of these patients, people with CKD, and really anybody with renin-independent, aldosterone-driven, salt-sensitive hypertension, including black patients, and I should say including Asian patients, where we know there's a high frequency of salt sensitivity, and I suspect if we looked hard, there would be a high frequency of dysregulated aldosterone secretion. Anyway, thank you very much for your attention.
Thank you, Professor Williams. This is the plenary lecture. There's no questions and answers. It is very exciting era is coming. Thank you, Professor Williams. I will close this session. Professor Williams, could you come up to the stage one more time? Could you?
We are prepared the flag of appreciation. So please come up to the stage, please. Brian Williams, in deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024, in conjunction with the first scientific meeting of KSH, November 9, 2024.
Will you take a seat, please? 이찬주 쌤, will you take a seat, please? Okay, we'll start this special lecture session, and before starting our lecture session, I would like to express my appreciation for the Scientific Committee of Korean Society of Hypertension to invite the biggest hypertension scientists they invited, and we have a chance to hear their great lectures. And the first one was done by Professor Brian Williams, and second one will be presented by Professor Gianfranco Parati from Italy. Okay, I will introduce him. He's a specialist in cardiology and in internal medicine. Is an honorary professor of cardiovascular medicine, and he also scientific director of Institute Oncologico Italiano, and he is also many members of many scientific committee, ESC, ESH, ISH, and Italian Society of Hypertension and Cardiology, and he is also chairperson of Council on Hypertension, ESC, and yesterday I heard that you will be chairperson of World Hypertension League next year, isn't right? Okay, so he got many awards. There are too many, but we have limited time, and we'll start great lecture from Professor Gianfranco Parati. Thank you.
Thank you for the introduction, and thank you again for the invitation to this 30th anniversary of your society. It's an important congress. I will use this time to discuss with you one of the hot issues we are still debating in the field of hypertension, and this is related to the importance of nocturnal blood pressure monitoring and on the importance of taking this into account in hypertension management. These are my disclosures, and well, let's start with this. It's a nice Van Gogh painting. When you look at this, you think night is something relaxing, quiet, which is in most cases, but there are several things occurring during the night, and in particular, one of the questions we are addressing in our clinical research is what happens to blood pressure at night, and then, even more importantly, why should we measure it? What is the reason? Well, you can just make a simple consideration. We spend 1/3 of our life sleeping. So that's, quantitatively speaking, is more than enough to justify some interest to this phenomenon. And we also know that during sleep there is a complex involvement in neural regulation of the cardiovascular system. And that's a nice model to investigate cardiovascular control in health and disease. We need to understand indeed why in many cardiovascular diseases there are events specifically occurring at night which may represent a target for treatment. And understanding this might help us managing our patients better. And this is what happens to blood pressure. That's one of our initial studies many, many years ago when we used the intra-arterial monitoring, and you clearly see that whenever you sleep, either during the night or during the day, on average you have a blood pressure reduction. But the situation is a bit more complicated. If you consider a hypnogram with the different sleep stages, you find that when you go from wake to stage 3-4, which is the deep sleep, indeed you find a reduction in blood pressure. But when you enter in a REM sleep, is the thicker line here, you find that also the blood pressure tracing is different. You have a thicker line, which means more beats, higher heart rate, and also higher values. Because you know that during REM sleep, there is a sympathetic activation with the leg movements, and this is the time of dreaming, and the time that in some studies has been suggested to be dangerous for increased risk of stroke and cardiovascular events, which happens usually in the last part of the night, in the early morning, which will be responsible for the so-called early blood pressure rise, which occurs before awakening. That's what you can get out of a classic recording. It's not a continuous recording, but nevertheless you can have an idea of the changes in blood pressure between day and night, including changes in heart rate, which should be considered. And this physiologic behavior can be disrupted by many different clinical conditions. Just an example, if you have an obese patient lying supine, you might have in this position an occlusion of the upper airways, which is obstructive sleep apnea. And in this particular case, if you look at the polysomnographic recording, you might see that in spite of the muscle efforts for breathing, there is a block of the upper airways, so you keep having a stop of the airflow, which is responsible for oxygen desaturation and chemoreflex activation. And then when you start breathing again after a few seconds, you have a blood pressure rise to the sympathetic activation stimulated by the chemoreflex. And if you consider continuous recordings, that's some of our sleep studies where we combine continuous blood pressure monitoring with the polysomnographic tracings, you find that whenever there is an oxygen desaturation, you have a blood pressure rise. These are 5 minutes and you have 6 apneas. So this is a patient with a severe obstructive sleep apnea syndrome. And this kind of sawtooth behavior of blood pressure can be risky, can be responsible for an increased overall variability of blood pressure, but also a change in the blood pressure profile. And this is indeed what you might see. In some patients, you might have still normal blood pressure in the office, even at home, but only an increase at night, which is accompanied, as you see in the bottom here, with the polysomnographic tracing by repeated oxygen desaturations. And that's a typical pattern that we define masked hypertension due to isolated nocturnal hypertension. Sometimes difficult to identify if you not use the proper methodology. So in normal condition, you have a dipping. In some cases, you have this so-called non-dipping. And there are several conditions responsible for this. Autonomic dysfunction is one of them. Typical example are the Parkinson's disease and other chronic neural diseases, but you also may consider diabetes, CKD, sleep disorder, breathing, you have seen an example before, insomnia, periodic leg movements during night, but also use of short-lasting drugs. If you made a wrong choice of drugs, you might not cover the night, and you may come up with a non-dipping behavior as compared to what happens during the day. All these conditions may have a clinical relevance. And this is an old study, the SESTIO study. I show this slide often because that was a study in which we had the opportunity of a placebo arm at that time, because isolated systolic hypertension was not considered to be treated in those times, and this study indeed was demonstrating the need of doing this. If you remember, these elderly people with isolated systolic hypertension were randomized to be treated with diuretic or a CCB or to placebo. And the study was prematurely discontinued because of excessive mortality in the placebo arm. So we learned that we have to treat these people. And in the placebo arm here you find over a 2-year follow-up that the events rate was of course associated with the clinic pressure, but there was a very weak association. The association was better with daytime, with a 24-hour, but it was best with nighttime blood pressure. Again, emphasizing the importance of recording this parameter at night. This has been confirmed by many other studies. That's another example, the Dublin outcome study, 10-year follow-up in hypertensive patients. Again, you find that the association of blood pressure with outcome is weaker with clinic, better with daytime, 24-hour, and best with nighttime. Exactly the same as in the SESTIO study, although they were completely independent trials. And something similar can be seen also for diastolic blood pressure. And more recently, you may consider the Spanish ambulatory blood pressure registry. Professor William was involved in this study, and you see that considering more than 59,000 patients, again, there was a much better prediction of all-cause mortality by nighttime pressure, the blue dots, than daytime pressure, which was the case also for cardiovascular mortality. So several studies all pointing to the importance of nocturnal blood pressure. And more recently, at a study from Professor Carrier using nocturnal home blood pressure monitoring, again you find that the level of nocturnal blood pressure is associated progressively with a worse prognosis with the increase in cardiovascular events, which is shown by considering total cardiovascular events, stroke and coronary artery events separately. So again, even a different technology may give us the same information on the importance of nocturnal blood pressure. And if you focus just on dipping, so the change between day and night, which is a more difficult parameter to quantify, because as you may well imagine, dipping means a difference between daytime and nighttime. So it does not depend only on nighttime pressure, but also on what you do during the daytime, which may be responsible for some reduced reproducibility. That's an old study. The Ohazama study was the first to demonstrate that non-dippers, and even more so the so-called risers or inverted dippers, carry a higher risk of mortality, cardiovascular and all-cause, again pointing to the importance of quantifying these phenomena. And more recently, Paolo Palatini was focusing on blood pressure variability, specifically during the nighttime in young individuals, and he find that even accounting for the average mean blood pressure levels, whenever you have an increase in nighttime systolic or diastolic blood pressure variability, you have any reduced survival free of events, which is important because even when you control average blood pressure, but you cannot buffer these changes, you might not protect your patients well enough. Well, based on all this data, some years ago we came up with a recommendation between the European Society of Hypertension and European Respiratory Society, recommending to take care of blood pressure at night, even in the respiratory field. Our colleagues, pneumologists, very rarely measure blood pressure in their respiratory patients, and we are strongly emphasizing the importance of monitoring blood pressure at night in these conditions, because you can screen for people at higher cardiovascular risk due to this impairment in the normal control of blood pressure over the day and night. Well, if this is a recommendation, then the next question is, how should we measure blood pressure at night? Which is not a trivial question, because when you are measuring the classic approach, you are inflating a cuff, and the cuff inflation may disturb sleep, so in a way you might interfere with the parameters that you're going to quantify. Well, nevertheless, ambulatory blood pressure monitoring remains the most important approach for nocturnal blood pressure measurement, because in spite of the cuff inflation and the possible interference with sleep, you still see the occurrence of nocturnal blood pressure. And we did investigate this specific issue years ago by using intra-arterial monitoring combined with the classic non-invasive oscillometric measurement, and we showed that by having intra-arterial monitoring performed for 48 hours, 24 with the cuff inflation and 24 without, comparing the two intra-arterial tracing did not show any systematic change, which means that even if the cuff inflation may disturb sleep, in many patients it might not interfere with the sympathetic withdrawal, so in the end they still show some kind of dipping, although this is not purely physiologic. And that's an example of what might occur. This is an interesting German study showing that whenever you increase the air pressure in a cuff, you determine an arousal in the EEG, which is responsible for an increase in systolic and diastolic blood pressure in the following seconds, which may be as important as 30 millimeter of mercury, and on average in this study it was around 24 millimeter of mercury increase, and in this case is really interfering with the measurement of the nocturnal blood pressure behavior. This is not the only problem, however. If you consider the fast blood pressure changes due to, for example, sleep apnea, I showed an example before, and that's a case where you see continuous blood pressure recording in red, and you see here 4 blood pressure peaks due to 4 apneic events. When you are measuring blood pressure discontinuously with a classic oscillometric device at a frequency of every 30 minutes, these are the black dots here in the tracing, As you see, you might not identify all the fast occurring blood pressure peaks. In this particular example, only 1 out of 4 blood pressure changes was identified by the discontinuous monitoring, which is telling you that the classic approach is useful, obviously, but is not very precise, and you might miss a lot of these fast changes that can be responsible for a worsening prognosis. And the final problem is the possibility of a change in the hydrostatic height difference between the cuff and the heart. As you know, all guidelines recommend to have the cuff at the heart level. So when you're sleeping supine, there's no problem, it is at heart level. But if you sleep on a side, and for example, you have the cuff on your left arm, if you are sleeping on the right side, you have a 20 centimeter difference with the cuff higher than the heart, or when you sleep on the left side, it's the opposite. And if you consider that there is an equivalence of 1 millimeter of mercury for 1.39 centimeter water change, this difference might be responsible for a change in blood pressure up to 12 millimeter of mercury whenever you are changing position during sleep. This is very rarely considered in clinical studies. That can be a source of noise and of reduced accuracy in measuring nocturnal blood pressure. And for all these issues, we have problems indeed with the classic ABPM, although, I repeat, is still the recommended approach in general practice. We are facing something which is non-reproducible. Nocturnal blood pressure level may be different nights, which can also be physiologic in a way, because we are not always sleeping in the same manner. So sleep is not reproducible itself. So it's not only the blood pressure, but it's the sleep phenomenon which is not reproducible. But in particular, the dipping is very poorly reproducible. In many studies, it might show a variability of 40%, which means if you repeat ABPM twice, you might have a 40% chance to have a different definition of dipping simply by repeating the recording in different conditions. And then we have the sleep disruption as a problem, which I showed you before, and the poor acceptability by patients. Many patients don't like to have ABPM repeated because this repeated cuff inflation is really disturbing the physiology of their sleep. And indeed, in general practice, ABPM is not easily available, which is the most important issue in many countries, mainly in the low mid-income countries, where this is very, very poorly available in daily practice. So because of all this, we need new solutions. And one possibility comes from home blood pressure technology. We published this paper a few years ago introducing the new home blood pressure devices which have a nocturnal measurement function. In a way, you can use them to measure home blood pressure in the usual way, but they can also measure blood pressure in the night automatically. This is the newborn in the family, which is a wrist device. This is able to measure blood pressure at least 3 times automatically during the night, 2 a.m., 4 a.m., and 4 hours after going to bed. And you can use this also during the daytime. You have to shift to day or nighttime mode because there is a different algorithm for blood pressure measurement. You are awake and seated, and when you are sleeping supine. It has a memory. It can provide a different cuff size depending on the wrist size. And at the moment, is still under investigation, but the initial studies, mainly from Japan, Professor Cario showed something yesterday, you might see that it seems to reproduce the performance of ABPM in terms of identifying the prediction of nocturnal blood pressure. And this might be related to organ damage and to events rate, but again, we need more studies because there are several issues to be addressed, you can well imagine. The first is the difference between the wrist and the arm level. The wrist is a peripheral site and the pulse wave is wider, as you know. So you don't have exactly the same blood pressure, systolic and diastolic, as when you measure this at the arm level. The second problem is the possibility of artifacts. When you sleep, you move. And the wrist can move in a wider manner than the arm, which is introducing possible artifacts, as well as with the classic arm cuff inflation. You can also consider the hydrostatic high difference between the wrist and the heart. Again, this is an issue that has not been yet carefully investigated, but we have to go deeper into this. And finally, the question is, how many measurements do we need? The device now comes with 3 measurements already set, and this has been shown to produce a nice prediction of outcome. But is this the best approach, or we need more measurements? The reproducibility of sleep blood pressure depends on the frequency of measurement. Only 3 might not be enough in the way, but you can also consider that this device can be used in different nights. So you have less measurement per night, but you can use it for several nights. So you can have a nocturnal pressure for the week, for example, which is something you cannot have with the ABPM. But again, the question is how many nights are needed. Now they recommend 1 or 2 nights, but we don't know whether this is the final solution yet. So as you can see, we have a lot of studies to be performed to use this possibility better in the future, although this represents an alternative. Obviously, also, this measurement is not continuous, is intermittent. So the question is then, how can we do this better by monitoring blood pressure continuously? And this raises the issue of the wearables, which is an emerging technology on which we are all very interested, but of course, we know that there are still problems to face here. We started with the intra-arterial line, you remember, with the Oxford system that was very useful for us to understand. Now it would be impossible for ethical reasons, for the cost of the device, also for the complexity of the procedure. But nevertheless, it was the starting point. We moved then to the continuous monitoring with the Peñas method, the volume clamp technology combined with photoplethysmography, with the FinaPress that was translated into a portable device. The PortaPress, we use this device in many, many studies, space flights, mountain research, whatever. And we demonstrated in the past, as compared to the intra-arterial line, that you can have a very accurate monitoring of the blood pressure changes. The yellow tracing refers to the PortaPress and the red one to the intra-arterial line. The vertical lines here refer to the shift between fingers every half an hour, not to disturb the finger too much. So this device is still available. The company is now producing a much smaller one, but you have 2 main issues here. One is the cost. It's terribly expensive. It can be $35,000, $40,000 for a device. And then the complexity of use. Again, the fingers are a very sensitive location. If you move your fingers, you have a lot of artifacts here. I did many studies by asking my patient to keep the arm in this position like Napoleon, to avoid any movement and to avoid any change in volume shift due to the hand movements. But this is not easy to be done in clinical practice, so it's not a clinically available tool. And then we come then to the possibility of considering the wearables. We did this paper with George in the frame of our working group of the ESH, try to summarize what is the current situation with these wearable technologies. As you know, we are facing an issue which is technologically quite stimulating. The speed of development is much greater than science, so we see many of them coming into the market without any validation because we cannot keep up with the changes. And they're based on different technologies. Can be use of pulse transit time, pulse wave analysis, facial video processing, PPG remotely assessed with the camera, oscillometry, finger pressing, ultrasound, or volume control, like my ring that is made here in Korea. So we try to use them to understand how they work, but basically all of them are not measuring blood pressure, as you know. They pick up a signal with a sensor, and they use artificial intelligence to correlate the change in the variable they're quantifying with blood pressure. And this is a calculation. So definitely you need to validate this calculation. And you see many of them on the market without any validation, unfortunately. Or even worse, you can see some validation studies done by company people, which is not acceptable scientifically because it's not an independent validation. And to do this properly, we need proper protocols. We are now working on this with the ISO group to prepare a new protocol for testing these devices, not only at rest, but also when they measure changes, because this is the key feature on which we should find the possibility of demonstrating accuracy. At the moment, we have no evidence that they provide accurate measurements. They may do this right after a calibration for a few minutes, but then you have a drift over time, mainly when you compare daytime with nighttime, in particular sleep, and that at the moment is not recommendable. So definitely we need to wait until we have a validation of their accuracy in all these conditions, including their ability to follow blood pressure changes. So in conclusion, that just to sum up this quite interesting topic, where you see we have a lot of information, but we still need to do much better also from the technological perspective. Sleep is coming up. In 2022, there were two main papers, one in The Lancet, one in Circulation, that were emphasizing the importance of sleep in medicine. Sleep disorders were a kind of Cinderella in medicine until some years ago. Now we understand that sleep is really important in cardiovascular risk assessment, and in US they were defining the lives essential. There were usually 7. In 2022 they became 8. So you have diet, physical activity, glucose control, body weight, lipids, blood pressure, no smoking, and now also you have sleep. And a good sleep in terms of duration and quality is an essential component of a good cardiovascular health. So if hypertension remains a stealth killer, then we need to do better in many ways, of course in diagnosing, in assessing cardiovascular risk, in early intervention, but our assessment should include a better monitoring also at night. And indeed, targeting sleep and nocturnal BP could be the next frontier in improving cardiovascular health. You have seen many studies with renal denervation recently, focusing on the ability of renal denervation to effectively reduce blood pressure also during the night and the early morning. That could be something to consider, because we might change our focus to consider our patients not only when they are awake in our office, but also at home, and in particular during sleep. I invite you to come to the WHL meeting we are scheduling in India in March next year, where this issue will be discussed again, globally speaking. So you're really welcome to send some abstract if you want. There is still a possibility for a few weeks. And also, if you can, don't forget Milano, because we are having in Milan the ESH Congress this year in May 2025, between 23 to 26. And again, we will be discussing most of these topics with our colleagues from all over the world. Thank you again for the invitation and for your attention.
Thank you for your great and comprehensive lecture, and he gave us our future to make good sleep. So we have 2 minutes. Do you have any question or comment in the floor? Professor Brian Williams, do you have?
So, Gianfranco, lovely talk. You mentioned that you thought most of the abnormality in blood pressure regulation at night was neuromodulation. But actually, one of the interesting observations about most causes of secondary hypertension, which again are related to sodium sensitivity and imbalance, is they lose the nocturnal dip in blood pressure. So do you think some of it is also related to volume retention and sodium retention, so that when people are lying flat, you get this redistribution, and as a consequence, they're just unable to dip their blood pressure. And if they've got stiff arteries because they're older as well, their compliance to accommodate the volume at night will also be lost. Do you think that plays a significant role as well, and may also be a factor in modifying the patient's risk?
No, excellent question, Brian. There are 2 main issues related to what you're asking. First, I go back to your lecture, the role of aldosterone. As you know, there are several studies showing that increased aldosterone level might be responsible for a worse sleep apnea during the night, both central and obstructive. And Kalun from US was showing that if you antagonize the mineralocorticoid receptor with spironolactone, you may not only reduce nocturnal pressure, but also improve the apneas, because you may reduce the sodium retention, the water retention, and the edema in the upper airways. On the other way around, if you consider, for example, people with legs edema in heart failure, that is studied by Doug Bradley in Toronto, they were testing these people standing and supine, and when they get supine, they have a centralization of volume, which is increasing the central volume, stimulating the chemoreflex and the ventilation, and then you have hyperventilation, hypocapnia, and central apneas, which is worsening in heart failure. At the same time, you are increasing the thickness of the upper airways, which may favor obstructive apneas as well. And again, also in this case, using diuretics and a mineralocorticoid receptor antagonist was responsible for quite an improvement. We see now the new drugs, they might help us out also in this particular setting in controlling nocturnal hypertension and sleep apnea-related blood pressure rise. That would be really something to investigate specifically, in my opinion. Thank you for asking.
Thank you. I think we have to close this session. If there is no question, we'll close this session. Thank you, Professor Gianfranco, and nice question, Professor Brian Williams.
Good afternoon, ladies and gentlemen. I'm Kim from China University. I would like to open this session for blood pressure measurement challenges in clinical practice. I think it's very interesting, and we need lots of discussion for that. This session will be co-chaired by Professor Jung-hyun Choi from Busan National University. So let me introduce two first of presentation, and then introduce to you the last two sessions by Professor Choi. So first of all, I'd like to introduce first presentation. The title is the barriers and solutions to accurate blood pressure measurement. It will be presented by Kwang-il Kim from Seoul National University. He's now current Secretary General of our society, and he is now Professor of Chief Division of Geriatrics, Department of Internal Medicine, Seoul National University Bundang Hospital. Dr. Kim, please.
Thank you, Professor Kim, for kind introduction. And good afternoon, Kwang-il Kim from Seoul National University. And it is a great honor for me to be here and present my talks. My topic is the barrier and solution for accurate blood pressure measurement. I think that my talk is kind of the introductory topic, and the next speaker can provide more solutions for the better blood pressure measurement. This slide show the history of the blood pressure measurement. In 1733, the Stephen Hall first measured the blood pressure of a horse by inserting a tube at the carotid artery. It is very invasive procedure, and unfortunately, he could not measure the blood pressure repeatedly. By introduction of the Bechy's sphygmomanometer and the Levaroch's cuff, we can measure the blood pressure non-invasively and repeatedly by applying the Korthoff auscultation method. For more than 100 years, the office blood pressure measurement, I mean that measuring the blood pressure by a physician or the medical staff using the stethoscope or the stethoscope and the sphygmomanometer has been the golden standard for BP measurement for diagnosing hypertension or hypertension management. And nowadays, there are lots of devices available for blood pressure measurement. So we can measure the brachial blood pressure as well as the central blood pressure, and we can measure the blood pressure at the office and also at the out of office blood pressure by using the ambulatory blood pressure monitoring or home blood pressure monitoring. Conventionally, the blood pressure can be measured by the invasive method or auscultatory method or the oscillometric method. The invasive blood pressure measurement is most accurate in measuring the blood pressure, but this method can be applied only for the hospitalized patient and usually in the ICU setting. So this method cannot be used in diagnosing or managing the hypertensive patients. So we use the auscultatory method or the oscillometric method. But when we use the oscillometric method, there are some limitations because the oscillometric method can measure the blood pressure by detecting the maximum oscillation point and estimating the systolic and diastolic blood pressure by applying the algorithm that the company have. So this method is not accurate in measuring the blood pressure for some patients who have a very wide pulse pressure, such as the very old adult or the pregnant women. But it is very convenient because the oscillometric method do not need the stethoscope and experienced medical step to measure the blood pressure. So most of the digital device used this oscillometric method. Recently, novel blood pressure measurement method, including the photoplethysmography or bacilloscardiography or the bioimpedance measurement, have been developed and are ready to use in clinical practice. But this method is kind of indirect estimation of blood pressure. So essentially, all of these new blood pressure measurement methods also have some limitation in measuring the blood pressure. This is the list of the common barrier for the accurate blood pressure measurement. The first one is the white coat effect. And sometimes the patient has some kind of anxiety in the clinical, especially the office. So this anxiety can temporarily increase the blood pressure levels. The second one is device inaccuracy. A non-validated or poorly maintained device can yield only liable reading. The next one is the technique, the improper technique, including the incorrect cuff placement or improper patient positioning, or the physician or the medical staff do not follow the standardized the procedure, and all of these things can have some impact on the accuracy in measuring the blood pressure. The blood pressure is intrinsically variable, but this BP variability or circadian variation have some impact in measuring the blood pressure. So just measuring blood pressure one time, especially in the office setting, it cannot reflect the true level of blood pressure. The final component is the patient non-adherence. Although we have a very well developed standard protocol or recommendation, if the patient does not follow that protocol, it has no effect. So patient should follow and should be educated to follow this the procedure. But in clinical practice, there are some problem that the patient does not follow the standard protocol to measure the blood pressure, and this limitation can cause some inaccuracy in blood pressure measurement. The office blood pressure measurement is the most commonly used, and it is the golden standard for diagnosis of hypertension and hypertensive management. Actually, it has lots of strengths in measuring blood pressure, but still there are some limitations. And among them, sometimes the physician or the medical staff do not follow the standard protocol to measure the blood pressure. And so sometimes it is overestimate the blood pressure levels. Another one and the most significant factor of a limitation of the office blood pressure is that single measurement of office blood pressure cannot reflect the blood pressure level, so the office blood pressure have a very low diagnostic precision. As I mentioned before, there are concerns about the white coat effect or white coat hypertension, and the office blood pressure cannot detect the masked hypertensions. Actually, it has been well developed that some factors have very significant effect on the blood pressure level, including the patient position, and cuff size or measurement method. And this factor can increase or decrease the systolic and diastolic blood pressure significantly. So when we measure the blood pressure, we should follow the standard protocol. Fortunately, we have lots of well-developed recommendation to reduce the error when you're measuring the blood pressure. But the problem is that the most physician or medical staff or the patient does not follow the standard protocol. So we have to find a way to encourage our patient or the physician to follow the standardized recommendations. As I mentioned before, that nowadays many digital devices, sometimes a wearable device such as the ring or the smartwatch can measure the blood pressure continuously. But there are some factors which can affect the accuracy of the blood pressure measuring, especially the plethysmography signals. The PPG signal is not accurate for the very obese patient, and it has some problem in the tracking the blood pressure for the dark skin tone or tattoo, or there is some decreased skin perfusion or cold temperature, and especially there are some issue that this PPG signal does not measure the blood pressure when the patient moves, and it does not tracking the blood pressure when you move significantly. So we have to find a way to overcome this barrier. Let me talk about the blood pressure variability. The blood pressure is intrinsically variable, so sometimes this variability make it harder to measure the blood pressure accurately. So to overcome these issues, it is recommended that repeated measurement of blood pressure for the office blood pressure, repeated visit the office, and multiple measuring, duplicate or triplicate. So in this slide showed that at least 10 measurements of blood pressure are required to reach some kind of true level of blood pressure. So most of the recommendation ask for the multiple blood pressure measurement, at least 10 blood pressure measurement to diagnose hypertension. But as you know, various types of blood pressure variability, including the bit-to-bit variability, or 24-hour short-term variability, or the visit-based long-term variability, has prognostic relevance for cardiovascular and renal outcomes. But the problem is that we have to find a way to capture this kind of BP variability index. For that purpose, we should use the home blood pressure monitoring or the ambulatory blood pressure monitoring, and hopefully in the near future, we can get some bit-to-bit variability index to tell the clinical significance of this kind of variability. This is the solution for the accurate blood pressure measurement, and I will talk about this 6 topic in more detail in the next slide. The first solution for the accurate blood pressure measurement is the physician or patient education. For that purpose, we should develop education material for blood pressure measurement, aiming for the patient or the healthcare provider. And also, we have to train our healthcare provider that he can know about the best practice recommendation and follow the recommendation of the blood pressure measurement. For the patient resource, very simple, accessible video should be developed and uploaded for the internet or at the YouTube. This survey result showed that actually this survey was performed by the Mu-Young Lee in Korea, and the result showed that the Korean population there are very low rate of home BP measurement, and they some problem in the high rate of non-validated device and the high rate of inappropriate measurement. So in more detail, they are very heterogeneous in measuring the blood pressure, time, and the frequency of home blood pressure measurement, and the rest time before the home blood pressure measurement and time interval between the measurement. You can see here that they did not follow the recommended standard protocol for home blood pressure measurements. Fortunately, there are many educational material for home blood pressure monitoring, and this is prepared by the AHA and AMA, and also KSH developed the home blood pressure monitoring guidance, and also we developed this kind of the movie clip and uploaded this
안녕하세요,
clip
환자분. 잘 지내셨어요?
YouTube. The second one is device validation, and we should encourage the patient or the physician to use the device certified organization. And also, the device should be calibrated annually to ensure the ongoing accuracy. This slide shows the major blood pressure device validation protocol. As you can see here, that lots of protocol exist, and they define the criteria indicating a valid device. But the problem is that the patient did not care about the validation for their home BP device. So the physician should encourage to use the validated home blood pressure monitoring device. The third one is the standard measurement protocol, and fortunately, it has been already well developed and established that the blood pressure measurement protocol is already very well established regarding the position or arm support or the environmental factor. And many these recommendations are already presented in the guideline, and this slide shows the ESH guideline, and you can see here that the guideline recommend the way of blood pressure measurement with strong evidence. And another important thing is that the highlight of the out-of-office blood pressure measurement, and for that purpose, we should recommend the home blood pressure monitoring or ambulatory blood pressure monitoring. Or hopefully, in the near future, we can use the wearable device to tracking the bit-to-bit continuous blood pressure change. And this ESH guideline strongly recommend to use the ambulatory blood pressure, and there is the description regarding the time interval for the blood pressure measurement, for ambulatory blood pressure measurement, or there is a strong recommendation for the home blood pressure monitoring, and there is detail how to measure the home blood pressure for the patient. And using this out-of-office blood pressure measurement, we can check the existence of white coat hypertension or masked hypertension. And especially I would like to stress the existence of masked hypertension, because masked hypertension has a very poor prognosis, and sometimes many physicians, many primary physicians do not know about the existence of masked hypertension, so we have to encourage our physician to check the out-of-office blood pressure for patients with high normal or elevated blood pressure levels. The final solution is a little bit in the near future, so we can encourage our patient to use the smartphone app to track a blood pressure reading or the remote blood pressure monitoring by way of the telemedicine or the home BP-based data sharing. Or in the near future, the artificial intelligence-driven can provide more accurate blood pressure level when you're using the continuous wearable, when you're using the wearable device for continuous blood pressure monitoring. Preparing this talk, I asked the question to ChatGPT regarding what is the unsolved challenge and issue in blood pressure measurement, and this is the answer that I got from the ChatGPT. Something is a little bit weird, but some statement is quite interesting. So I would like to introduce the answer of the ChatGPT. The ChatGPT answered that the problem of unsolved challenge, what are the effective way to standardize the blood pressure measurement in home setting. The second one is how can we reduce the impact of white coat and the masked hypertension. And third one is what is the role of wearable technology in continuous blood pressure monitoring, and how can you account for variables like the cuff size and placement. And the next one is the impact of digital health literacy. That is quite interesting that usually we do not care about the digital literacy, but it is very important, especially for the very old patients. How can a machine learning model improve the blood pressure measurement accuracy, and what step can we take to reduce the impact of short-term stress or reading? Or finally, how can you better measure and understand the central blood pressures? This is my last slide. There are lots of barriers in measuring blood pressure, but we have a solution, and some solution we already have a good answer. But the problem is that this the education material and the validated device protocol or some recommendation is not penetrated to our clinical practice. So we should find a way to how to spread this kind of recommendation to our clinical practice. And for the future direction, we have to do something more regarding the ongoing development in AI-enhanced BP device or wearable technology, which can have some beneficial effect in measuring the accurate blood pressure. Thank you for your attention.
Thank you very much, Dr. Kim. So let's move to second presentation. This will be presented by Dr. Kei Asayama from Japan. His title is What Did He Learn from the International Databases on Ambulatory and Home Blood Pressure in Relation to Cardiovascular Outcome. Dr. Asayama graduated Tohoku University School of Medicine in 2000, and he's now professor of Department of Hygiene and Public Health, Teikyo University School of Medicine in Japan. Dr. Asayama, please.
Thank you very much, Chairpersons. It is my great pleasure to have this opportunity to provide my lecture regarding the international database on ambulatory and home blood pressure. I'm sorry. Okay. So, as all you know, the home and ambient blood pressure, namely out-of-office blood pressure, has a lot of advantages compared with in-office blood pressure measurement. Of course, we should not overlook the advantage of office blood pressure also. And I would like to provide the out-of-office blood pressure-based studies, two studies, such as the upper word is ambulatory blood pressure, namely IDACO, and it is the cohorts collecting ambulatory blood pressure monitoring data integrated one. And this is an individual person, participant-level data set, so-called IPD meta-analysis. And also, similarly, we cohort collecting self-measured home blood pressure measurement data, also integrated to the IDHOCO. This is also a home blood pressure based international database, also IPD meta-analysis. So based on these IPD meta-analysis, we assess how out-of-office blood pressure contributes to risk stratification and the management of hypertension. So first, IDACO is a random population sample and longitudinal follow-up of both fatal and non-fatal cardiovascular outcomes. I would note that the principal investigator is Professor Jan Stassen, living in Belgium. And this is consists of more than 13,000 of participants from 13 centers from Europe and Asia and South America. And the participants from Europe is also contributed to the EPOCH study group. From IDACO, about 15 years ago, we proved that the nighttime systolic blood pressure has a predictive power to predicting for all-cause mortality as well as cardiovascular mortality at events. And daytime systolic blood pressure also has a good ability to predict cardiovascular events, but not so for cardiovascular mortality and all-cause mortality. And the diagnosis threshold for ambient blood pressure monitoring was calculated. We calculate the diagnosis threshold based on 10-year cardiovascular risk. And the reference values were proposed as shown in the lower panel. And essentially, this is essentially similar both for untreated and treated people. So, except the daytime systolic value as a gray out value, these are commonly accepted in the recent guidelines, as shown this slide, as American guidelines and European Hypertension Society of Hypertension and European Society of Cardiology guidelines also accept still use these thresholds for the guideline for the thresholds for the ambient blood pressure, and of course Japan. So criteria for hypertension in if office blood pressure set as 140 per 90 mm mercury or more. So worldwide diagnosis criteria for ambulatory hypertension are daytime awake is more than 135 per 85 mm mercury. Nighttime sleep state 120 per 70 mm mercury and more. And 24 average 130 per 80 mm mercury. However, the therapeutic targets still vary, and are sometimes not defined. So gaps in the evidence were noted in the previous European guidelines and still not fully proven, addressed. Anyway, based on the out-of-office and office blood pressure information, we can classify participants into 4 categories, such as shown here, as you know, from normal tension to sustained hypertension. There are 2 specific conditions, so-called masked hypertension and white coat hypertension. However, we should note that based on the IDACO population, prevalence of white coat hypertension and masked hypertension differed very much when we rely on the ambulatory blood pressure values. If we use the nighttime blood pressure only, the white coat hypertension prevalence was only more than 12%. However, if we stringently uses 24-hour plus daytime and nighttime all, the prevalence of white hypertension decreased less than half. And in contrast, masked hypertension prevalence also differs very much according to the ambulatory blood pressure information. Therefore, there are twofold differences, and we should consider which factors, which period of ambulatory should be were used to define white coat and masked hypertension. And then identification of truly low-risk white hypertension, as shown in the left panel. If white hot hypertension, if based on 24-hour blood pressure, has similar risk to true normal tension. However, when only based on day or night blood pressure, the white hot hypertension has a significantly high risk for cardiovascular risk. Therefore, identification of truly low-risk white hot hypertension requires all measurements of 24-hour, daytime, and nighttime blood pressure. In contrast, masked hypertension shows consistently high cardiovascular risk compared with normal tension. And ambulatory blood pressure contributes to risk stratification, refined risk stratification in normal tension and prehypertension, as shown here. Can I see? Okay. Compared with normal tension subgroups, if people has masked hypertension, even their in-office blood pressure is under normative range, their cardiovascular event risk is more than 2 times high, and also in the stroke. Therefore, I repeatedly say ambulatory blood pressure can contribute to risk stratification, particularly in the presence of masked hypertension. Next topic is self-measured home blood pressure. As you know, it enables stationary observation of blood pressure at a fixed condition. It improved health awareness in individuals and multiple measurements under the standardized procedure conditions. And home blood pressure has better predictive power than conventional office blood pressure. It's comparably cheaper and free from white-hot effect in principle. We set the international database of home blood pressure in relation to cardiovascular outcomes, namely IDHOCO. Also, Professor Ian Stenson is a principal investigator of this meta-analysis. In this meta-analysis, we collected around 9,000 participants from 7 centers, following for almost 70 person years. And in the treated population, we also calculate the prognosis criteria based on IDHOCO home blood pressure criteria. However, in the treated population, the association between blood pressure and events was weaker than for the untreated population, and no association at all for office blood pressure and events in the treated population. Therefore, only can be applicable for untreated population and treated untreated combined populations, and determine home blood pressure with the treated population as shown below. Then, diagnostic thresholds for home blood pressure was proposed by IDHOCO, and also it is partially adopted in the recent and current guidelines. As you see, hypertension office more than 140 per 90 millimeter mercury is equivalent to 130 to 135 in systolic and 85 in diastolic millimeter mercury. And normal tension, office blood pressure less than 120 per 80 millimeter mercury, except the most recent European cardiology guidelines. It is equivalent to 155 per 75 millimeter mercury in the Japanese Society of Hypertension guidelines. But in the American guidelines, the same values were used. And similar to the ambulatory blood pressure, home blood pressure can refine the risk classification based on in-office blood pressure. As you see, even in the optimal blood pressure measurement populations, the risk of cardiovascular can be further detected by home blood pressure, and home blood pressure can refine the risk stratification of this population. So, and also similar to the ambulatory blood pressure measurement, classification by the combination of in-office and home blood pressure can be done and can be calculated. And based on the data set, risk of home blood pressure according to the office blood pressure level and masked hypertension is shown here. As you see, masked hypertension based on home blood pressure is more than 2 times high risk even when in-office blood pressure is under the optimal blood pressure ranges. And the other issue is the white-hot hypertension. White-hot hypertension accounts for 15 to 30% of patients with an office blood pressure of more than 140 per 90 millimeter mercury diagnosed with hypertension. And high prevalence of white-hot hypertension is found in older adults. Therefore, eventually, their prognosis is poor when we do not consider the confounding effect of aging. Is white-hot hypertension truly risk of cardiovascular disease has been under the debate, but from the IDHOCO, we provide a result regarding the risk of white-hot hypertension. As you see, the left columns show the untreated population compared with normal tension. White-hot hypertension, people with white-hot hypertension has a significantly higher risk, and it also succeeded to mask the hypertension and sustained hypertension. However, when people limited to those with under antihypertensive medications, compared to the normal tension with medication, the white-hot hypertension does not have a significant risk. However, you see the treatment status, itself 1.554 means itself shows 1.5 times higher risk compared with untreated populations. We should not interpret it as a drug itself increases risk, but we should consider that they had those with treated patients had a high risk enough to start medication. Also, there are some debates for the truly risk in white-hot hypertension patients, but at least several cohorts, with, including our Ohasama Japanese cohort, said that the patients with white-hot hypertension tend to become for sustained hypertension more than the truly normal tension. Therefore, careful follow-up for white-hot hypertension is needed. That means careful follow-up means measurement of blood pressure among these white-hot hypertension patients. And from the IDHOCO, we calculate, assess the day-by-day home blood pressure variability and its cardiovascular risks. The risk was, as you see, significantly greater in the highest decile, highest divided 10 groups risks, systolic, diastolic, both. And the threshold of the highest CV coefficient variation is more than 11 and 12.8 millimeter, no unit, which equals to, blood pressure level is 135 by 85 millimeter mercury as a criteria for hypertension. The SD standard deviation equivalent to 15 per 11 millimeter mercury. However, if we deploy it to clinical practice, 95% of recorded blood pressure in individual ranged from 106 to 165 millimeter mercury in systolic and 65 to 106 millimeter mercury in diastolic. And 1 per 20 measurement could be out of the range. That means implies that the measurement condition, the high day-by-day home blood pressure variability might be because of their instability of measurement or less adherence for blood pressure measurement condition we concluded at that moment. And this is a challenging slide that we try merging IDACO and IDHOCO data set combined. From the Japanese Ohasama study, both data were provided, but in this case, home blood pressure data are used. And cardiovascular risk by age group and categories of out of blood pressure are shown here. As you see, at young age, the lower lines, high relative risk, but low absolute risk were observed. In contrast, relative risk decreased and absolute risk increased with advancing age. That means we should underscore the need for a life course approach to the management of hypertension. Indeed, this analysis we faced a very difficulty to merge it because the characteristics differ very much, and yes, there are a lot of things, and yes, it is still a challenging approach. Anyway, this is some clinical issues as shown here. Clinical inertia is also a main topic all over the world among the patients. Patients sometimes say, I don't want more medications, more pills, or I want to take the same medication for now. Next time I want to follow your indication, and I cannot pay more. Yeah, it is also a case. And instead, I'm going to start reducing my body weight and exercise do, but maybe next year it's also possible. And before the treatment status, I want to continue measuring home blood pressure. Some patients complain. If white-hot hypertension, I do not need to take medication yet, right? Sometimes patients say. Partly yes, but partly no, because white-hot hypertension, the risk differed according to their other conditions. As shown in the IDACO slides, left panel show the people with low-risk groups. In low-risk groups, white-hot hypertension is not a significant risk. However, among the high-risk group, such as diabetes, such as taking smoking and high old age, white-hot hypertension itself is a significant risk compared with normal tension. And this is in the Japanese society guidelines for the stratification of the risk. So as you see, for example, grade 2 hypertension, more than 160 per 100 millimeter mercury. The category 1 is surely moderate risk, but category 2 and 3 equivalent to high risk population. And category 2, the condition is at least one of age more than 65 and men and dyslipidemia or smoking. That means I am man, therefore I cannot be category 1. So I'm man living in a difficult world anyway. So if the high-risk patients we saw, treatment of essential hypertension should be start drug therapy immediately. Guidelines says, of course, parallel to lifestyle intervention. Therefore, to breaking down clinical inertia, we should not allow mere home blood pressure measurement if clinically needed. High risk or, of course, moderate risk should be needed. And in Japan, there are remaining issues in home blood pressure, also maybe also in the world. And for example, how many times should we measure home blood pressure? And how long should we measure home blood pressure? We prove that as long as possible should be required because more than 5 years of continuous home blood pressure is also feasible. And long-term home blood pressure can detect seasonal blood pressure variations, and it defines also cardiovascular risk stratifications. And conditions on the evening measurement is another big issue, because in the Idaho population, there is a valid measurement condition among populations. You see Ohasama Finhome, when limited to the evening measurement, in Ohasama, evening should be measured just before going to bed. But in Finhome, in the Finland study, evening should be 6 to 9 o'clock in the evening. And Dijima Greek cohort, evening 5 to 11 in the evening. There are as a result, home blood pressure difference between morning versus evening differed between Japanese and other 4 cohorts. You see, morning blood pressure is higher than evening blood pressure in Ohasama, but in contrast, other result is in contrast in other 4 cohorts. And when we collect another meta-analysis, but aggregate data-based meta-analysis, as you see, the difference between morning and evening home blood pressure in Japanese cohorts are almost 5 millimeter mercury difference in women, and more than 7 millimeter mercury in men. Therefore, at least in Japan, separate home blood pressure threshold for morning and evening might be needed, but evidence is scarce and need for further investigations. This is the last slide of my presentation. Based on the Idaho, along with many other investigators, we would advocate and promote routine monitoring of ambulatory and home blood pressure as essential instruments in risk stratification, the diagnosis and management of hypertension, its associated complications, and any other conditions in which blood pressure is an issue. Thank you very much for your attention.
Thank you very much, Dr. Asayama.
Yes, let's move to the next speakers. Next speaker is Professor Eugene Jiang, and his topic is very interesting about the emerging device and telemedicine in hypertension. And it's my pleasure to introduce Dr. Eugene Jiang. He is Professor of Cardiovascular Medicine in Department of Cardiology in Huai Hospital and Chinese Academy of Medical Science and Peking Union Medical College. And he is also General Secretary of the Chinese Hypertension League and also the Associate Editor of the Journal of Clinical Hypertension. Dr. Jiang, please.
Thank you, Professor Chai. It's a great honor to be invited by the organizing committee of the Korean Society of Hypertension, and also congratulate your 30th anniversary of the founding of the society. And I was asked to deliver this presentation on this topic. It's have been touched a little bit by our previous speakers. I have no conflict of interest. The current situation of hypertension burden is still high in worldwide, especially in China, because in China we can also find that the control rate is relatively low, around 16%. And the whole population of hypertension. But now in this country, in Korea, we know that you have reached the more than half of the patients of hypertension have been well controlled, which have meet the standard created by the World Health Organization. And also we have also noticed that, but in the other parts of the world, especially in the States, and we also noticed that even though the definition have been changed, but from the enhanced study, the blood pressure control rate still increased during the past few years. So it means that we may have a great burden, still have great burden in the control of hypertension, though we have made a lot of progress in this area. So we may need some new technologies or techniques to improve our tools in the management of hypertension. I gave a presentation yesterday in China in a big meeting, and one doctor asked me why our control rate is still very low. But I said I have no good idea, because as physician, we can only do is to use the current tools to the management hypertension, including we invent the new devices, new equipment, such as recommended by our two speakers, using home blood pressure monitoring, ambulatory blood pressure monitoring to improve our control. But healthcare system may be the fundamental issue. Maybe in other countries, such as in Korea, you have a relatively better healthcare system. They encourage patients to come to the hospital or community clinics, have their blood pressure measurement and have their disease consulted and treated. But in China, it's relatively different. The patient have many choices to visit different kinds of hospitals. So the follow-up patients is a big problem in China currently. So maybe the new technologies is relatively needed. So we have now the telemedicine, current recommendations by the few guidelines in the European guidelines, in Chinese hypertension guidelines. Telemedicine is encouraged, but still we have faced some difficulties in using that, because maybe only for the younger populations of hypertension can use this kind of tool, but for the elderly also is a big problem. Anyway, we have made some progress in the past few years, and maybe the artificial intelligence is a kind of tool. We have, I have heard Professor Eugene Yang from in Cartagena, his presentation gave a kind of introduction using AI in the Seattle. It's a kind of very good try to in the management of chronic diseases. It's a kind of thing that we under research, and to some extent have been used in the clinical practice. Very useful in the imaging test, but still in the hypertension test. I don't know whether we can have many other tools investigating some extra parameters other than clinical parameters we test routinely during our clinical practice. So it's relatively different in the hypertension management from the imaging tests. So the AI is a kind of thing that we are trying to do. There are still a lot of emerging devices we are looking for, and also have some of them are very successful in the from the engineering point of view, but from the clinical point of view, yes, we still have some limitations. That's something like that we can wearable devices, and these kind of devices become more comfortable, skin-like, up to electronic system or for complex continuous monitoring, blood pressure monitor is quite useful, but whether it's accurate, to some extent it's accurate. It's accurate when we at rest, but during the movement it's also a big problem. We also test the effects of these kind of blood pressure measurement varies dramatically during exercise, and also healthcare. There are also monitorings via heart, breathe, called sound. Wearable piezoelectric patches can monitor this kind of thing, not just from the traditional sonometric methods varying the blood pressure, but from called sound, get the sound from the heart, lungs, and different parts of the body, and also can characterize the systolic and the diastolic blood pressure. May be useful, but still under research. There are also other kinds of using continuous wireless monitoring for monitoring the blood pressure. We have many kinds of materials, devices, mechanical designs, the data processing methods and integration strategies for the thin, soft, miniaturized system. So this kind of thing may be also a continuous monitoring blood pressure in a real wearable format. And with accuracy, actually, I think the accuracy is become much better than before. When we do the validation tests, there are also some different subtypes in the current investigation. Also, a lot of deep learning system using the AI techniques in monitoring blood pressure. Anyway, we may have to calibrate this kind of blood pressure with traditional devices when we're using this new equipment. And also the AI technology has been integrated in the blood pressure measurement devices. And also this QRSmart, many kinds of these things combined with our apps, and also kind of thing that's very traditional, but not necessarily to go through all of them, but anyway, this something that is under research dramatically during the past few decades, and also some ways in using the ultrasound. Some data some paper have been published in the hypertension journals, especially in the journal Hypertension. We reviewed several of them. These papers have been tested to be accurate in the measuring the blood pressure. It's also wearable, even in the flexible wearable ultrasound blood pressure measurement devices being used in the research area, but also in some pediatric studies we use that in measuring blood pressure, because in patients with younger age, very young age, infants, measuring blood pressure is relatively a difficult task. So this is also a challenging work for the development of blood pressure measurement devices. But anyway, ultrasound it seems to be also a promising technology in the new blood pressure measurement devices. So there's also many kinds of devices have been developed during the past few decades. When we have the first meeting, I remember correctly, in 2017 in Milan, organized by Professor Parati, and we also have talked about the new devices which we use, whether we use the PTT or PSG or ultrasound. New devices have been used, these new technologies, and seems to be effective. All kinds of things also very seems to be promising. But after 7 years, we can find that although we have this kind of devices, we also have these devices been tested to be accurate during the rest, not exercise, but we also have to face the challenges that this kind of thing can can this kind of thing be used in the daily clinical practice? And it also there are some possibility that used for patients for self-monitoring of their blood pressure better than routine office or the home blood pressure monitoring. This is something that we have to be cautious, because also in the document published in by the European Society of Hypertension and the reviewing of the cuff list devices, we have noticed that there is complexity in the validation of these cuff-based devices. It's not a routine protocol compared to the traditional blood pressure measurement devices. And also, there are also some problem in the measurement of the accuracy. We have some many discussions with our colleagues from Korean and colleagues, such as we can use the Sky Labs devices, rings, and we have also in China we have devices with wearable devices such as watch. All these devices are under research, and also only the acceptable devices can be used in clinical practice. It's still a traditional one, whatever in the ring or whatever in the arm or somewhere, or like something like watch to use that. So there's also in the cuff-list devices, especially those worn in the wrist or other non-heart level locations, may be susceptible to hydrostatic pressure effects, which can introduce errors in blood pressure measurements. That's such thing we have to be cautious in the explanation of the data. So, and also the other situation we have to concern about is the user-specific calibration, that because data are used, the individual user calibration must undergo periodic recalibration to maintain accuracy. It can be a burden to users. And also limited validation protocols and validation protocols have been developed by different societies, engineering society and the hypertension societies. And these also have to be, there's some similarities, but also we have noticed that in important differences. So in whether we should use it in clinical practice, there are still a lot of work to do. So in the blood pressure measurement devices, it's promising. I believe that it can be used in the future, but when we are working hard on that, we know that. And it's actually in the AI techniques and the management hypertension, we try to use the machine learning or something like that to improve our treatment and diagnosis of chronic disease, including hypertension. It seems to be effective that using the new technologies and measurements measures more divided in parameters. So as to get precise estimation of the risk, because the chronic disease treatment is based on the risk-based strategy, and especially the blood pressure management. Machine learning technologies have been also investigated during the past few years. Seems to be effective in the prediction of hypertension-related outcomes. Especially in the younger subjects, including the patients with hypertension, cardiovascular disease, and end-stage renal disease, and the other kind of morbidities. So there are some data showing that in the machine learning data using combinations of different kinds of variables, such as blood sugar, blood pressure levels, and maybe cholesterol, something that will be easily obtained by our daily clinical practice, and with the calculation, it should be more accurate in than the traditional risk factors scores, such as Framingham score, or the score study, or even score maybe comparable to the Chanapar risk stratification scores. So this kind of machine learning technologies have been used for the risk estimation scores. And for the management of hypertension, Professor Cario have been done an excellent work in the the pivotal studies. He also encouraged the patient to use these apps in the better management on the lifestyle modification, including the sleep condition, on the salt intake, alcohol in reduction, exercise, improved exercise, and the improved blood pressure, blood weight control, and the stress management. It seems to be without using any antihypertensive agents, the blood pressure can be effectively lowered by these digital health, digital therapy. 24-hour blood pressure was reduced by 2.4 mmHg, the systolic, and even morning home blood pressure was reduced by 4 mmHg. And office blood pressure also significantly reduced. But this also, although it seems to be trivial in the lower blood pressure, but from the general population point of view, the few mmHg differences can bring a more beneficial effect in reducing cardiovascular events. So that's the using machine learning technology may be also used for cost effectiveness. Also from the SPRING study, they investigated that using SPRING machine learning algorithm can predict individual benefits. But then was this methods have been tested, validated in the cohort blood pressure results, and demonstrated the potential and beneficial effects of machine learning and tailor hypertension treatment based on the individual patient profile. This seems to be an effective way, or cost-effective way in the future management of hypertension if can be the data can be digitalized or put into the electronic health record. And then the machine learning algorithm classify visit-to-visit blood pressure variability and do as a predictor of cardiovascular disease, because we have there are a lot to try to individualize the management of hypertension based on blood pressure variability. Anyway, it's relatively difficult because how to calculate which kind of parameters we use in clinical practice. So we have discussed this issue from maybe 14 years ago after the publication of the blood pressure variability study in the published in Lancet carried out by Professor Peter Rothwell, and we have discussed this issue with Professor Parati several times, and we try to initiate some clinical trials, but anyway, it's relatively difficult. Maybe using a more precisely measurement of this kind of variability and put into use in clinical practice is maybe bring better blood pressure management. Also, we have some other models. All kinds of models, many kinds of models have been performed. Under research in the different parts of the world, including China and other regions. We try to incorporate many different kinds of parameters together, and then to assist the doctor to make decisions to select on the selection of more effective antihypertensive agents. There are some also devices have been invented in this area, but still under research. But this is a way for the personalized medicine, the future management of hypertension, so as to improve the blood pressure control. We're now carrying out a trial in China with the small cloud sharing smart cabinet. Randomized clinical trial was approved several years ago. We are still recruiting patients. So the objective of this study evaluate clinical effectiveness of remote blood pressure management and investigate the feasibility of universalizing remote blood pressure control. And blood pressure control rate is the primary outcome, and we try to sharing these blood pressure measurement devices in our region, and it can be rented by very little price, only one RMB per day, to then ask the patient to get their blood pressure measurement for at least 1 week, and then return back and we record this. Also, for the three group was there are three groups in the study. The first group is documented. We provided the remote equipment and train the patient and to have remote management with and educate patient with healthy health educational program. And that second group is just to provide electronic devices for the patient, ask them to return to record their blood pressure and return. And the third group is only the routine blood pressure management. And this study is underway, but we still have noticed that we still have noted, though we have some new approaches, but this kind of thing have to be validated, not validated. Most of them have not validated, and many factors should maybe have complex interactions between the genetic, environmental, lifestyle, wonderful factors. So the summary, I'll have to face the fact that we have made great progress, and engineers have made great progress, and we have used these technologies in our clinical practice, and also have improved our care for the patients. But also for the AI technologies appears to be promising, and the current medical research indicating that AI can enhance our personalized treatment plans, including improving the blood pressure control and produce cardiovascular risk more accurately. I'd like to be in the future as an integral part of our clinical decision making, of being more efficient and effective management of hypertension strategies of hypertension. Thank you.
Thank you, Dr. Xian. Yeah, thank you for your insightful lecture about future perspective. And our last speaker is Hae-young Lee from Seoul National University Hospital, and also he is director of international peer of KSH. And his topic is about validation. Is it right? Yes, sorry. Yeah, validation and future direction of BP measurement. Dr. Lee, please.
Thank you, Chairperson, for the kind introduction. Certainly, hypertension is no longer the science for old age, but not as a relic of bygone era, but as a dynamic field bringing DNA vaccination and device therapy, and also coupled blood pressure measurement. In this new technology, I focus on the coupled blood pressure monitoring device. So blood pressure is highly variable, so we need repetitive measurement. So if the lower, the better is the strategy in dyslipidemia treatment, the more, the better strategy is blood pressure measurement and treatment. So it will be very fantastic if you adequately can measure blood pressure variability and nocturnal blood pressure. We can discriminate patient cardiovascular risk by 5-fold without any other specific workup. But the problem is with blood pressure variability and nocturnal blood pressure. We do not have still adequate tool to measure it. So current gold standard is ambulatory blood pressure monitoring. This is the data from my 2 patients. They rise the blood pressure during night time, and there are differences in sleep time. They are often considered in the reverse dipper, rather riser, but in that case, I asked them disease level, and I could not sleep at all due to discomfort. It is a common scenario, but we cannot estimate anything from this ABPM data in nocturnal blood pressure or dipping pattern of variability. It is not only case of my patient. The overall case, it is extremely difficult to persuade patient to repeat their ABPM, and more than 50% of patients replicated dipping non-dipping phenotype do not replicate at the second ABPM. So dipping pattern is difficult to correctly measure in 1 or 2 times, and the replicated examination is extremely difficult. So we have no unmet need in nocturnal blood pressure monitoring in hypertension measurement. So there are many various technology are entering the market or research base to measure the patient blood pressure continuously. I do not need to repetitively explain because Professor Kim already excellently explained. So currently there are two PPG-based blood pressure measuring watch in Korea market, but there is no watch in Apple technology that clearly represents the two waves. One is the positive aspect, and one is skepticism about watch-based, couplings-based blood pressure measurement. So let me briefly explain the current history of couplings blood pressure monitoring using the couplings device and smartwatch-based blood pressure monitoring. This technology comes from 2013. So before 10 years ago, they first started to adopting smartwatch or smartphone device in the blood pressure measurement. In the initial period, the measurement result presented as a range rather than actual blood pressure value. From 2016 to 2018, approaching the medical term like explanation, the mean value and standard deviation, but still they are compared to the gold standard brachial curve-based blood pressure monitoring, the difference is over 2 digits. But after 2018, they are meeting the previous AAMI standard, 5 plus minus 8 millimeter mercury. And 2021, Korea government sometimes progress very rapidly. So in 2021, Korea FDA permitted watch-based blood pressure measurement as a medical purpose. It is the background data of that kind of permission. One is the over 85 subjects examined in the USA. The mean standard deviation is 0.1 plus minus 7.4, and within acceptance criteria is fully meet the criteria. It is the overall data, but overall result is quite good. There are some degree of underestimation and overestimation in the extreme part of blood pressure, but we can clearly overcome this difference if we have adequate data in the extreme high blood pressure or low blood pressure. But regrettably, the Galaxy Watch do not proceed one step more as a major in medical device. And Brand Altman solution show the same tendency: low blood pressure, slight overestimation, and underestimation. There are so while Galaxy Watch and watch-based blood pressure measurement device are staying in the same position, other type is more innovative approach, fully devoted to their ability as a medical device. The ring-type blood pressure monitoring device developed based on the over 2,000 A-line blood pressure value collected in Seoul National University operation room. So they made algorithm and tracking the blood pressure change according to the pattern of blood pressure, blood vessel volume change. So first approval data studied in Samsung Medical School. They sufficiently passed the criteria and I value is excellent. But initial algorithm, the one scientist found the correlation between SBP and DBP is over 0.99. That means in DBP tracking algorithm, they reflected the SBP mimicking algorithm. That is natural because in the operation room, usually SBP elevation are corresponded by DBP elevation. So after the revision of algorithm, currently the correlation between SBP and DBP is near 0.7. So we clearly discriminate the tracking algorithm between SBP and DBP. But so we have two tools. One is ring-based blood pressure monitoring device and watch-based blood pressure monitoring. The common aspect is wearable device, and it needs cuff calibration. But different position is watch-based blood pressure monitoring. The closing the continuous blood pressure mode is autonomic measurement function, because if autonomic measurement function is open, it may consume the battery life significantly. So they do not measure the nocturnal blood pressure pattern by current mechanism. But cut blood pressure, ring type blood pressure can measure blood pressure every 30 seconds. So it can calculate over 24-hour value. I show you the example of 24-hour blood pressure measurement result. But as all of you know, the national guidelines still approach the very conservative one. We need more data. In case of 3, usually interpreted 2 parts. It may be harm, and we cannot apply in the routine practice because of lack of evidence. So one of the good things of coupleless blood pressure monitoring device is does not harm to any patient condition, like the putting hazard material in the body, just the wrong result. So we can more freedom to applying in the medical device and feedback by feedbacking real world result in the improvement algorithm, like the discrimination of SBP and DBP value in the current, the initial algorithm into currently independent tracking mechanism. So European Society of Hypertension suggested 5 essential components to make to one step forward as a medical department. Now we are near completing 3 parts. The first part is already passed by using static blood pressure protocol. We are near completing device position test and treatment test, and now I can show you the sleep test as a function of ABPM monitoring, and Samsung Medical School are currently doing the exercise test. So I think it need not be done completely, because if we cannot fulfill the exercise test, we can discard the usage and in this kind of exercise blood pressure measurement. So it is the typical result of comparing conventional ABPM data and coupleless blood pressure monitoring data. As you see, there are clearly show the tendency. The ABPM blood pressure monitoring, they are abrupt rise, abrupt falling of blood pressure. But coupleless blood pressure, PPG-based monitoring device make still somewhat modest change in abrupt falling and increase. It may come from the distal part arteriole rather than brachial artery. So there are inevitable difference between brachial artery-based blood pressure measurement and finger artery-based blood pressure measurement. But one good thing is like that. The typically ABPM data recorded blood pressure monitor every 20 minutes, but many Korean hospitals measured nocturnal blood pressure every 30 minutes because discomfort in sleep. So at best, 60 times of blood pressure measurement was done during 24 hours. But the small dot represents the data recorded by coupleless blood pressure. The average blood pressure measurement number is over 200 times. So 20 times of blood pressure measurement and 200 times blood pressure measurement. So you can 10 times more data in 24-hour blood pressure data. It is the initial data of 33 patient value. Among them, 21% patients belong to the hypertensive range, and 20% of them treated with multiple drug therapy. So there are difference. First, ABPM and ring type blood pressure monitoring data, they can somewhat modest blood pressure change, but the correlation is 0.730, and overall correlation is over 0.9 and 0.84, and Brand Altman solution from 110 to 150, 70 to 110, there are no sign of deviation in the low to high blood pressure range. And in terms of nighttime, daytime change tendency in compared to the brachial artery based blood pressure monitoring and ring type blood pressure monitoring, the R value is still acceptable in 0.7. So next time we evaluate the interaction, possible interaction of age, sex, and medication. Somewhat argued in ring type coupled device might not correctly measure blood pressure in the old age or female with exaggerated hormonal response according to menstrual cycle or medication. But regardless of age, sex, and medication or their combination, the R value are still nearly same, and there is no sign of possible interaction between age, sex, or medication. We all know, and I particularly pointed out, in terms of coupled blood pressure monitoring, one of the most important parts is initial calibration. If calibration was not done adequately, it can greatly change the blood pressure value. So some scientists suggested the artificial 3-point calibration, like sitting position, standing position, and supine position. We made 2 times of sitting position, standing position, supine position, and merging all 3 one, and compare the result, which position and which combination of position of validation with bestly measure the correlate blood pressure pattern in calibration position, but there is no significant difference. That is good sign. That means if the skip technician or doctor come into calibration position, just the sitting position after sufficient rest, no further measurement, no further indication like sitting or spine is needed to adequately measure nocturnal blood pressure or daytime blood pressure. We just sit silently and fully resting condition and calibration 2 times. Will be no difference in the artificial 3-point calibration. It is very interesting one. The value is the difference in ABPM value and cut blood pressure value just after ABPM value acquisition time. In daytime, cut BP value just after ABPM inflation is lowering by 3 millimeter mercury. In night time, higher in 2 millimeter mercury. Let me explain the situation. In the daytime, one person walking the street and suddenly ABPM began to inflate. Usually they stop the walking and resting for them. That resulted in the lowering blood pressure just after the ABPM inflation. In the night time, we naturally can think the nighttime ABPM inflation, patient wake up, and that means the inflation of elevation of blood pressure just after the blood measurement. That means we can argue, until now, we try to match ring-time coupled blood pressure measurement data, the gold standard ABPM data. But I can argue ABPM measurement data is not adequately measure 24-hour blood pressure correctively. In the night time, ABPM couple inflation cause the elevation of blood pressure. In the daytime, if one feel the elevation of inflation of cup, they can usually stop the motion and make the artificially lowering blood pressure. So now, one good thing is ring-type blood pressure monitoring device is now reimbursed in Korea as an alternative ABPM device. In Korea, ABPM examination cost is very cheap, near lower than $10. So by cost, in terms of cost, we can safely replicate ABPM monitoring using coupled blood pressure annually because it did not make any little discomfort during measurement. In times are changing, so other usual people very open to the accuracy of the coupled device. Only 1/3 of them actually thought it is very accurate, but 2/3 of them they can use it as a medical purpose in terms of because it is convenient. And one of the good things is not only ring type device, even Galaxy Watch device, we can measure 1.5 times a day in user, and 16% of patients can measure blood pressure every day. We cannot do that by conventional brachial artery or wrist type blood pressure measurement device by using this data. It is my favorite topic in Korean Society of Hypertension position statement. Currently, all the measurement is based on static blood pressure measurement, but we can, by using coupleless blood pressure measurement device, we can now start the way toward to the dynamic blood pressure evaluation and management. And Japan scientists already begin to check the relation of change and their long-term outcome. Everyone knows this year is our 30th anniversary of Korean Society of Hypertension, so our society is very ambitiously designing the outcome study of using coupleless ambulatory blood pressure monitoring guided hypertension evaluation treatment. Tentative name is Cabinet. By conducting annual assessment of 24-hour blood pressure with coupleless monitoring. So hypothesis is that group maintaining ambulatory system pressure daytime, nighttime, average blood pressure, we experience fewer cardiovascular events over 4 hours compared to the office blood pressure targeting group under 140 millimeter mercury. As you know, 4 hours is not a sufficient time. We have to require near 10,000 patients. So it must be very hard task, but annually our society started ambitious one. Firstly, perform the first outcome trial in hypertension field in using coupleless device. Thank you very much for your attention.
Thank you, Dr. Yu. Your valuable lecture is ongoing progress. Okay. It's time for the panel discussion. We have 3 distinguished panel. One from the Jong Sin-woo from the Kyung University, and Jin Ju-bak from Seoul National University, and Hang Young Kim from Seoul National University. Would you please first, Dr. Kim?
Thank you very much for your wonderful and very informative lectures. I am very exciting after the listening the lecture of the Professor Chang. I want to ask the Professor Chang about the new technology for the measurement of central blood pressure. The Professor Chang showed the slide about very flexible sensors to measure blood pressure in the wrist. If this device can apply to the measurement of central blood pressure, especially for this flexible sensor can detect the carotid artery hemodynamics by just patching in the neck or in the chest for the central aortic pressure, it is very promising for the measurement of central blood pressure non-invasively. But some direct measurement. Could you please give me some information about this, Professor Chang?
Thank you for the important question, but I think this kind of new technologies have been developed during the past few years or few decades in the improvement of blood pressure measurement, especially using PPG or PTT, something like that, including the new technologies in the measurement using ultrasound. This was very interesting and also seems to be promising, but nevertheless, we have to be considered about the the validation of these kind of devices. But currently, we still just have this kind of validation protocols for these kind of coughless devices, but it's still very complicated to do the validation. So the previous validation, the ISO, AMI, and the ESH guideline or the protocol is still on the traditional blood pressure measurement devices, or whether it's oscillometric or quarter of sound devices. But currently, whether you use coughless, which kind of coughless, ultrasound, or maybe the PPD test, or something like that, is still based on the previous protocols. It seems to be accurate, but still cannot be applied to the daily clinical practice. It's still a research area. But anyway, I think it's promising if you can use the new protocols to do the validation test, whether it's skin, soft devices, or using the ultrasound, something like that. So this is the emerging thing. I think it will be go through strict examination on the validation of these studies. Thank you.
Is the distance from the skin and the vessel, like carotid artery and the aorta, is the problematic in this device?
Well, I think it's something like the devices developed by previously developed by Professor Michael Oak on the test of these wrist area to estimate. It's still estimated the essential blood pressure. It's now in use that we use that in our daily clinical practice, but have not been widely used because in the estimation of the essential blood pressure is even more important in younger subjects rather than the elderly patient, because maybe in the younger subjects, these patients may have the subject may have the spural hypertension, which means the peripheral blood pressure is high, but the central blood pressure is relatively lower, which may not be that harm. Thank you.
Thank you very much for the wonderful lectures of all speakers. And I have a question to Professor Lee. We saw that there was an evolution of blood pressure monitoring in the last, let's say, 200 years. And the latest development seems to be the cuffless devices with the ring type. You showed us that there was difference in the blood pressure between the cuffless and the ABPM, traditional ABPM, about less than 3 millimeter mercury. And how clinically important is this number 3 or 2 millimeter mercury? Because when you treat your patient in your office, when you measure your blood pressure, you are not that accurate at measuring blood pressure. Let's say 123, 125. I think it's the same. And the second question is, if you have this difference between the ambulatory BP monitoring device and the cuffless one, and there's this difference of 3 millimeter mercury, which one is correct? Do you think the ABPM is the correct one or the cuffless one?
Yes, that's completely agree with you. I think 2 or 3 millimeter mercury is not a significant value of clinical judgment. But currently, we do not have adequate tool to measure nocturnal blood pressure or dipping pattern repeatedly. Now, our hospital make a protocol in every patient to making ABPM. We perceive them to attach the ring type device simultaneously without charge. Ring type device for 48 hours and ABPM just 1 day. 2 days ABPM. Cuffless device monitoring device value is very different. So that means ABPM make quite remarkable discomfort during measurement. So I do agree, rather than 2 or 3 millimeter mercury of technical error, it is more important to finally we can measure the nocturnal blood pressure and variability. That's why I'm quite positive of this new technology. Thank you very much for the asking.
Professor Lee, one moment, please. So I'm very interested for your investigation, and as you're the main investigator of this device, so what would you like to expect the future of this machine by the basis of your experience about the advantage and disadvantage? What would you like to comment for that?
Previously I made very positive aspect of this device. In the negative aspect, this one is we need very meticulous initial validation process. In our experiment, our technician made special attention to the attachment to ABPM device and calibration. So now there are possibility of a very wide infiltration of ring type device in the previous private clinic because cost is not a barrier. But without the meticulous validation process, you cannot acquire adequate signal, or the result is very insufficient. So as Professor Sturgeon suggested, in some days in the near future, there are validation-free coupled device will be developed because in our human nature is not so different to the people to people. So if we input the age, sex, ethnicity, and some other variable, we can reach the validation fully coupled device finally. But currently, one of very important cause of potential harm is the initial error in validation process. We should pay special attention to the initial validation.
Yeah. Thank you. Dr. Wu, please.
Yes. Thank you for wonderful lectures. I want to ask a question to Dr. Asayama. It would be a similar question as Dongjin Kim's question. I would like to ask your opinion on whether the new blood pressure measurement technology will only serve as a complementary role to ABPM or home BP monitoring, or whether they can become game changer in the future.
Thank you very much for the question. Indeed, I am the member of the ISO committee of the blood pressure clinical validation processes, and also in Japan. And yes, because the validation still needs a frequent validation process, even in such a ring device or other watch devices, others. And I remember the failure of the Actia device. It could not measure nighttime blood pressure accurately compared with other cuff devices. But at least at the first initial phase, Actia device can pass the validation process officially provided by a third party, such as a very prestigious investigators. Therefore, even the ISO, the most recent standard is only partly approved by the American FDA and not fully approved because of the lot of issues to be passed for the so-called DASH3 the protocol. And also in Japan, these devices should be each approved by the government agency such as PMDA. And very recently, only one device was just approved in Japan and will be marketed in next year, I suppose. And it will be evaluated by a lot of patients, a lot of investigators, and a lot of people in clinical practice. And then we can provide the next perspective on that. Of course, I expect to drastically change the world, but not so early in real. Therefore, we wait for coming further evidence.
Okay. Oh, yeah. Yes,
I have one more question. Yes. In your international home BP or the ABPM data court, usually the nocturnal blood pressure was measured using ABPM.
Only
However, you
ABPM,
know
yes.
that the ABPM is cause some discomfort to the patient. So I know there's some wrist device developed in Japan is very accurate and validate in the measurement of nocturnal blood pressure. So do you use this wrist device in the measurement of nighttime blood pressure in Japan?
Well, first, please note that the IDACO population baseline is before 2000 year. Therefore, at that moment, only upper arm cuff device is available for ambient blood pressure. And lift cuff device is still less reliable, less accurate compared with upper arm cuff device. It is definitely true. But of course, it is tended to be within the acceptable ranges for the fundamental errors. Therefore, of course, it's the best advantage of the wrist cuff device is low noise and less interrupt for the sleep, sleep disturbance. Therefore, we expect very much the wrist device advancement of wrist device very much. However, this is still using cuff technologies. Therefore, compared with such a cuff wrist device and cuffless technology devices would be the future issues.
Yeah, thank you very much, Dr. Asayama. So, is there any other questions or comments from floor? Okay, so before closing this session, on behalf of our society, I will give you plaque of appreciation to international speakers. Dr. Asama and Dr. Zhang, come up the stage, please.
Okay. Yeah. Yes. Dr. K. Asama, in deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024 in conjugation with the 61st scientific meeting of the KSH, November 9th, 2024. Eugene Jiang, in deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024 in conjugation with the 61st scientific meeting of the KSH, November 9th.
Good afternoon, ladies and gentlemen. Welcome to Precision Medicine and Hypertension, DAI Revolution session. I'm Seung-Gil from Yuha Women's University, and Professor Jang Bae from Korean University will co-chair with me. And I will introduce two speakers first, and then Professor Bae will introduce the next two speakers and lead the discussions. I'd like to introduce the first lecture by Ki-yeon Jeon from Seoul National University. The title of the lecture is Artificial Intelligence in Hypertension Management. Please.
Thank you, Chairman. Good afternoon, ladies and gentlemen. I'm K.H. Jeon from SNU Bundang Hospital. It's a great honor to be here in this such an interesting session. I'm going to talk about the AI in hypertension management. So today I will discuss how AI can be used to improve hypertension management and the role of the large language model, such as ChatGPT, in hypertension management. So this table provides a concise overview of potential application of AI in hypertension management. Using AI, we can predict the development of hypertension and assist in its diagnosis. And AI can also be applied to monitors and predict blood pressure trend, and it can assess the risk of cardiovascular event in the patient with hypertension. I will now introduce some key studies that support each of these applications. So this study focused on the prediction of development of hypertension. It involves a machine learning model trained on patient data from the electronic health record to predict the likelihood of hypertension development within 1 month. And the patient data used in this study includes diagnosis of 30 chronic disease, lung and liver, and cardiovascular kidney, and other metabolic disease, diabetes, and 2 demographic features of gender and age, and medication history, laboratory finding, and socioeconomic factors, and healthcare expenditure data. They trained the machine learning model on this comprehensive data set to predict the risk of hypertension onset within 1 year. Based on the model's prediction, the patient was categorized into 5 risk groups, ranged from very low risk to very high risk. On the distribution of risk group, we can see the clear difference based on the age, and Kaplan-Meier curve on the left side represented the very low risk group, and right is very high risk group, and high risk group according to the comorbidity such as DM or repeat disorder. The distinct pattern in the hypertension onset across these groups indicated significant difference according to the risk group as identified by the machine learning model. And this study also focused on hypertension prediction, utilized the large-scale model based on data from 4 million individuals, and it is a cross-sectional study, and the model predicts hypertension using variable data such as age, gender, and blood pressure, waist circumference, lifestyle factor, and laboratory findings. And in this study, researchers developed various models, including random forest and boosting model. The most model achieved an AUC of 0.85, indicating a strong predictive performance. And age and waist circumference and ECG finding emerging as a key feature in the analysis to predict hypertension onset. And the next study focused on the hypertension diagnosis, specifically addressing masked hypertension, which is often challenging to detect in the clinical setting. Detecting masked hypertension typically require tests like 24 hours ABPM, and in this study, researchers developed a model using clinical data to diagnose hypertension with a random forest model achieving the highest performance with AUC 0.85. This tool could enable clinicians to identify the masked hypertension cases where patients present with normal blood pressure in clinic office, helping us to suspect and detect hypertension more effectively. And next, on AI application in blood pressure measurement. Recently, many coupleless blood pressure measurement devices were developed, and many of these devices require periodic calibration with traditional cup-based blood pressure monitors, and the accuracy issue a common concern. Recently, the new devices have been developed that measure both ECGs and PPG signal simultaneously. By merging this data signal, they produce several metrics that can be used to estimate blood pressure by using machine learning. And so the AI is essential for process and training model on this data, making it possible to generate accurate blood pressure measurement with these advanced devices. These groups show the difference between the blood pressure measurement obtained from this device, the simultaneous device, and standard cuff-based monitoring. The distribution of this difference across the entire group is shown here, with a difference of the most patients were within 5 mmHg range. The difference of real blood pressure and device pressures. And this study focused on predicting blood pressure after hypertension treatment. Researchers developed and validated a model based on 1,000 of patients, and the model demonstrated a mean absolute error of approximately 8 mmHg for systolic blood pressure prediction compared to actual ABPM measurement. Additionally, the correlation between the predicted and actual value are strong, with an R values around 0.72, while there are still some accuracy limitation. But this model could be highly beneficial for identifying pattern in blood pressure response following treatment with antihypertensive medications. So next study is focused on the model predicting cardiovascular event in patients with hypertension. Numerous models have been developed to predict CV risk, and ACC-AHA CVD risk model is one of the most well-known and widely validated model. This study compared the predictive performance of new machine learning model against established ACC-AHA risk prediction model. So the machine learning model trained on data from the MESA registry and validated with Flamingo registry demonstrate higher sensitivity and specificity, and the AUC was 0.93. An interesting finding from this study is difference in statin recommendation between the model. The new machine learning models identified only 11% of patients as high risk and in need of statin therapy, compared to 47% 6% classified as high risk by the traditional ACC-AHA model. Among the patients who actually experienced the CV event, the machine learning model has a significant lower rate of false negative, meaning it more accurately identifies those truly in need of statins. This suggests that the machine learning model can help reduce unnecessary statin use and support more precise and personalized preventive care. So many studies on AI-based prediction model emphasize the need of external validation in a different group across the different ethnicities and different countries. However, I no longer fully agree with this approach. It is not necessary to create a model that fits everyone all over the world. Instead, we should focus on developing models tailored to our specific patient population. So this is support that viewpoint. Using our Korean National Health Information Database, this model was developed from data on 3 million patients in South Korea. And the deep learning model achieved impressive AUC value, 0.93 for predicting CVD hospitalization, and 0.97 for CV deaths, and 9.3 for both combined. And additionally, it predicts accurate for myocardial infarction and stroke. Then AUC reached 0.97, while this model may have reduced the accuracy if applied to the African American in United States. That is not a concern. In my view, if a model performed well within the population we made, that should be sufficient. This in my personal opinion. So now let's move on to the ChatGPT. ChatGPT has become remarkably smarter as time goes by. The study on the left side used ChatGPT 3.5 to take the USMLE exam published in February last year, where it barely passed the cutoff score of 60. However, in the study published in October last year, using GPT-4, it achieved nearly perfect score. So at this point, GPT's medical knowledge was superior that of most physicians. So what can GPT contribute to hypertension management? ChatGPT can offer personalized treatment recommendation and assist in the risk stratification, and it can also help interpretation of clinical guideline and support patient education and serve as reference for clinical decision making. And additionally, GPT can be widely applied in the patient monitoring and research related to hypertension. So this study shows how accurately ChatGPT could answer 100 questions related to hypertension. GPT provides correct answer for 93 out of 100 questions. Is slightly outperforming the physician who answered 92 questions correctly. Although GPT sometimes produces variable responses, raising concern about reproducibility, but this study demonstrates a high reproducibility rate of 93 in ChatGPT. So let me show you how to tune the GPT into the hypertension expert. The OpenAI now offers the service called customized GPTs, which allows users to create specialized models. By setting targeted instruction like this, you can design the GPT specialized focused on hypertension. So I say to GPT, you are an expert on hypertension and you have extensive knowledge of hypertension guideline, and I provide ACC and ESC and Korean hypertension guideline. And for patient case, you provide appropriate recommendation based on the Korean guideline. So now we can make hypertension expert GPT, like this. And the key feature here is ability to upload the reference file along GPT to use this as its primary source. I upload the hypertension guideline, Korean guideline, ESC guideline, ACC guideline, and to create customized hypertension expert GPTs. And next, I provide a patient case for model to evaluate and recommend the treatment option. The patient is 72 years old male and history of hypertension and diabetes. Despite taking 5 milligram amlodipine, his official blood pressure remained 154 and 88, and the laboratory result indicate CKD. And the task for the customized GPT was to assess this patient and provide treatment recommendation based on his clinical profile. So it make answer like this. So let's see. Here are the results. The customized GPT determined that patient blood pressure is above target level according to 2018 Korean hypertension guideline, which is recommended lower blood pressure below 130 per 80 for patient with diabetes and CVD, and due to the kidney involvement, it suggests the addition of RAS blockade for the patient. And the model also recommends managing diabetes and renal protection following a low-salt diet, and emphasize the importance of regular follow-up and monitoring. Additionally, it advises referring the patient to specialists such as nephrologist, endocrinologist, and provide detailed patient education on this point. And customized GPT model can effectively summarize and compare guidelines. For instance, when asked about the target blood pressure in diabetic patient, the model can present well-organized table detailing recommendation from various guidelines. So let me see. This is 2080 Korean guideline. And updated 22 hypertension guideline in Korea, and ACC guideline, it show 130 and 80, ES guideline, and make a table like this. And additionally, it can provide detailed comparison between 2080 and 2024 ESH hypertension guideline, recently updated, and highlighting the key updates and changes. This capability enhances clinical decision making by offering relevant information. So we can upload the two guidelines, and it compares and show the change of new guideline like this, and the detailed information like this. So, ladies and gentlemen, I would like to wrap up my talk. The AI can significantly improve the hypertension management by predicting development hypertension and diagnosing earlier, and making blood pressure measurement more accurately. So it also helps predicting CV risk in patients with hypertension, and allow for more personalized and proactive treatment. And tools like GPTs, the LLM, support clinician by simplifying the hypertension guideline and helping with clinical decision making. The integrating AI in managing hypertension has the potential to improve diagnosis and tailor treatment and enhance patient outcome. And we should be considered the ethical and data privacy concern must be carefully managed. Thank you.
Thank you for your excellent lecture. And I'd like to introduce the next lecture by Professor Akihiro Nomura from Kanazawa University, Japan. He works as a cardiologist staff and also research about the application of digital health technology and machine learning to CV medicine. He will give us a lecture about digital therapeutics on hypertension and chronic disease. Please.
Okay. Thank you very much for a kind introduction. So it's a great honor to be able to talk about the data therapeutics for hypertension and chronic disease. Also, the congratulations on the 13th anniversary of the KSH. So this is my disclosure. Okay. So first of all, I briefly describe the definition of data therapeutics. So the data therapeutics, also known as the DTX, is a health software intended to treat or alleviate a disease, disorder, condition, or injury. So the DTX recently has a more broader meanings containing a disease prevention and diagnosis. So in addition, the DTX delivers a medical intervention that has a demonstrable positive therapeutic impact that is a kind of clinical evidence on the patient health. Also, DTX has the strength of providing a medical intervention in a patient's daily life through a mobile device. So now a smartphone is dominating the DTX platform, and the DTX using virtual reality with a head-mount display are also being developed. Okay. So as an example of current DTX, I introduced two data therapeutics management applications around the world. So the first one is the blodtryck doctrine, the Swedish language meaning the blood pressure doctor here. So the Swedish DTX system provides an insurance-covered hypertension management program through a smartphone app and online coaching with medication prescription. So this slide shows a retrospective study evaluating the effectiveness of the hypertension management program using the blodtryck doctrine app. So this study cohort included 7,752 participants receiving the program. The mean age was around 47 years old, and 50.6% were male, and antihypertensive medication could be issued through the app when necessary. So the primary endpoint of the mean changes in the SPP from baseline to 1 year was around minus 13.8 millimeter mercury for the high baseline SPP groups. So also the baseline SPP stratified analysis in the right figure shown here, the higher the SPP at the baseline, shown in the blue line, so here, the greater SPP reduction effects. So the second example is a Hello Heart, providing the data hypertension management service for specific corporate health insurance employees in the United States. So this Hello Heart smartphone app paired with the freely delivered the home blood pressure monitoring, incorporating the personal health records, including the blood pressure, body weight, and activity tracking records. So this program also involved on-demand digital coaching delivered from the guideline-based recommendations for non-pharmacological interventions to promote healthy lifestyle, daily dietary habits, the physical activity, stress reduction, and medication adherence. So moreover, the AI-based algorithms create a highly personalized user experience by considering the patient characteristics, patient usage patterns, and patient feedback. Okay. So here's a retrospective study resulting to assess the effectiveness of the Hello Heart hypertension management service. So this study cohort included more than 28,000 corporate health insurance employees from 21 companies using the Hello Heart service. So also it should be cautious that this study did not consider the antihypertensive medication status of each participant during the study. The primary endpoint, mean change in SBP at 3 years, was minus 17.2 millimeter mercury for elevated baseline BP group. So minus 12 to 0.2 millimeter mercury for grade 1 hypertension at baseline, and minus 20.9 millimeter mercury for grade 2 hypertension at baseline. So furthermore, the authors mentioned that the higher the hypertension management program adherence, the larger the blood pressure reduction effect. Okay. So moreover, the Harrow Heart investigated the effectiveness of the Apple-based lifestyle modification service beyond the blood pressure reduction. So in this latest study, the over 100,000 corporate health insurance employees were enrolled to assess the effectiveness of the service on the cholesterol and body weight. So again, it should be cautious that the cholesterol analysis cohort was only included just 1,006 participants, the 1.6% from the entire cohort. That also showed that total cholesterol was reduced by minus 29 milligram per deciliter. The LDL cholesterol by minus 26, and the body weight by minus 4.3 kilogram. So this effect was again significantly affected by the baseline values, and the Apple engagement and the means the Apple engagement, that means the continuous and the frequent measurement and the input to the Apple, was one of the strong key factors for reducing each value. So now I move on to the DTX Apple that has already been cleared by the regulatory authority in Japan. So as of November 2024, we have 3 DTX medical devices in Japan. The first one is a DTX system for tobacco use disorder. The second one is a DTX application for hypertension. And the third one is a DTX application for insomnia. So next slides are going to focus on the Cure Up HD DTX Apple for hypertension in the center one. So the DTX Apple for hypertension was approved and reimbursed in Japan in 2022. So this DTX Apple aims to address the treatment gap between the outpatient clinic visits for hypertension management. So by using the Apple, shown here, it promotes awareness of hypertension and complications through the connection with home blood pressure monitoring. So to efficiently support lifestyle modification that is recommended for all hypertensive patients in the guidelines, so this DTX Apple was developed to maximize the effect of non-pharmacological treatment in 6 months. So also the information is shared with the healthcare providers through a web application, and then can provide medical advice to patients based on the data during their regular clinic visits. Okay. So this slide shows what the Apple supported lifestyle modification through cognitive behavioral therapy, the CBT is. So this DTX Apple includes 6 clinically effective non-pharmacological treatment: the salt intake reduction, so body weight control, the alcohol reduction, the promoting exercise, the stress coping, and good sleep. So through the Apple, the hypertension patient can take an interactive education session about the importance of non-pharmacological treatment first as a step 1, shown here. So then, with Apple support, the patients are encouraged to execute each lifestyle modification component as step 2, shown here. Finally, the goal is for the patient to set their own modification plans, practice, and evaluate the non-pharmacological treatment, and incorporate a good lifestyle into their true habit as step 3. So I'm going to show you the HARP DH1 pivotal trial evaluating the efficacy of the DTX Apple for hypertension. The total of 390 antihypertensive medication naive patients aged under 65 years old with essential hypertension were randomly allocated to either the DTX group, using the DTX Apple for hypertension, adding to the guideline-based hypertension management, or the control group, only receiving the guideline-based hypertension education. So the primary endpoint was a mean change in 24-hour SPP from baseline to week 12, and the patient was followed up for up to 24 weeks. So this slide shows the key result of the HARP DH1 trial. So the primary endpoint, the mean change in 24-hour SPP from baseline to week 12, was significantly greater in the DTX group than the control group. Also, the key secondary endpoint, the patient in the DTX group clearly showed a significantly greater reduction from the baseline to week 12. The DTX group was a minus 10.6 millimeter Hg, and the control group was a minus 6.2 millimeter mercury. Also, the OPS SBP demonstrated the same trend between the groups, shown here. Okay, so now let's look at which specific features of our DTX intervention were most effective in lowering blood pressure beyond just looking at the overall result. So in our previous trial, we noticed that the two interesting patterns, the BMI and salt intake scores, seems to be linked to how well patients responded to the treatments. So as shown on the slide, our additional analysis revealed that the patient who started with higher BMI and or the higher salt intake scores showed a particularly strong improvement in their blood pressure when using a DTX apple. So furthermore, we found that the successful blood pressure reduction was not only associated with their baseline values, but also depended on actually achieving the reductions in BMI and salt intake during the intervention period. So based on this trial results, the DTX app for hypertension received a regulatory approval from the Ministry of Health, Labor and Welfare in Japan as the world's first therapeutic software as a medical device for the treatment of hypertension in April 2022. So then it was also reimbursed by public insurance in Japan. So in addition to obtaining regulatory approval in Japan, the Cure app is now developing a US adapted version of the hypertension DTX platform named the commemorate. So this initiative aims to validate the efficacy of the hypertension management concept and implement the service in the population with different racial backgrounds, the languages, the religious beliefs, and the dietary and exercise habits. So since the approval and reimbursement of the DTX for hypertension in Japan, so thousands of patients with essential hypertension have been treated using the DTX app. However, there is still limited knowledge regarding its effectiveness in the real-world settings, especially concerning the impact of patients aged over 65 years old and its add-on effect for medication users. So therefore, in the next study, we assess the blood pressure changes in the first 1,000 patients prescribed the DTX app for hypertension using the de-identified practice-based real-world data of QApp HD cohort. So moreover, we extended our investigation to include the populations previously excluded from the HARP DH1 pivotal trial, specifically elderly individuals aged 65 and above, and those who have been taking medication at the time of DTX prescription. So this slide shows the baseline characteristics of the eligible 1,000 patients in the cohort. So the median follow-up duration was 160 days, and the mean age was 54.8 years, and the females are 48.9%. So the baseline morning home SBP was about 133, and the DGP is around 86 millimeter mercury. So this slide demonstrates the primary endpoint of the changes in morning home SBP from baseline. So at week 12, the changes from the baseline were minus 4.9 millimeter Hg and minus 6.1 millimeter Hg at week 24. Shown here. So when we compare these findings with those of the historical HARP DH1 pivotal trial control group, the DTX users in this cohort also showed the significantly larger reductions of morning home SBP at both week 12 and 24. So next, this slide shows the transitions in the morning home crude SBPs and the changes in morning home SBP from baseline, stratified by the baseline morning home SBP values shown in the x-axis here. So the effect of SBP reduction was significantly impacted by the baseline morning home SBP levels. So the higher the morning home SBP at the baseline, the larger the reduction in SBP levels that DTX users receives. Now also when we compare the HARP DH1 intervention group data shown in the right side, whose baseline SBP was around 147, So with that of the 140 to 150, so a category in this study whose baseline SPP was around 144. It's almost the same baseline. So we found that the reduction in SPP level at week 12, the yellow line shown here, and week 24, shown in the red line, were relatively consistent in these two categories. Okay. So finally, we evaluated the variations in changes in morning home SPP by subgroups. So there was consistent SPP reduction effect across all subgroups except the Apple engagement rate category, shown just here. So based on this result, we may demonstrate the pragmatic benefit of DTX for hypertension for patients aged 65 years or older, shown in this category here, the same effect size. And also the receiving medication at baseline, this medication usage, yes, this one categories. So which are specific patient populations excluded from in the previous, HARP-DH1 pivotal trial. So also the group with a poor Apple engagement rate did not show a significant decrease in the reduction of morning home SPP at week 24. So here. Okay. So I'd like to summarize this real-world cohort study. So the significant reductions in morning home SPP from baseline were observed at both week 12 and week 24. So that was surpassing those in the historical HARP-DH1 control group. Then also the DTX Apple for hypertension demonstrated the pragmatic benefit for hypertension patients, especially among the elderly and those on medication, the populations previously excluded from the HARP-DH1 trial. Now also this study has some limitations, so data are only limited in the 6 months in the reimbursement period. Now also the result from the low Apple engagement subgroup might be just influenced by the small sample size with a larger 95% confidence intervals. So in conclusion, the DTX and the DSAT service for hypertension has already implemented in several countries, including Japan. So the lifestyle modification for hypertension have entered a new era with DTX application. Now also in this RW cohort analysis shown in the last part using the DTX for hypertension, we might demonstrate the effectiveness of the DTX across various patient groups. However, further evidence related to the DTX safety and efficacy are still needed. So thank you very much for your attention.
Thank you very much, Dr. Nomura. We have discussion after all the speakers' lectures. I'm Jang Obe, co-chair of this session with Dr. Seung-gi Ryu. And I'm very pleased to introduce the next very interesting topics titled Novel Technology of BP Monitoring by Dr. Kyung-jin Kim from Ewha Women's University. Actually, he works in cardiology, especially in the heart failure and heart transplantation teams. Dr. Kim, please.
Yes, thank you for the introduction, Chairman. My name is Kyung-jin Kim from Ewha Women's University Medical Center, Mokdong Hospital. Today, I will be presenting on the topic of novel technology of BP monitoring. The history of blood pressure measurement dates back about 300 years. In 1733, Stephen Hayes was the first individual to measure blood pressure levels by inserting a glass tube into an artery of a horse. Importantly, he also noted that the blood would rise and fall at and after each pulse by 2 or 3 or 4 inches. This observation not only signifies the pulsatility of blood flow, but also indicates the variable nature of BP levels. Subsequently, there have been many efforts to make blood pressure measurements more convenient. In the beginning, similar to Hayes' method, invasive techniques were used where one side of the tube contained mercury and the other side was inserted into the artery. Later, non-invasive devices were developed based on the principle that blood pressure could be indirectly measured by determining the pressure required to stop the artery's pulse. The development of non-invasive blood pressure measurement devices had continued over the centuries up to the present day, and currently, the two most commonly used methods are the auscultation method and the oscillometric method. The auscultation method involves a healthcare professional listening to the sound produced by the blood flow in a compressed artery using a stethoscope to measure systolic and diastolic pressure. The oscillometry method used in the autonomic blood pressure device is based on the principle that the amplitude of blood flow oscillation changes depending on the cup pressure. When air is pumped into the cup, the pressure becomes higher than the pressure generated by the heart pump, temporarily blocking the blood flow. And as the cup pressure gradually decreases, blood flow resumes, then oscillating with each pulse of the heart. By analyzing the maximum amplitude of these oscillations, the vibration ratio, and other standard indicators, blood pressure can be derived. However, these two methods are primarily used to measure blood pressure during visit to hospital. At present, office BP measurement is arguably the most common procedure in medical practice. However, the intrinsic dynamic nature of BP remains underappreciated. On a B2B basis, BP levels can vary markedly from -24 to 33 in response to usual extrinsic and behavioral factors. The degree of BP variability also differs between individuals in the short term and long term. From the first landmark 1967 Veteran Administration Cooperative Study to the 2021 Spring Trial, although all outcomes trials in hypertension have used the average of snapshot BP levels to demonstrate the efficacy of the antihypertensive drug, accumulating evidence have highlighted the clinical relevance of BP variability and circadian rhythm beyond the effect of average BP levels on cardiovascular outcomes. This study demonstrates that in elderly hypertensive patients, the presence of morning surge in blood pressure is associated with a higher risk of stroke. This study involved around 500 elderly hypertensive patients who underwent blood pressure measurement using ABPM and were prospectively followed for stroke through brain MRI. At baseline, the group with morning surge had a higher prevalence of the past cerebral infarction, and during the follow-up, the incidence of new cerebral infarction was also high in morning surge group, and this remained after adjusting age or 24-hour blood pressure result and also typing pattern. And this another study which used also the ABPM to investigate the relationship between nocturnal hypertension and nighttime BP typing patterns with cardiovascular events, followed around 6,000 patients for on average 4 years. The results show that the nighttime systolic BP pressure was associated with an increased risk of atherosclerotic cardiovascular disease and heart failure. Now, another study is a meta-analysis examining the relationship between blood pressure variability and cardiovascular events. The study aimed to assess the association between long-term BP variability measured in the clinic and mid-term BP variability measured using ABPM and short-term variability measured with ABPM with cardiovascular outcome. it was found that all the long-term, mid-term, and short-term variability were all associated with poor outcomes. And the association between BP variability and poor outcomes were more consistent in the using ABPM and HBPM. In other words, blood pressure is not constant and varies from short-term to long-term. Considering this fact, OPIS measured BP as a snapshot of fluctuating BP is inadequate for the diagnosis and management of hypertension. Therefore, recent international guidelines for hypertension management recommend the assessment of out-of-office BP using ambulatory BP monitoring and home BP monitoring based on the evidence that out-of-office BP is a stronger predictor of cardiovascular events. So, out-of-office BP measurement is recommended for both confirming the diagnosis of hypertension and adjusting antihypertensive medication as class 1A or 1B. However, both HBPM and ABPM have limitations as well. Although ABPM and HBPM are recommended in guidelines, ABPM typically measures at short intervals ranging from 15 to 30 minutes, but it is limited to 24 hours, capturing day-night variability, but not daily or long-term changes. On the other hand, HBPM can capture daily and long-term changes, but is limited to being measured only at specific times, such as in the morning or evening. Blood pressure can vary depending on the season and differ throughout the 24-hour period and change frequently in response to even emotional stimuli. And even if the average blood pressure is same, there can be individual differences in the range of blood pressure fluctuations. The amount of time spent within the therapeutic range can vary even when the average blood pressure is the same. And there is also a growing recognition that the longer the time spent within the target range, the better prognosis. Therefore, the need for advancing blood pressure measurement method is increasingly shifting from the office BP to ABPM and HBPM, and now towards wearable BP monitors. Traditionally, methods for measuring blood pressure require a cup. Cupless wearable devices therefore require a different concept. The principles used in these devices include PPG, photoplethysmography, and BCG, ballistocardiography, and EBI, electrical bioimpedance, and electrical cardiography. Using these principles, there have been efforts to measure blood pressure by applying PPG and BCG and ECG through widely available devices like smartphone or wearable phones such as bracelets or rings. And to understand couplet devices, we first need to understand what is plethysmography. It is a combination of the words photo and plethysmography, where photo refers to the light and plethysmography refers to the measurement of blood volume, specifically the blood volume within tissues. Looking at the plethysmography first, the attempt to measure blood flow within tissues has been around for a long time. Efforts were made as far back as around 1950s to measure the volume of the upper and lower limbs. One approach involved measuring changes in volume within a sealed space with water or air, but however, this method was quite cumbersome. So there was effort, as shown this figure, to measure changes in the dimension of the limbs instead. And the following study used the plethysmography method mentioned earlier to measure volume pulse and then compared it with arterial pressure measured using an actual arterial catheter. The study found that the plethysmography measurement represent cumulative volume changes across all blood vessels, including aorta, small arteries, and arterioles and veins. But the arterial pulsation was the most significant factor. Additionally, when we look at this graph, we can see that in the large arteries, the changes in the tissue volumes closely resemble the changes in arterial pressure. And this cumbersome method has evolved into a simpler approach using light after many advancements. And the photoplethysmogram is a non-invasive circulatory signal related to the pulsatile volume of blood in tissue, and is displayed by many pulse oximeters and bedside monitors, along with the computed arterial oxygen saturation. The photoplethysmogram is similar in the appearance of arterial blood pressure waveform. So look at this study. This study measured digital volume pulse using plethysmography in a total 60 patients, 40 healthy and 20 hypertensive patients. At the same time, they measured the peripheral radial pulse and peripheral digital artery pulse using applanation tonometry and servo-controlled pressure cuff for comparison. So among the 20 healthy individuals, the results were also compared after nitroglycerin administration. This study found that in both healthy individuals and hypertensive patients, and as well as after NTG administration, the peripheral pulse closely resembled to the volume curve, which was measured by plethysmography. The PPG signal is a complex mixture of the blood flow in veins and arteries of the cardiovascular circulatory system. The PPG signal generally includes pulsatile and non-pulsatile blood volume. The pulsatile components of a PPG signal is related to the change of blood volume inside of arteries and is synchronous with the heartbeat. So PPG data, but it is a kind of qualitative information, and to use it for blood pressure measurement, a conversion process into a quantitative method is necessary. With the advancement of digital sensors, signal processing, machine learning algorithm, and improved physiologic models, pulse waveform analysis using plethysmography for the assessment of blood pressure has become more feasible. Then let's take a look at the various methods for the calculating or determining blood pressure using PPG data. The first one, it is using the simple plethysmography. In 2060, Edison found a single feature that is correlated with BP called STT, which is slope transient time, that requires only single PPG signal. The STT reflects the steep trend of rising pulse wave. It is a slope parameter calculated from the foot of the peak of the systolic waveform. And in 2018, Liang found that the BD area of APG is also associated with blood pressure. And another formula can be derived from the pulse transient time and pulse arrival time, which is measured by electrocardiography and photoplethysmography. Pulse arrival time is defined as the time taken from the pulse waveform to transfer from the heart to the distal side. And the pulse transient time is defined as the period from relatively proximal side to the distal side, like from the arm to the finger, or between the two distal sides. The pulse arrival time and the pulse transient time parameters are often used interchangeably. However, these propagation times are different. The PAT interval includes the PTT and the interval of PEP, which is pre-ejection period. That means that additional delay time between the electrical depolarization of the left ventricle, as indicated by the ECG QRS complex, and the start of the mechanical ventricular ejection. So, for measurement of PAT, the commonly utilized fiducial points are the R wave on the ECG and systolic peak of the PPG waveform, which is measured at the distal site. And for measurement of PTD, generally two arterial sites are used, such as PPG proximal systolic peak pressure waveform at measured of the upper arm and the distalic systolic peak of the PPG at the fingertip. The next one, we can use the TD, time difference, to measure blood pressure using ballistography and photoplethysmography. Ballistography is a long-established technique for evaluating the cardiovascular health of patients that record the vibration produced in the body during the cardiac cycle. Unlike the ECG, the BCG does not require skin contact and can easily estimate heartbeat information from patients, which makes it suitable for long-term monitoring and measurement. Each BCG beat consists mainly of the 5 waves, H, I, J, K, L, which were closely identified to represent heart activity information. The time difference between the predetermined BCG indicia, which is J peak of the BCG, and the systolic peak of the PPG correlate with the systolic and diastolic blood pressure. And this is the last one. We can use vascular transient time measured by the ponography and plethysmography to estimate the blood pressure. Heart sound associated with blood movement is recorded using the ponography instrument. Collected sound can provide information about the mechanical cardiac function and blood flow. The VTT is derived from the first heart sound of a PCG and the systolic peak of the corresponding PPG. So through these information, various formulas for calculating blood pressure have been developed, and there have been continuous efforts in this regard. And these various candidate formulas and data accumulate, and with the development of machine learning algorithm, blood pressure measurement using PPG is gradually becoming a reality. However, based on this reported sample size and limited validation attempts in its publication listed in this table, it is difficult to confidentially understand that accuracy of BP estimation attained using these PPG-based wearable devices. All studies except one use data collected solely from normal healthy individuals, and the sample size was very small for the majority of studies, which does not indicate reliable findings and robust analysis. In summary, blood pressure is not constant and varies from short-term and long-term. Recent international guidelines for hypertension management recommend the assessment of office BP using ambulatory BP monitoring and home BP monitoring based on the evidence that out-of-office BP is a stronger predictor of cardiovascular events than office BP. The need for advancing blood pressure measurement method is increasingly shifting from office BP to ABPM, HBPM, and now toward wearable BP monitors. Plethysmogram is an important concept in understanding couplet device. The plethysmogram is a non-invasive circulatory signal related to the pulsar type volume of blood in tissue and its similar appearance of arterial blood pressure waveform. However, a direct translation of pulse signal, which is associated for volume changes, into continuous BP is challenging because of confounding effects of cardiovascular, respiratory, and autonomic nervous system. Although their sensor hardware is very simple, significant work is still needed to achieve clinically acceptable performance. Thank you for your attention.
Thank you very much, Dr. Kim. I'd like to again introduce next a very interesting lecture titled ASCVD Risk Prediction Using AI, which is delivered by Dr. Shiok Kang. Shiok Kang is working in Seoul National University Bundang Hospital. He's actually an interventional cardiologist. Dr. Kang, please.
Thank you, Mr. Chairman. My topic today is atherosclerotic cardiovascular disease risk prediction using artificial intelligence. There have been a significant progress in this field, so I'm very happy to be able to present the recent updates of the study results. Cardiovascular risk prediction is evolving. From the beginning of Framingham risk score, 10 years ago there was pooled cohort equation, and last year American Heart Association published Prevent Score, a new scoring system. And also in Europe, score system has been updated. Q-Risk, also Q-Risk 1, 2, 3. And in Korea, there was Korea Risk Prediction Model in 2014. Prevent equations last year, which was published last year, there have been a little changes from pooled cohort equations. The major change was they included estimated glomerular filtration rate, which reflects the concept of cardiovascular kidney metabolic syndrome, and also added a couple of variables, including body mass index and social deprivation index, and also a couple of variables. These models basically based on linear regression models such as Cox proportional hazard models. Recent studies using machine learning or artificial intelligence have two approaches. One is model-centric approach, adopting new models, new machine learning models into the calculation. And second is data-centric approach, including more variables, not only 9 variables in pooled cohort equations. Prevent includes 14 variables, 11 essential variables, and 3 optional variables. And even Q-Risk 3 includes 22 variables. And thanks to machine learning development, we can process a lot more number of variables, like hundreds or thousands. So these kind of studies adopt gene informations or imaging studies, such as fundoscopy or cardiac CT or ECGs. And also some studies adopted electronic health records in their studies. So I have a couple of questions in my mind. First is, can machine learning improve cardiovascular risk prediction? And second is, which is more important, number of variables or model? And lastly, recently new models have been published, so I believe novel machine learning models can help improve this area. Actually, we published a paper a couple of years ago, 3 years ago. We looked at a 5-year ASCVD risk using National Health Insurance Service database. And we wanted to compare pre-existing cardiovascular risk prediction models, and secondly, develop machine learning-based models. We used neural net at the time. Compared to logistic regression, neural nets have multiple neurons. Logistic regression or Cox proportional hazard model have variables and wait for each variable and just sum all the products and put it into logistic calculation. Compared to logistic regression, neural network have multiple neurons and have different functions such as ReLU, and it can reflect interactions of multiple variables and calculate complex network of different variables. So first, conventional models. SCORE European model worked best in our study. Pooled cohort equation, C statistics was between 0.73 to 0.74, and SCORE was about 0.79. And calibration was best for pooled cohort equations. And for machine learning models, we compared pooled cohort equation as benchmark calculator. Pooled cohort equation for whites, AUC value was 포인터가 사라졌네요. 나왔다. 네. 제가 조작이 안 되는데. 네. Pooled cohort equation, AUC was 0.73, and machine learning models improved the performance, but the improvement was not very dramatic, I would say. Logistic regression, AUC was 0.794, and neural net was 0.751. There was an improvement, but the degree of improvement was about just 1%, and the difference between neural net and logistic regression was very minimal, was 0.002. This number of variables, 8 to 9 variables, and they are mostly binary. They are not numbers. Only age and cholesterol are numbers, and most relationships should be linear. So based on this study, we learned that logistic regression works very well. Although pooled cohort equation is not perfect for Korean population, but logistic regression, Cox proportional hazard model, linear regression models are very, they do a good job, and we do not necessarily require neural net for this kind of risk prediction. 마우스가 안 되는데요. Using Korea Heart study 10 years ago, researchers published a risk prediction model for Korean population. For example, this model used Cox proportional hazard model, and as shown here, we can calculate the risk by multiplying and adding multiple variables. And most models have different calculators for each sex, men and women. 다음 슬라이드요. Let me show you a couple of machine learning studies in this field. This study was done in Korea using National Health Insurance System, a service database. They analyzed 250,000 Korean individuals without cardiovascular disease and assessed 10-year cardiovascular risk. Compared to pooled left side, compared to pooled cohort equation, they used random forest model. Random forest model improved performance by 0.006, a little improvement for both men and women. And they also did analyzed the importance of each variable for men and women, and they learned that age is the most important variable for both sex, but other variables work differently for between sex. For men, cholesterol level and total cholesterol and LDL cholesterol level were most important, and for women, aging and abdominal obesity were shown to be important. This study from China, they did a similar analysis comparing pooled core equation and another calculator, PAR, and developed machine learning model. The performance of conventional model was about 0.78, and they did a couple of machine learning models, tested multiple machine learning models, and there was improvement. Neural net, AUC was 0.80, and GBM was 0.774. There was a little improvement, but again, the improvement by neural net was not remarkable, was just minimal. And they also showed that important variables, and age was the most important, and followed by systolic blood pressure and other ECG variables. Another study from the UK, not UK Biobank, they included 30 variables, including nine variables used in pooled cohort equations. They used other laboratory tests like liver function test and pulmonary function test, and other medication history and diagnosis, such as antipsychotics or oral glucocorticoids. They also showed, compared to pooled cohort equation, machine learning models improved the performance. And again, in this study, logistic regression, AUC was 0.76, and neural nets, AUC was 0.764. So neural nets improved performance compared to logistic regression by 0.004. An interesting study from UK Biobank. They analyzed more than 400,000 UK Biobank participants and developed a machine learning model, a very complex framework. Not only neural net, they did data imputation and feature processing and classifier, not only neural nets and multiple machine learning models. So the table on the right side, a little busy, but compared Framingham risk score model, AUC was 0.724, and Cox model, including all the variables in Biobank, there are hundreds of variables in this database. When all the variables are used, performance improved by 0.03, a significant improvement. But the last part, auto prognosis, this is the framework they developed. When they used only 7 core variables, the performance was 0.744, so the improvement was limited. But when using the same model, when the number of variables were increased, hundreds of variables, the improvement was more significant. So they concluded that information gain achieved by considering more risk factors in the model was significantly greater than the modeling gain. Using more variables is more important than using a better model, their conclusion was. The same slide. So answers to my initial questions: can machine learning improve ASCVD risk prediction? Yes, but improvement is not very significant compared to linear regression, logistic regression, or Cox proportional hazard models. Is model important or number of variables important? Both important, but looks like number of variables are more important than building a better machine learning models. But it is, I would have to underline that with increasing number of variables, we have to use machine learning. With hundreds of variables, machine learning works much better than only linear regression. And I'm interested in recent advances in machine learning models, so I would like to introduce two recent advances. One is Transformer, best known by ChatGPT. By training a model using general language models, we can do a better work in other downstream tasks. And the second is called Kolmogorov-Arnold network. BERT was the first generation of large language model, a precedent of ChatGPT. The researchers trained a model using BERT architecture on electronic health records from UK. They used CPRD database, which is a network of primary care physician electronic health records. So they recruited hundreds of thousands of electronic health records and basically trained a model on the database. And what they did was predicting the likelihood of more than 300 conditions in a subject's future. So an example of a patient. This patient made the first visit in his 37 years old and made other 8 visits. But when the first and fourth visit, there was no diagnosis, so they excluded the 2 visits from the analysis, and they only included subjects with valid 6 visits. So the data structure was shown in the left panel, and they trained the model using MLL prediction, masked language model, a representative, a famous method for self-supervised learning. And what they did in this study was prediction of subsequent disease prediction. So this is an example of a patient. In A, this patient had rheumatoid arthritis, and the text on the right side, rheumatoid arthritis was highly associated with menorrhage and polymenorrhea, and gastroesophageal reflux disease, and so on. So BERT is basically bidirectional and uses self-attention mechanism. So they showed using BERT, performance was improved for subsequent disease prediction. And they did a couple of other studies, transfer learning. They trained a model and used this model based on large language model. They did another jobs, transfer the learning of the model to other database and do another job. This study, the database was basically similar, CPRD, 1.1 million patients between 1985 and 2015. And they did cardiovascular disease risk prediction for heart failure, stroke, and coronary heart disease. Performance was improved compared to Framingham risk score or Q-risk-3. Other conventional risk scores on the right panel was between 0.88 to 0.89, but BERT AUC was above 0.95, significant improvement. And second, transfer learning using biobank. They analyzed more than 400,000 patients, and this is a very interesting paper. They learned a lot of lessons. The first was more information is important. Leveraging a more comprehensive medical history substantially improves model performance. So Q-risk-3 uses only diagnosis, but machine learning models improve the performance. But by using more variables such as socioeconomic status, measure laboratory results, behavioral results, environmental information, performance improves more significantly. And both model-centric and data-centric approaches are necessary to improve predict performance. Compared to linear regression, BERT did a better work using the same number of variables. And lastly, this graph shows performance by extracting each domain, by subtracting diagnosis using only other variables except diagnosis. The model degrades most significantly. So the conclusion is that diagnoses are more important, but other variables such as socioeconomic status also are important in predicting future cardiovascular risk. Korean study done by Bae in Korea. They did an interesting study. They used ChatGPT 4 and did a zero-shot test. They used UK Biobank and COGAS database and asked GPT what the patient's risk is. Using this prompt, they put the test results and risk factors and asked ChatGPT to calculate risk percentage. And for this particular patient, ChatGPT estimated the risk should be 0.84%. And ChatGPT performance was similar to pooled cohort equation. The improvement there, the performance was similar to conventional model, but this trial was zero-shot prompt. The model was not trained for this specific database, so I think there is much room for improvement in this area. The last is CAN, a little complex concept published this year. The advantage of this model is interpretability. It can explain how machine learning calculated the risk, and it reflects non-linear regression, non-linear relationship. So we are doing this work, not published, and we are doing preliminary. I'm showing preliminary data compared to logistic regression. Compared to a multi-layer perceptron conventional neural network, performance of CAN was shown to be improved a little. This is our preliminary results, so we're going to do further investigation, and I hope we'll be able to show you better results in the future. So this is my last slide. I believe novel machine learning models can help us understand future cardiovascular risk prediction. Thank you for your attention.
Thank you for your very informative lecture about the current status of AI in the field of cardiovascular disease. And now we have 4 excellent presentations and open for discussion. We invited 4 experts for active discussions. Bae from Yonsei University, Dong-Shin from Yonsei University, Seung-Chan Yu from Yonsei University, Hyung-Jun Ju from Korea University. Please.
My name is Bae, and Yongin Severance Hospital. I'd like to question about Akea Road, Nomura. Thank you for your wonderful lecture, and I'm very impressive about the digital therapeutics, about the CBT-based lifestyle modification application. So, but I have one question that, but this RCT model is compared to the control but the intervention arm is have many bias. It's more procedure and more concentration. So if we know the real impact of the digital therapeutics, then I think the double-blind RCT were needed. But I didn't see the double-blind RCT trials in the digital therapeutics. What do you think about how to overcome this bias?
Thank you very much for the great that's a really great point. So it's when we use the sham apple in terms of using this kind of the RCT, it might be reduce the bias of that kind of things. But at this time, to report the application, the patients know this app is for the effective one or not. So we couldn't do this kind of totally blinded RCT. So we need to think, so we need to think this as a limitation of the study. So, the one solution is to use the sham apple, yes.
I have a question to Dr. Conrad. I'm Dong-Hu Shin of San Francisco. Thank you for the wonderful lecture and congratulations to your amazing studies. I'm curious about the commercial models of digital therapeutics, especially cure of hypertension. Can patients buy the service by their own will, or only doctors can prescribe the application for their selected patient?
Yes.
And then the buying was one-time buying, or it can be subscribed to for some time. And what if the patient want to use longer the app? And what happened?
Yeah, thank you very much for a great question. So this time, we need to prescribe the DTX in the hospital by the doctors. Yeah, only for the doctors. So we can prescribe the DTX for up to 6 months. So that's the reimbursement period. So after finishing the 6 months program, we quit using the Apple, and Apple automatically shut down but there is another PHR Apple that can enter the blood pressure for the patient. So we switch the Apple to, and also the account and the data to another PHR Apple that was not included in the kind of the program, just for the PHR Apple. So we can use this Apple with the doctor's web application to check only for the BP for the long term. Yes.
So patient should pay only for the 6 months subscription period
for the program,
and for the program, and then free use to the monitoring use, right?
But after 6 months, yes.
Thank you.
The patient that do not pay for each feedback.
So after 6 months, the patient do not pay for.
Actually, I do have a short question to Dr. Nomura and the other to Dr. Kang after this. So, in your observational study, it was really, amazing. And after 6 months, 24 weeks, less than half patients remained in that data. Among the 1,000 patients, you had 400 patients. In your observational study. At the second study, you have only 40% of the patients at the 6 months follow-up period. After 6 months follow-up, only 400 patients remained in that study, in the data. So I think it's more than I expected, actually. But it's not optimal. So is it, within the acceptable range? How do you
thank you very much for, maybe you checked my manuscript, right? Yeah, no? No. Okay, so you mean that the engagement at 6 months is only the 40%, right?
Right.
Yes, thank you very much for that. So in this cohort, when I did my analysis, so some patients, the duration of some patients just not completed the total 24 weeks. So we did additional analysis to include only the patient with finishing over the 24 weeks. So so the number is really different about this one. So we need to check the engagement in the different analysis. So this one is not the true number of the upper engagement. It's not a similar,
Yeah, but it's more than I expected.
Yeah.
So, Okay, thanks.
Thank you.
I have another question to Dr. Kang. But is CVD risk prediction using AI? So, actually, I agree with his conclusion that usually deep learning model is not better than the conventional models, such as logistic regressions, if they use the tabular data with small predictors. But you are trying to use the Korkut-Arnold network CAN instead of the conventional, deep learning models. So could you please explain further about why you are going to use this and to show something, compared with the previous deep learning models?
Oh, CAN is a complex concept. What they are trying to do is they don't use a neuron using a linear regression. Instead of neuron, they use an edge, have non-linear function. So their model uses sine, cosine, log, etc. And they also do pruning. They cut unimportant connections. So the final model is much more simpler than conventional neural nets. So first is non-linear relationship they can reflect. Secondly, interpretability, explainability. One of the most disadvantages of machine learning is AI black box. So the paper of CAN, they showed that prediction can be better with small number of variables and show interpretability. So I think it is important, interesting.
Yeah, thanks for the explanation. Thanks.
I have a question to Professor Chun. I really enjoy your lectures, and you showed how to use ChatGPT for hypertension treatment, and your model is for cardiologist or patient. First question, and second question is I feel that the limitation of the ChatGPT is the ChatGPT cannot ask. Means that ChatGPT can only answer the questions, but in clinical practice we usually ask the question to the patients. For example, in your samples questions, if I were ChatGPT, I recheck the blood pressure first, or other whether the patient is a stressful condition or not. Usually we check their circumstances first. So in this kind of perspectives, do you believe that the patient can use those kind of large language model to self-care, or the healthcare provider should use those kind of large language model first?
Okay, thank you for the question. At first question, you mean the model is for clinician or for patients? So the model, I put the guideline for hypertension, and that these are for clinicians. So the model is for doctor. And if I want to make a model for patient, I put another document for patient education and something. So it's different goal. So this is first question. And second question is, yes, right. GPT cannot ask about the health information to patient, but we can make to ask the question, make question of GPT. For the customized GPT, we can make instruction. So I provide the algorithm of the questionnaire. So at first you ask ask blood pressure and ask the medication adherence and such an algorithm. So GPT can ask patient and get the answer. And what is second? What is third question?
Do you believe that the patient can use ChatGPT for self-care?
Okay, okay. Currently, it is impossible because OpenAI prevent to use such a customized GPT for medical use. So I cannot publish that GPTs for everyone. Just I use only me, or I give some link for others. So now it is impossible, and we need more advance about that to use self-care of patient. Thank you.
And now we've come to the end of this session, and I'd like to thank all speakers and discussants and audience. And before ending this session, we'd like to have time to express our appreciation to Professor Nomura, and we prepared appreciation plaque to Professor Akiro Nomura for his contribution to Korean Society of Hypertension.
Okay, plaque of appreciation, Professor Akihiro Nomura. In deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024, in conjunction with the 61st scientific meeting of the KSH. Thank you very much. Congratulations.
예, 안녕하십니까. 대한고려학회 총무이사 김광일입니다. 하이퍼텐션 서울 2024 제61회 추계 학술대에 참석해 주신 모든 분들께 감사드리며 특별히 끝까지 이 자리를 빛내주고 계신 모든 분들께 감사의 말씀드립니다. 지금부터 추계 학술대 보고 및 폐회식이 있겠습니다. 먼저 대한고혈압학회 신진호 이사장님의 인사 말씀이 있으시겠습니다. 박수로 환영 부탁드리겠습니다.
모든 이사장님께서 아마 이런 경험하셨을 것 같은데 저도 아마 이사장 맡아서 이제 첫 국제학술대회를 하게 되면서 굉장히 우리 학회에 계신 여러 교수님들의 어떤 역량이나 또 열정적인 어떤 그런 어떻게 보면 저한테는 큰 도움이 돼주시는 거거든요. 그런 거에 대해서 굉장히 깊은 감사의 마음을 느끼게 되는 것 같습니다. 그래서 이틀 동안 쉬지 않고 여기까지 달려와 주신 여러 교수님들께 다시 한번 감사의 말씀을 드립니다. 감사합니다.
예, 이사장님 감사드립니다. 다음으로 총무보고가 있겠습니다. 자리를 옮겨서 말씀드리도록 하겠습니다. 예, 추계학술대회 등록 현황입니다. 추계학술대회 2024년 11월 8일에서 9일까지 콘레드 호텔에서 개최됐습니다. 등록자는 국내 등록자가 580명, 그 다음에 외국에서 83분 등록 참석해 주셔서 총 663분이 참석을 해 주셨습니다. 본 학회의 메인 후원사 16개의 회사에서 본 학술대회를 후원을 해 주셨습니다. 이 자리를 빌어서 다시 한번 모든 후원사 분들께 감사의 말씀 드리겠습니다. 일반 후원사도 21개 후원사에서 부스와 광고로 이렇게 참여를 해 주셔서 감사의 말씀 드리겠습니다. 학회가 이제 그 4개의 방에서 나뉘어져서 이렇게 개최가 되다 보니까 한 방에 계시다 보면 이제 다른 방에서 있었던 이런 세션을 참석을 못 하셔서 많이 아쉬웠을 거라 생각됩니다. 그래서 이번 학회에서 발표됐던 내용들 그 온디맨드 VOD 서비스가 학회 후에 아마 준비 마치는 대로 오픈되고 아마 한 달 동안 여러 참석하신 분들이 보실 수 있도록 저희가 서비스를 제공 준비하고 있습니다. 그래서 곧 메일 확인하시고 보지 못했던 듣지 못했던 강의는 들으시면 될 것 같습니다. 다음 미팅 소개해 드리도록 하겠습니다. 2025년 춘계 학술대회는 5월 16일과 5월 17일에 걸쳐서 부산 백스코에서 예정되어 있습니다. 추계학술대회 하이퍼텐션 서울 2025는 2025년 11월 7일과 8일 이곳 서울 콘레드 호텔에서 예정되어 있어서 여러 선생님들 일정에 참고 부탁드리도록 하겠습니다. 86회 대한고혈압학회 개원이 및 전공의 연수 강좌가 12월 22일 일요일 날 오전 9시부터 오후 5시 30분까지 이곳 서울 콘레드 호텔에서 예정되어 있고 대한의사협회 6평점이 부여될 예정입니다. 고혈압과 관련된 여러 가지 좋은 강의가 준비되어 있어서 여러 선생님들 직접 또는 이제 전공의 선생님들께 소개해 주시면 좋을 것 같습니다. 또 저희가 이제 그 젊은 고혈압 연구자들을 대상으로 고혈압과 관련된 심도 깊은 집중 강의를 1박 2일에 걸쳐서 저희가 준비를 하고 있습니다. 그래서 올해 제3회 윈터스쿨이 2025년 1월 4일부터 5일까지 코트야드 메리어트 보타니 파크에서 예정되어 있습니다. 매년 개최되는 행사라서 이번에 놓치셨으면 다음 기회에 꼭 지원을 부탁드리겠습니다. 예, 오늘 그 심원규 임원이 이제 아침에 평의원에서 발표가 됐습니다. 차기 회장으로는 충남의대 정진옥 교수님께서 수고해 주시기로 했는데 오늘 좀 몸이 불편하셔서 참석을 못하셨고요. 차기 이사장은 영광스럽게도 제가 맡게 돼서 앞으로 열심히 하도록 하겠습니다. 추천해 주신 많은 분들께 감사드립니다. 예, 시상식인데 또 자리 옮겨서 진행토록 하겠습니다. 자, 시상식 진행토록 하겠습니다. 일반 연재 시상이고요. 전달은 이사장님께서 진행을 해주시겠습니다. 저 영 인베스티게이터 어워드와 클리니컬 리서치 어워드 시상을 하겠습니다. 영 인베스티게이터 어워드는 고려의대 이지은 교수님이십니다. 축하드립니다. 무대 위로 올라와 주시기 바랍니다. 영 인베스티게이터 어워드 고려의대 이지은 연구 제목 Current State of Use of Validated Home Blood Pressure Monitoring Device Among Korean Patients with Hypertension. 상기인의 논문은 Hypertension Seoul 2024 60일에 대한고혈압학회 추계 학술대회에서 발표한 영 인베스티게이터 어워드에서 우수한 연구과제로 선정되었기에 이 상장과 상금을 수여합니다. 2024년 11월 9일 대한고혈압학회 회장 이무영, 이사장 신진호. 축하드립니다. 네, 다음으로 클리니컬 리서치 어워드 1등은 연세의대 이찬주 선생님이십니다. 축하드립니다. 무대 위로 올라와 주시기 바랍니다. 클리니컬 리서치 어워드 이찬주 연세의대 연구 제목 An open-labeled randomized clinical trial of spironolactone versus amyloid for treatment of resistant hypertension SPARE trial. 상기인의 논문은 하이퍼텐션 서울 2024 제61회 대한고혈압학회 추계 학술대회에서 발표한 클리니컬 리서치 어워드에서 우수한 연구 과제로 선정되었기에 이 상장과 상금을 수여합니다. 2024년 11월 9일 대한고혈압학회 회장 이무영, 이사장 신진호. 네, 축하드립니다. 네, 두 분 같이 사진 촬영 있으시겠습니다. 네, 박수로 축하 부탁드리겠습니다. 베스트 포스터 프레젠테이션 시상은 슬라이드로 발표하겠습니다. 올해 수상자는 총 9명입니다. 인하의대 김대영 교수님, 한양의대 김병식 교수님, 서울시립대학교 김현욱 교수님, 한양의대 김현전 선생님, 가톨릭의대 김현현 선생님, 서울시립대학교 최세영 교수님, 고려의대 주영준 교수님, 서울대학교 최영환 선생님, 서울시립대학교 최태근 선생님. 수상하신 모든 분들 축하드립니다. 네. 다음으로는 대한고혈압학회 연구비 당선자 발표를 하겠습니다. 2024년 제21회 학술연구비 당선자는 총 5분이십니다. 연세 원주의대 강대용 교수님, 한양의대 나지현 선생님, 고려의대 나진우 교수님, 용강의대 의미 교수님, 충남의대 전병영 교수님이십니다. 예, 다음으로는 창립 30주년 기념 연구비고요. 당선자는 서울의대 이혜영 선생님입니다. 축하드립니다. 다음은 대망의 기다리시던 경품 추첨 시간입니다. 추첨에 앞서서 몇 가지 공지사항 안내드리겠습니다. 경품 수령은